Check, check. Check, check. 1, 2, 3, check, check.
यहाँ से कर लेगा ना. A pleasant and very good morning to everyone present here. On behalf of Caho, Consortium of Accredited Healthcare Organizations, and the Small Healthcare Organization Wing, Healthcare Division, and Nazareth Hospital, Shillong, it gives me an immense pleasure to welcome you all to this Jeevan 2026 Shillong. Jeevan is a flagship initiative dedicated to strengthening small and medium hospitals, empowering healthcare leaders with practical insights, quality frameworks, and real world solutions. We are very delighted to host you today at Nazareth Hospital, Shillong, and we look forward to a day of learning, collaboration, and meaningful dialogue. Caho is not for profit organization committed to improving healthcare quality across India through focused programs, training, and capacity building initiatives. Jivan is one such initiative designed by hospital leaders for hospital leaders. Nazareth Hospital is a non-profit, multi-specialty tertiary care hospital and has been a trusted name in healthcare, renowned for delivering quality medical services to the community. The hospital stands as a beacon of advanced healthcare, where patient well being and professional excellence go hand in hand. This program is organized by Caho, SHCO Wing, and Nazareth Hospital in collaboration with AHPI. So, ladies and gentlemen, without any more ado, we will now begin with the session one, focusing on critical foundation of hospital operations, the medical consents, and medico-legal case scenarios. To chair this session, we are honored to welcome the chairpersons. There will be two chairpersons for this session, Dr. G. Ringat and Dr. Anamika Mall. Dr. G. Ringat, sir, is a consultant surgeon and chief medical officer, Nazareth Hospital, Shillong. Sir has done his MBBS and MS General Surgery from CMC Vellore and has been trained in pediatric surgery, GI endoscopy, laparoscopic surgery. Sir has been the medical head of the hospital since 1990. And he published several publications in national and international journals and has been the guide to the DNB students. May I request Dr. Ringat, sir, to kindly take the place on the chair. Next is Dr. Anamika Mall. Madam is a consultant neonatologist and pediatrician, pediatric allergy specialist at Supercare Hospital, Shillong. Ma'am has got special interest in neonatal care in resource-limited settings. She is also the IAP Meghalaya editor since 2023-2024, IAP Meghalaya secretary 2018-2019. May I request Ma'am Anamika Mall to kindly take her seat. We will have two speakers in this session, Dr. Rebecca L.I. Kharsaithyang. She'll be handling patient consents and documentation. Ma'am is a consultant radiologist and medical superintendent at Bethany Hospital. She is experienced in diagnostic radiology, hospital administration, and healthcare systems development. Participate in institutional decision-making related to quality assurance, service expansion, and long-term capacity planning. Faculty in DNB program at Bethany Hospital, and special interest in fetal ultrasonography. May I request ma'am to kindly take her, she already took. May I request Dr. Rebecca L. Ice Karsnaitang to kindly come forward with the presentation. Can I?
Morning, everybody. Thank you. As chairperson of this session, may I take the opportunity to welcome all of you once more, even though on behalf of Nazareth Hospital, we have welcomed. Thank you so much. It's always a great pleasure to see a good number of delegates who come to any workshop or conference. And I'm sure that this will be a very useful time for all of you. I would like to welcome our faculty who have come from far and near, and also each one of you. Thank you so much for being here. And we now go into the first session, which is the medico-legal problems. This is one of the things which is very important for us. Many times I keep on saying this when we have our meetings, that sometimes I have to go to court for some cases which need some witness. And when I look at the file of some patient who has been seen about 10 years ago or 15 years ago, I have no idea what has happened. There's no documentation. There's nothing at all. And my face is fair like this, so it becomes red now when I go to court. It's very embarrassing for us and can be also very dangerous. So it's a very useful session. Thank you, Dr. Rebecca, for being with us.
Good morning.
Good morning.
Shall I start? Okay, so I'll just time myself. Good morning, everyone. I would first like to thank Dr. Pramod and everyone for giving me this opportunity to stand here. I'm not sure how much I can talk about this. In all honesty, when I got this topic, I thought, how much can there be to talk about? I'll finish it in 5 minutes. And as I went through the research, it became a rabbit hole. And now I feel like I'm watching a good movie, so much to say and yet so little time. So let's just start. Handling patient consent and documentation is extremely important because it has legal, ethical, and operational imperatives. Okay, so consent taking and medical document must function as a structured hospital system rather than just individual habits. So this is basically my talk. I'll keep elaborating. Meghalaya, I keep saying just Meghalaya alone. Our landscape is extremely varied. We have different types of patient. We have less. We have a number of hospitals, but I would still say we have a high turnover in many hospitals in which it causes a strain. We have mixed referral pathways. We have frequent medico-legal systems such as RTAs, assaults, poisoning, in all honesty, even sexual violence. You have workforce rotation, and you have you have people who are so trained, and I keep saying it really hurts when you have a very trained assistant and then she says, "Ma'am, I need to leave." It really feels like your partner is going, and it really hurts. So you have workforce rotation with variable medical legal training. Limited, when I say limited resources and manpower, what I'm trying to say is limited trained, specifically trained resources and manpower. You have lack of digital documentation system. When I say this, I would like you to understand at the current moment, right today in 2026, we are living in a spectrum between a population group which has no access to the digital system to the current AI system where miracles can happen. You can do anything. So this is actually the reality and the spectrum that's going on. And infrastructure and training gaps, we all have it. I think every hospital here do have some infrastructural limitations, be it building, be it rooms for specific trainings. We all have infrastructural limitations. When we say consent, we as caregivers, the reason we became caregivers was the intention to do good, the intention to treat. But I want everyone to understand today, sadly, intentions are not all. It cannot ensure a safe and defensible clinical practice. So you have to have a strong consent documentation system. It should be structured. It should almost be like the nervous system of your hospital. It should not be based on an individual habit. And every adverse outcomes always happen. We may have the best intention, and we feel so bad when suddenly you get a court paper saying so and so has put a litigation against you, because you think in your head, "Oh, I did my best." So I just want you to explain that adverse outcomes will always come. But it comes mainly due to a process failure. You cannot defend yourself if your process is not strong. So I don't really say it's not due to individual incompetence. Sometimes we tend to say individual incompetence. I think it's more of a process rather than an individual. I keep saying the evolution of medical records. When long ago, when there were physicians, they used to write little notes of paper to as reminders. It was almost like a post-it. Then slowly we realized that no, we need to have a structured record. So we developed into a structured record, and suddenly we realized, okay, structured records. We need to. It can be used as a defense. It can in the court. It can be formed in a form of litigation. So I can either it can reprimand you or it can defend you. So then we started calling it a legal medical record, and today we see that it has become a electronics record system where we have created digital. Uh, First of all, it is used as a memory aid. Then when it became a legal medical record, we found that it can be used as a evidence, as a finance, as well as a quality assurance. So your electronic record is nothing but creating your legal medical record into a electronic data. There are four functions of a legal medical record. One is communication. A good communication is, it's so imperative. I'll express this later. Then you have your legal, it can act as a legal evidence. I'm sorry if I'm going fast. I just want you all to just take little take home messages so that I think. And quality assurance is mainly to audit improvement and to create accountability. And you have the financial data. I'll be very honest, revenue generation is important. Why? Is because we cannot provide the services we wish to if there is no revenue generation. We can do more good if we have enough revenue generation, and this can help us by actually making us understand the demographic, the transparency of your billing system, and most important, when we deal with insurance, you can see the revenue integrity, the rejections, which can be a silent revenue leak. So core components of a legal medical record, you have a clinical documentation. When we talk about clinical documentation, it is mainly subjective to, mainly focus on patient care. So it captures the patient's condition. It is essential for decision making, collaboration between the multidisciplinary departments, then giving a good discharge summary. You have your OPD notes, ICU flow sheets, nursing notes. So these all come under your clinical documentation. Anything relating to the care and health of the patient comes under clinical documentation. Now, this is where there's another part where you have the administration and financial record. So here it tells us about your patient demographic. What kind of patients are coming to your hospital? You have your insurance and your billing code for your revenue integrity. Like I said, you have your admission, discharge, and the most important is your MLC registration and police intimation logs. Then comes your legal documentation, your informed consent, whether you have the care time, date, the clinical signature, your medical legal entries. And if so, when we were kids, I think everyone remembers used to write and then used to cut and used to write. As caregivers, we cannot do that. Please remember that any amendment has to be, you have to have the time, you have to have the date, and you have to justify why you have amended it. Okay, so it cannot just be a scratch and just write. Why documentation can be used as a strategic asset, right? You have the patient safety, you have the continuity of care, you have the legal protection, and you have your financial stability. These are basically the four dimensions which impact every hospital. Patient safety, like I said, again, it goes to so a document is not only to protect the hospital, it is also to protect the patient. So you have the accurate, timely records, you ensure the continuity of care. Then I always say this, to be honest, I was quoting this. Incomplete documentation, personally, I feel, is submitting an incomplete form demonstrates insufficient commitment, as it is more serious than just an unintentional oversight. So when it is a incomplete form, I personally feel like the commitment is a little more lacking than just a careless oversight. So I feel that is more grievous than uh, an incomplete form is more grievous. Then you have your legal protection. The medical record is often, like we said, manpower, attrition, people come, people go. Consider your legal documentation as your best friend who will be by your side for years. It is the only witness that can defend you even when there is no more physical people to defend your case. And you have your financial stability. Uh, like I said, generic documentation can result in insurance rejection, and that can be a silent revenue leak. Please remember, if it is not documented, it is legally presumed to have not been done. So I know that a lot of people say, but I did it, or I thought, I just want you to know, please document it. No information is trivial when it comes to healthcare. Right? Then okay, so there are 4C frameworks as a defensive documentation. It should be contemporaneous, it should be clear, it should be complete, and it should be consent-centered. Okay, so contemporaneous, you should document whatever happens in real time. Then it should be clear. When we were in MBBS, when I was small, I used to when I was young, I used to write patient doing well. because we had to fill 40 sheets. So we just write patient doing well, patient better. I would recommend doctors not to write that, or caregivers not to write that. Be specific. What do you mean by well? What do you mean by better? Do a comparative note. This is the SpO2, this is the BP. Make sure that it is complete. Every good point should be, every positive history should be supported by a negative history. So do not just write only what is positive. Enhance it with what is negative. So document both the positive as well as the negative finding and make it consent centered. Okay, consent second, record all discussions. Make sure that the patient understands. Also, when I say consent centered, this is not just for intervention. Let's just say you have a patient. He knows he's coming to end of life. He's staying in your hospital. You want to refer him out. You want to tell him that it would be better, if you go somewhere, because we may not have these services in the hospital. He says, no, I want to stay here. Make it sure that it is clear, it is documented, the patient is aware that these are the services that you are unable to provide. He understands the risk of staying back in the hospital. So it's not always just intervention only. I'm sure everyone knows this, but just a brush up. All medical records have to be retained for within 3 years. In case of any judicial litigation or any authoritative requirement, you have to know that you have to produce the document within 72 hours. And the most important is every patient has a right to their information. So you should be able to produce whatever information is required regarding their health immediately. Taking this into consideration, just a little note on referral system. I'll get into referral and LAMA later, but I just want you to know that in every referral system, a good referral system. So when we say referral system, it means we are taking the onus of the patient from the time of leaving the hospital to the time the patient is received and confirmed. So you have to have the reason for the referral. Clear note, treatment provided before the referral, the entire story, the patient condition at the time of the transfer, the investigation done and the results, okay, medication given including the doses and times, the accompanying personnel and the contact details, and receiving hospital name and the receiving doctor confirmation has to be there. Okay, please remember that a poorly documented referral system, you are liable for the events that occur at the receiving center or in the way. All right. So this is something about referral that we have to keep in mind. This changes a little in LAMA, which I will get into. So there are legal foundations of informed consent in India. Before we used to follow the IPC. In IPC, the article states that it protects the bodily integrity and personal autonomy. And you have the medical intervention without a valid consent might constitute battery, negligence, and deficiency. What has changed in 2023 is the shift from the IPC system to the BNS. Okay, so what has changed is before in the IPC, we used to say in case of death or in case of medical negligence, you can either be fined or imprisoned. The term was implied that most of them would be fined. Generally, we did not. Generally, imprisonment was not imposed. The shift with the BNS is that now it has almost implied that imprisonment is mandatory. So there's become a stricter law to it. Before we could get away with fine, not get away, but before we could be punished with fine or with imprisonment, now it's become fine and almost mandatory for imprisonment. So it replaces the IPC section. Another thing, please remember that as healthcare givers, we are giving a service. It comes under the Consumer Protection Act. So we are still liable also for penalization under the Consumer Act. I keep saying what was the landmark to all of this? The landmark case was Samira Kohli versus Dr. Prama Manchanda. So basically what it stated out here is, one, we cannot have a blanket consent. Okay, you cannot have, and a doctor must disclose the nature and the procedure, the purpose, the alternatives, the material and the risk, and the consequence of the refusal. Okay, so for a consent for one procedure does not authorize that you can do another procedure, unless, again, here is the exception, unless it is life-saving or it is imperative, then you can, but it should be clearly documented why. Okay, so Capacity and so the components of a valid consent is capacity and voluntariness, adequate information, the communication, and the traceable documents. Okay. I was having this conversation with my friend. She practices in the UK, and I was telling her, oh, what is consent? I have to talk on this. So she was saying capacity evaluation is imperative. Please understand, patient consent is paramount. Um, I realized that in my hospital, we practice where when the patient comes, he's in pain and all of that, and we take it for granted that we ask the attendants nearby, sign the consent for admission, sign the consent for this. I did not realize till I went into this rabbit hole that if a patient has the capacity, irrespective of his state, it is paramount that he signs the consent. All right. So let us just look. I'll just give you a quick thing about capacity, how to evaluate capacity. So evaluation of capacity is basically in the UK, you have a functional test. Okay, is the patient, it's a two-step system actually, but actually I'll just go to the functional test. One, is the patient able to understand? Is he able to retain the information that he is getting? Is he able to weigh the consequences? And is he able to communicate? Can they communicate their decision? Now, a lot of people say, oh, he's unable to communicate because, he maybe there may be some difficulty, but communication will also include even a simple muscle movement like eye blinking and squeezing of hand, as long as he is able to understand. All right. So you have to have the capacity and the voluntariness. The patient has to voluntarily give the consent. If you find that the voluntary if the capacity or if it's being influenced, you have to document it. Okay, you have to give the patient adequate information, and you have to have, if you're using an interpreter, language is so important, especially in a place like Meghalaya. Within Meghalaya, we have Khasi, Jaintia, Garo, you have Hindi speaking, and you have English. Within that, you have multiple dialects. Then you have your neighboring states which have multiple dialects. It is easy for people to say have a multilingual consent form. Yes, I agree, it is important, but I also want to state that it is extreme, more than a multilingual form, it is extremely important that the people understand what they're being communicated. Okay, so you have basically, like I said, I'll just go quickly. Common consent failures and risk mitigation is basically an incomplete consent form. You have your language mismatch. When I say language mismatch, I'll give you an example. I had a patient and I wanted to ask the patient, why did you have a surgery? He had a proper surgical site. So I speak Khasi, but at that time my Khasi wasn't very good, so I said belly fi plek po, and he didn't understand. He said, "Nga klem plek po," means I didn't open my stomach. And I'm saying, "Eh, belly fi plek po, your scar is there." What I wanted to say is belly fi po kak po. What I'm trying to say is, it is very important that it is not just the language, but it is the person's. You're saying it clearly, correctly, and the patient is able to understand that information. You have your doctors have the worst handwriting. I don't believe that, but majority of us do. Please understand that an illegible form is taken as a non-existent form. So try, I won't say improve, but if you have a bad handwriting, I mean, no judgment, try and make it in block letter, which is legible. As please, most times consent is taken by nurses or is taken by junior doctors. It has clearly been written according to the law that a consent has to be taken by someone who has adequate information of the procedure. So the patient should be able to ask any and every question, and the person should be able to reply or give the answer. Okay, so you have absent witness signature. If you're going to take a thumbprint, if you're going to have a witness, please make sure that the person is, is written. And you have your wrong procedure recorded. I'll give you a simple example. We had a pleural tapping. Doctor, the consultant, just by chance, had turned the film, so he wrote right pleural tapping, but the pleural effusion was on the left side. So uh, this is something that we face a lot. When the error is done, we always say, I thought, ngamut, I thought this is supposed. I would recommend, I always say this to everyone, and uh, if you think, confirm. It just takes 5 seconds. But confirm that whatever procedures, even a double confirmation, no problem. Just confirm whatever procedure is to be done is correctly with your consultants, with your seniors, and always at least get two opinions. It helps than a single one. And you have your lama. So lama is another whole thing which I'll get into, but it is basically make sure that it is all the risks in case of lama. For LAMA, which is leave against medical advice, please remember your care. You just because the patient takes LAMA does not mean your care ends there. Your care ends till the patient leaves the premises. But till the patient is there in the premises, just because he's taken LAMA and he's waiting does not mean that your care ends there. Okay, so every failure above has every one fix. Okay, but I always say the cure to every fix is training. Um, I was talking to my supervisor, the nursing supervisor that day, and I told her, is excessive documentation causing a lack of empathy? And she said something. She said, it's something you cannot help, but what we can do is we can train. So I spoke to my friend, and she said, you have to train your staff to a point where it becomes as easy as breathing. Like, I think in all of our fields, whether we are radiologists or surgeons or pediatricians, the first time we had to learn something, it was really difficult. Today we may have a bomb blast going on in the back of our head, but we can still function and know the diagnosis, and we can still treat our patient. So training, I keep saying, is literally the answer to everything. Like we all know, I won't go into this, but Mental Health Act and both HIV, every patient, please remember that they have a right to confidentiality. And breach of this confidentiality is punishable by the court. In HIV, please remember that every testing you have to take a consent. There has to be a pre-testing and a post-testing counseling. We tend to take it for granted that they are aware, but it is extremely important that we follow these consent rules. Challenges made, especially in small hospitals, I feel is, I keep saying when I say limited manpower, I want to emphasize what I'm trying to say is limited trained manpower. It is very difficult. First of all, like I say, you train, and then when they leave, it really breaks your heart. So limited manpower is there. Then after that, yeah, no digital systems does not mean no digital systems. It just means that we have a spectrum of certain healthcare places, especially in Meghalaya, where the electronic system may not be as advanced as it is, say, in a more metropolitan city. But the I keep saying this, the challenge we face, this is the challenge we face, and there is a remedy to it. It just will take a little time and a lot of resources, but it's not an absolutely impossible. The idea is basically to create data into a easy, accessible, traceable learning data in which we can create systems. Every problem a system can be created, and in that system where you can train, and every problem can be solved. It will take time, it will take resources, but it's not an absolute impossible task. You have training gaps, infrastructural constraints that we all know. I think every hospital in Shillong is going through infrastructural constraints. Medico-legal vulnerability, I'll be very honest, even with my medical officers till today, the training, we still have mistakes with our MLC documentation. We've been training, we have workshops, but like I say, to err is human. And you have your resource limitation. We always say we want an Audi at a rate of a Maruti 800. So everything always has budget constraints. So every time we have to have low cost, everything is low cost, but we want efficiency. I think we just need to crack a balance between these two. Now, practical solutions, challenges, manpower shortage. Uh, I learned this after this, and it really helped. We created documentation champions. Get your staff involved with the doctors. Create one documentation champion for 1 month. Nurses create one documentation champion. Let them go through the papers, see what are the errors in the documentation. Reward whoever catches, make it fun, make it competitive. It really helps. Then if you have no digital system, just create one standardized, just take one case per day, just one standardized template. Keep working, it'll come. Training gaps, I understand training gaps is a big issue, but even if you just have a 15-minute training gap, it will work. um, if you don't have a consent room, make sure that at least there's a private space for consent room where they can be exchanged. I keep saying consent documentation, these are conversations. Don't look at it as a paperwork, don't look at it as an errand. It is just a conversation you are having with a good friend who you want to explain your ideas to. That's it. Then you have language barrier. Like I said, language barrier is, you understood my experience. So language barrier, take a translator if required. Document who's translating. Make sure that the person is able to understand the gravity of the information that's given to him. And in MLC documentation gap, we can create all the training, we can create every form, but in the end of the day, yes, training is there, but I keep saying it should come naturally. It should be done over and over, where it becomes a habit. It becomes, I keep saying, training is basically a basis for a cultural foundation. That's it. Then you have, okay, so you have consent audit. I just have 4 minutes, so I'll just go quickly. Documentation pathway, you have the admission, you have consent, you have clinical procedures, you have the discharge, MLC, and you have to take up the sensitive cases. So this is basically the flowchart that you can follow. Okay. So key takeaway, documentation is a patient safety system. You have a 4C framework. You have the audit problems. Find audit and find your issues before the court does. Consent is a process, not a signature. Small hospitals can implement strong system. I really am very passionate about creating systems. I feel every problem can be solved with creation of system. You just need to brainstorm, and I love forums like this in which we can brainstorm and create systems. Culture is a goal, policy is just a start. Like I said, policy formation is just it's just a cultural creation. So now, I got a question from one of my doctors. She said, what happens when a patient is brought unconscious and found on the middle of the road and he has no attendant with him? What do we do? Can we do the procedure or no? And so I went into this and I realized, yes, you can. The legal framework clearly says every patient has a right to life. Okay, so the doctrine of implied consent means when a patient is unconscious, unable to provide consent, and there's no one who's legally authorized, no signature is legally required before clinical intervention in a true life threatening emergency. So you can proceed with the procedure immediately. You have to have a meticulous documentation to protect you, and you can have an administrative proxy, meaning it would be your medical superintendent, your CMO, your head of hospital who would sign. But this is mainly to safeguard yourself. This does not imply that if you do not get this signature, you cannot do the procedure. This is something you should be aware. So you have a SOP. Basically, you have to assess if the patient, if it is a life-threatening condition and the intervention would save him, do it. Proceed without waiting for consent. And after you stabilize, document the timeline, arrival, decision, surgery start. Proxy signatures only for record keeping. It must never delay the treatment. Now, second question I got was, ma'am, but if it's, ma'am, the patient is unconscious, but the wife could give the consent. But what do we do about this property and bank issue then? Do we have a solution to that? Because we've had cases where, they've asked us for the signature. Please understand that in intervention, we are saving life. But we cannot be culpable in abetting any form of property disputes or any form of financial transaction. That is imperative to understand. For this condition, the court can, either the patient can have a power of attorney given, or the court can appoint a legal guardianship. Okay, and then I just want to go to one more thing is quickly is just the I just have few seconds left. Yes, two things we should be aware of is passive euthanasia. I think it's a topic that is going on around, especially in today right now. Is passive euthanasia accepted or no? Yes, passive euthanasia is accepted. Okay, and in this passive euthanasia, you have two types. You have a living will, which is given and by the living person, and it is created by a two-tier board system. So in places like Shillong, before it used to say that for this board system, you have to have a 20 years experience. We have come down to a 5-year experience. So the primary board system can be formed in hospitals like Shillong, and you have the secondary board, which is an independent board. All right. So you have passive euthanasia, which is allowed, which is taken by both the primary board and the secondary board, and you have the advanced medical. You have the living
May I
will.
request you
Yeah.
to please close?
Okay. So I think I'm done, and I just want to end with a defensible healthcare system is built not only on clinical expertise but a reliable process. So if anyone has
I'm afraid we can't afford
Oh,
time for questions right now, but maybe afterwards if there's
yeah,
time.
sure. All right.
We'll have question after the second session. Thank
Okay,
you,
all
ma'am,
right.
for your
Thank you
crisp
so much.
presentation. Thank you.
Thank you.
Thank you so much, ma'am, for that insightful presentation. Now we will have our next speaker, Dr. Babu Narayan, sir. He will be talking on real-life medico-legal case studies. Sir has 25 years of experience in clinical practice and healthcare leadership, clinical expertise in general medicine, diabetology, ICU, toxicology, HIV medicine, emergency medicine, and Parkinson's care. He has experienced 20 years in medical administration, hospital operations, workflow optimization, and service delivery improvement. He is strong advocate of medical law, ethics, and quality management, actively driving patient safety, governance, and continuous quality improvement. I would like to welcome Dr. Babu Narayan, sir, to kindly come forward.
Good morning. Yeah. So thank you, Nasrat, for hosting us, the small healthcare organization being Jeevan program. So my good friend, Dr. Pramod was telling, I have a time slot of 20 minutes to complete. So I think it will be a happiest news for you because these sessions are very boring. This law, these are driest. Quality is the driest subject, right? Clinical practice, it is interesting, something actionable. We sit and talk about quality law. It is a very good medicine for sleeping. Okay, so it is a very important thing. So it is not such a invigorating or otherwise alluring, very attractive topic to speak about law. How many doctors? Any show of hands? How many doctors? Oh, good. Thank you. Nurses, nursing professionals. Wow. Yeah, they are the what to say, building blocks, or they are the pillars of healthcare system. Always they, I mean, they are very advanced than doctors. I would always say in my all my clinical practice as an intensivist, wherever I have done anything great, something for the patient in outcome, I would say that it is because of the nurse, not because of me. Because whenever I am intubating, when I am trying to resuscitate a patient, when I put a central line, all those kind of chaos, the intelligent and the so experienced nurses gives me a lot of inputs to save the patient rather than me out of my clinical expertise. So coming to the topic of today, maybe the next 15 minutes or so, I mean, legal aspect is, I mean, it is a one-day topic or it is a two-day topic or it is a course per se. when we come to medical legality. And 15 minutes is a very shorter time, but I will try to implant certain aspects which you could think of, you can ruminate, you can think of when we go back, right? See, with every session, if you take some 3 or 4 points back home, that is valid. 10 sessions, 40 points, right? In all my MBBS, when I was doing my biochemistry, I had 100 classes. If you ask me what I studied out of it, is that um, heated blood agar is called as chocolate agar. Okay, everything went above my head. I know the classes are very sleepy. Fine. So what we are going to do in the next few minutes or so, look certain aspects of what is this medical legality and how, as a hospital, we can protect ourselves. The consent and documentation, as Madam Rebecca was telling, is a very important component of everything, right? When this consent and your documentation is not good, then yeah, we go to our court, right? Fine. So in that case, one of the things which Madam was referring to is that a patient is brought down by an unconscious, unknown patient. Who will be giving the consent? Any idea? Who will be giving the consent? Somebody has to give consent to do something on this patient, right? Now, without consent, a casualty medical officer cannot do anything without getting a consent. Who will give the consent? Anything? Guess? Yeah, very nice, sister. So sisters are always, so they know everything. So the medical director, medical superintendent gives the consent. He is the person who gives a consent. So somebody has to give a consent. If a child is brought, who will be giving a consent? Parents are not reachable. The school principal. So that is an important thing you have to do. What are the principles whenever we look into a medical legal cases? What are the principles laid down by this court? One is called as, whenever they look into the case, they will see standard of care. Whether a standard of care has been given. There is a duty of care. As a doctor, I have a duty to do a care. So they will see that this doctor have done his duty. Informed consent. For doing the duty, he has done his duty. But has he got his consent? Madam was speaking a lot about it. Then fourth is res ipsa loquitur, which means that this thing speaks for itself. If there is a dead body, which means that somebody has died, right? It speaks for it. Nothing. Nobody has to come and say that, hey, dead body is lying there. There is something which happened, right? Res ipsa loquitur. So these are the various things. So what do you mean that the fact speaks for itself? That is what they look into. Looking into the bolum, 2 minutes of about bolum. This bolum guy had this thing. He had a psychiatric illness, went to the doctor. Doctor thought that, okay, I have to give him electroconvulsive therapy, ECT. There were two things which were present, ECT with muscle relaxant, ECT without muscle relaxant. Both the things are okay. This doctor chose that ECT without muscle relaxant, gave ECT. He had a convulsion, lot of bones break, including his acetabulum. Now he went to the court and said that, come on, I went for a psychiatric treatment. This doctor gave me an ECT without a muscle relaxant. So I had an acetabulum fracture. This doctor has to be sued, right? Now it comes. So this is a very important thing because all our medical negligence is based on this basic concept of Boehm's law or Boehm's test, which says that if there are two ways of management, because there are two types of management, one with muscle relaxant, another without muscle relaxant, and a doctor chooses to do one course of treatment, then he is not liable, right? So that is an important thing. So there can be umpteen number of treatment. A patient cannot come and say that you have to do only A. The doctor decide ABC, provided if the ABC treatment is being accepted by the community, the medical societies, right? So that is one thing. Second is that, for example, now people come and say that, oh, for this patient, there is like a patient comes in for this thing, went into for arrest. We were trying to resuscitate, not at all resuscitation. Now the patient go and file a case. See, if they have put ECMO, then my patient would have this thing. Then a defense lawyer will say, see, ECMO can save a patient. So do you mean that? No. Court or the law doesn't say that you have to do the best treatment. Neither you shouldn't do the worst treatment. You should have a reasonable treatment. So that is called as reasonable. So there is no compulsion for a doctor, for a hospital to do the best treatment. If I'm doing a clinic, I'm having a clinic and somebody rushes in and they are in the verge of collapse. I'm trying to do whatever is within my capacity, right? So it is a reasonable treatment. So this is an important thing on which all laws exist. So what this, like whenever something happens, what is a step? What is a step? What is a step to prove that there is a medical negligence? One is establish the duty of care. I took this patient and this doctor had a duty of care. Establish a duty of breach of duty. He had a duty of care. There is a breach. He didn't do it. Commission or omission. He did wrong or otherwise he didn't do anything. Establish due to that the patient had this thing, right? Causation. Then we need compensation. So this is how any kind of medical negligence goes. Okay, on what thing they will be looking into? Either Consumer Protection Act, that is the worst thing to happen for medical profession in the last decade, but however, we are liable in it. Now we come under the Consumer Protection Act. Civil court, that is called as law of torts. Torts are, let's say, nothing but is about negligence, right? You do something, you do not do something, then due to that something happens, then you are liable for compensation. That is nothing but tort law. It is a civil law. Criminal complaint. Sometimes they can go in for a criminal complaint. Now, what is this? There was an ruling from the judgment that cannot be taken into the criminal act, right? Because what is the outcome of criminal act? It is an imprisonment, right? So we cannot have that. It can be a fine or it can be an imprisonment. When it goes to a criminal act, 99.99% it is going to be a imprisonment, right? So now we are in the phase of danger that everything is being processed under the criminal act. Then medical counsel. So these are the few things under which a legal proceedings can happen. So this is a very important thing, okay? We were speaking about the consent. So this is one law. I will be saying 2 or 3 judgments which change the course of our legality in India. One is this Samira Kohli versus Dr. Prabha Machanta. She's a 44-year-old unmarried woman with endometriosis or maybe a bleeding, DUB, dysfunctional urethral bleeding. Went to the doctor. Doctor told that diagnostic and operative laparotomy may be needed. The doctor went in, found that the bleeding couldn't be controlled, took away the uterus, took away the salpinx and your ovary. Now, she goes and files that, see, I'm unmarried. This doctor has removed everything and how I cannot become a mother. I cannot give the prospectus of a marriage. So, I'm suing him. Is it right or wrong? The doctor with the right intention, he did everything, he removed it, but the consent for it was not got. Because it was in the operation theater, how to wake up the patient to get a consent. They went, the doctor's assistant went out, mother was there, told them, got the consent and did. Right or wrong? Okay. So that is very, very important that whatever may be the thing, without consent, we cannot proceed. What would the best thing would have happened? Because it is not a life-saving, except for a life-saving procedure. But even otherwise, you have to prove the life-saving procedures. Always the dagger will be just up in your head. Okay? It's better. It's better, right? Whatever with the good Samaritan you do, the fate decides what you are, right? Fine. So what it means is that is an important part of consent. If it is not consented, never do it. That's all. Simple as that. So the doctor was found guilty. We should understand. Second comes this Indian Medical Association versus VP Shanta, right? This is a very important thing which happened in the legal history, wherein the doctors, the hospital, everything came under the Consumer Protection Act, right? Fine. So here, what is that? The VP Shanta is a resident of Bangalore, advised to undergo coronary surgery, and she went to the hospital, did the surgery, and out of complication, she died. Now, the question there was, does it come under the Consumer Protection Act? Previously, all these cases were not processed under Consumer Protection Act. But however, the Supreme Court ruled that a doctor and patient relationship comes under contract. And if you have charged something from the patient, right, as a private hospital, then he is a consumer and you are the service provider. So you are bound by the Consumer Law or Consumer Protection Act. So now the medical profession comes under the Consumer Protection Act. So what is the outcome of it? Because now they can go to the consumer court and they can file for liabilities and by compensation, which can run into crores. So this case changed the history of medical negligence in India, under which it comes under the Consumer Protection Act. Can the government be implicated into it? Yes. If the government hospital charges any charge to any of the patient for something. Sometimes the government does all free of charges. They will be having a CT facility. There they will say that I will give you a subsidized rate. In Tamil Nadu, it is like that. For example, for a subsidy, 300, 400 rupees, they will be doing the CT facilities, right? If we are going to charge for one services, then the entire gamut of your service comes under this thing. So we should know that important fact. This is another thing which madam spoke about, your euthanasia. Very important aspect, okay? In India, euthanasia is illegal, right? There is something called as active euthanasia, then there is something called as passive euthanasia. Active euthanasia consists of three things: voluntary, trying to give some drugs and kill a patient, or we would say that assist in the euthanasia. That is called as, in certain countries it is acceptable, in certain things. Do you know it is acceptable? I can go to that country and I can say that I wanted to die and I can ask the doctor for a prescription and they will give and I can peacefully die. That is called as active euthanasia. Voluntary euthanasia. In non-voluntary and involuntary. Non-voluntary, not mentally competent patient, somebody decides to, okay, he's not mentally competent, he's not useful to the society, how can I go with this? He has a cerebral palsy, I cannot take care of him, let us do euthanasia. Involuntary, decision made without the consent. Patient is under some sedation or this thing, we are making a consent to do it. All these things are illegal, right? Now the question arises, can we withdraw or withhold? Because comfort care, right? Withdrawal of support. Withdrawal of support is not permitted in India legally. However, what we can do, if we think that it is pertinent, then we have to constitute a committee. The committee has to say that it is okay. Then they will go to court and the court has to give the order. So now there is a provision which is available due to this Shambok case. Previously, that wasn't even available. So now a provision is available. Let us say that a vegetative patient, 5 years, 6 years into ventilator, there is no hope of recovery. The medical bill cannot be borne either by the hospital or by the government or by the patient, right? Then we can have some kind of remedy which is available. Another important thing is that, does this bites come under the medico-legal? Yes. There are few things because it comes under Wildlife Protection Act. Victim compensation schemes are available, manner of death, and in some states it's a notifiable disease. So that only whenever a bite, snake bite, scorpion skin comes, you have to put it as an MLC. Because sometimes people will try to kill their kith and kin through this snake bite as well. Okay? Because it is also one way of homicide. Murder and other things can happen through this. So all the bites, for example, especially snake bites, comes under medico-legal case. And there will be a compensation as well. Coming to the last aspect of it, death certificate. Can I issue a death certificate for an witness? Witness to be brought to the hospital, dies in the hospital, 4 form, right? Dies in the home, witnessed by a doctor, 4A. If both the things are not happening, then there is a little bit of difficulty in getting it, wherein you have to tell to the police, they come and see Panchagama facilities available. Witnesses will be saying they will be coming to the birth and register or your Tahsildar, and the Tahsildar will issue a form to certifying that death certificate. Okay, so these are the few things. So fine. With this thing, what we can have a safe care model. One is standardized forms, consents, and checklist. Have those things, simple things. These doesn't need technology. These doesn't need any kind of money. These doesn't give any kind of capex investment. Audit documents monthly. That is very important. Whether you are documenting, consent form is very, very important. Family communication, which is structured. Escalation protocol. If deterioration is happening, are we keeping the patient in loop? Then consent culture. For everything, document and get the consent, whether it is relative, known, had been your patient for say 20 years, 30 years, had been your patient in Purva Janma also, no problem. Get the consent, okay? Or otherwise you are liable. Account through logs and registers. Maintain it. Referral early and documented. If you cannot manage in your facility, please refer. Evidence preservation. Please have all those records, samples, and reports. What hospitals can implement immediately, because due to time limitedness, I'm just rushing through it. Medical-legal readiness, right? We will be doing a mock drill for everything. Are we doing a mock drill for a medical-legal this thing? What has to be done whenever a medical-legal things comes in? Because we go into a panicky mode, right? So this can be prevented by having some kind of process in it. We can have a 24 hours escalation chains and train front office staffs to handle it and maintain a medico-legal file, because this is a documentation of what has happened to us. Summary. We would say that, to summarize whatever we have studied, small and medium hospital don't need expensive system. They need some processes in place. Medico-legal safety is not fear-driven. It's process-driven or it's a quality-driven. Every case teaches us something. We have to learn from something. When we strengthen our system, we protect our patient, right? And the important aspect when it goes for court is that only two things. One is consent. If at all you are going to lose, consent and documentation. I will stop by saying this thing. There are two theories. One is you are prudent patient, another is prudent doctor. Prudent patient, your system, we have to tell everything to the patient. Your death, this thing is 10%, your CVA is 5%, you can have these kind of, that is prudent patient. The patient will decide, I wanted to undergo this surgery or not, okay? Prudent doctor, that is the US or a UK system, it is British system, which we follow. We are a prudent doctor. Why do you say that? Doctor thinks, a patriarchal kind of thing, right? Okay, I shouldn't frighten him a lot. I would say that, sir, Baba, these are the complications. These are the top 5 complications, top 3 complications. But 99% of the people come out very well. Okay, there are two things. We follow the British system. Whatever the system follow, you have a consent form and document it. Thank you very much. I think you can take these 3 or 4 points from here, and take home message would be consent and documentation. Thank you for your patient listen.
Good morning, everyone. So due to the paucity of time, we are avoiding the question and answer sessions for now, because we will move ahead with our inauguration program. Okay, Riginti, over to you.
Thank you so much, Dr. Babu Narayan, sir, for that insightful presentation. Now we will move forward to with the inauguration. Ladies and gentlemen, it is now time for the formal inauguration of Caho Jeevan 2026, a healthcare excellence program for small and medium hospitals. Before we begin with the program, I would like to play the Caho anthem first.
Sound is there only. Sound is not coming. Sound is not coming. Here it is not coming. A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety, setting up standards with best foot forward. Won't ever leave no stone unturned. We wear our pride on our sleeves, walk with passion like a breeze, training people, enhancing their skills, spreading the message of quality health care for safer patient care, a better nation. We have a goal, a noble drive. Hand in hand, step by step, we will thrive. To march ahead together, a bright and shiny future with patient safety and quality health care. We are AHO, your healthcare companion, standing right by your side.
I now request our invitees to the dais. First, our chief guest of this morning, Srimati R.M. Kurba, DC East Khas Hills District, to kindly come forward, and she will be escorted by Sister Noreen, our administrator and organizing chairperson, Jeevan program. I request Sister Noreen, our administrator, to felicitate our DC, Srimati R.M. Kurba. Next, I like to request our guest of honor of this today's program, Dr. R. Pottsnam, Deputy Director, Health Services, DHS Shillong, to be escorted by Dr. Ringat. I request Dr. G. Ringat, Chief Medical Officer of Nazareth Hospital, to kindly felicitate Sir Dr. R. Pasnam. May I now request another guest of honor of this program, Dr. Babu Narayan, Caho SHCO Chairperson, Chief Business Officer and Health Quality, GEM Hospital. He will be escorted by Dr. Pramod Paharia. And Dr. Pramod Paharia will felicitate Dr. Babu Narayan. May I now request Sister Sharon to kindly come forward and felicitate our administrator, Sister Noreen, Dr. Ringat Sir, and Dr. Pramod Sir. Thank you so much, Sister Sharon, for doing the honor. Now we'll move to the lamp lighting ceremony. I invite all the guests in the dais to kindly come forward to light the lamp. I also invite Dr. Jeet Patwari, the zonal chairperson Caho, to kindly come forward and light the lamp along with the dignitaries. Lamp lighting is a ceremony where we used to do before the beginning of any program. It symbolizes light over darkness, knowledge over ignorance. Thank you so much, dignitaries, and also Dr. Jeet Patwari. Now we will welcome the choir from Nazareth Hospital to kindly present us with the welcome song.
light in the house, let it shine every day. Let it shine every day. Welcome, welcome, welcome with a grateful heart. Welcome, welcome, welcome with a grateful heart. Come and join us. Come and be the flood of glory. Come and see this beautiful day. It's a place of love, it's a place for you and me. It's a place of love, it's a place of hope, it's a place for you and me. Welcome, welcome, welcome with a grateful heart. Welcome, welcome, welcome with a grateful heart. Come and join us. Come and be the part of glory. Come and see this beautiful day. Come and see this beautiful day.
Thank you so much, sisters, for that melodious song. Now, I request Dr. G. Ringat, sir, the organizing co-chairperson of this program today, to deliver the welcome address.
Can you bring this down a bit? Bring the mic down a bit. Srimati RM Kurba, Deputy Commissioner, and Dr. Bosnam, Dr. Babu, Dr. Jeet. It is a great pleasure and a privilege to be able to give this welcome address this morning for our guests who are here and all of you who are delegates. It is my great joy to welcome our Deputy Commissioner, RM Kurba, who has been a great agent of change in our district. She is our district Deputy Commissioner, and I'm sure she has a lot of work to be done to do today as well, but we thank you for coming and sparing your time to be with us this morning. Dr. Posnam also, who is a Deputy Director of Health Sciences, DHS, Deputy DHS. Again, he probably has a lot of work to be done, and I thank you, Dr. Posnam, for being with us. I'll not take too long for this welcome address, but it is our privilege to have you with us. And Dr. Babu, I'm sorry, Dr. Babu Narayan. I just met him today for the first time, and he has come to Shillong also for the first time. So I hope you enjoy your trip here and enjoy your time here. He's going to be a master resource person this whole day today with us, and we thank you for taking the time to come. You came from Chennai, I believe, to be with us. It's a long trip, And Northeast is quite far from other areas of India, but still, we thank you for taking your time to be with us. Dr. Jeet, thank you, and all other faculty, resource persons who are here. We thank you for spending your time to come and be with us, sharing your knowledge, and we believe that these sessions will be something which is going to be useful for us, all of us who are here and listening and taking part in the discussions. I would also like to welcome each one of you, the delegates who are here. It is a good number, and I really did not expect this many people to be here. The hall is full. It's a great joy to be able to see so many of you are here, and maybe we hope that today's session will be something which you'll take back, whatever key points we can get from here to use in our day-to-day management to improve, to give quality care, which is the basis of what we want to do for our patients and for the good of all, and also for our own protection. So thank you very much, and Sister Noreen, for allowing us to have this program here. Thank you. Welcome all of you once more. Thank you.
Thank you so much, sir, for that warm welcome speech. May I now request Dr. Babu Narayan, sir, Chairperson SHCO, to speak about Caho and Jeevan.
Maybe 2008 or so, when I was 28 years old. So I went and applied for this hospital, Vijaya Hospital, which is in Chennai. Of course, I was practicing there, and the chief medical officer called me, "You have finished your MD General Medicine, and why can't you come and work?" So it is a 1,000-bedded hospital, and it is the first multi-speciality hospital in Tamil Nadu and in Chennai, before Apollo. Apollo started some 5 years or 6 years later. So at that time, they are the equal competitors. It is a 1,000-bedded hospital, and all the consultants are very experienced and senior, like our Professor Rangot. And everybody is very senior and experienced. So after some 3 or 4 days, maybe 3 or 4 weeks or so, I was called by the owner of the hospital and told that, "Babu, from tomorrow, you become the chief medical officer and medical director." I do not know what to do. I'm 20 years old and I'm fresh, and everybody is so experienced, and the hospital has a 50 years legacy and a 1,000-bedded hospital. So I am given with the task of managing 150 consultants who are at least more than 30 years of experience. I was really surprised, sometimes shocked, and sometimes afraid, sometimes concerned, though I have a confidence in my clinical medicine and other things, about the administrative thing. That thing it was life-saving that NABH came into this thing, and we were the 52nd hospital to apply for NABH, right? So that gave me a kind of shield to get to the consultant ask. So I have to think about like Professor Rangot and going to him and asking, because I think we had the first urologist in India, Professor Chinnaswamy. So my task is to go and ask him. He's at that time 75 years old. "Sir, can I get your MBBS certificate, because NABH asks?" Okay. So, "Babu, do you think that I'm practicing for this 40 plus years without graduating?" So this is a kind of thing what we get into this thing. But this NABH gave a kind of an structure, process, where a person of 28 or 30-year-old, fresh from an college, I studied in Madras Medical College, one of the oldest, to
come to terms or administer a 1,000-bedded hospital, right? So that has done a lot of things. We got into NABH and we were looking that, okay, we got into NABH, how to sustain it? Because NABH gives you the norms, right? These are the things, standards we have to do, right? Then how come my, say my nurses, my administrators will know about the process, how to give them the knowledge, how to give them the skill. So that was a major thing. You can go to a consultant, but consultant charges a hefty amount. Being a trust hospital, we may not have that kind of leverage because for maybe till now, they don't have even a marketing department. Most of the time, it is 70 to 80%. Till I left in 2021. After 14 or 15 years of service as a chief medical officer, we didn't have a marketing department, right? So we were thinking that where to build the capacity, where to do this thing. Then Caho came into picture, Consortium of Accredited Healthcare Organization. Thank you, Dr. Pramod. So this is a non-for-profit organization. What is the intent of it? The intent is quality and patient safety. NABH give you the standards, but how to follow the standards, how to make the documentation, how to make it a process, implement it, measure it, all those training programs is given by Caho. Started as a small standee in one of the AHPA conference. I still remember attending my MS Ramaya one conference where it started as a small standee, Caho, with 2 names, founding members. Now it has become an international organization running 79 plus programs and more than 50,000 trainees all over, thousands and thousands of members and associates, affiliates, ISHQA, membership, and everything. What they do? Capacity building, outreach, evidence-based research, patient empowerment, and key collaboration. This is a central team headed by Dr. Agarwal and Dr. Lallu. And we have 3 divisions: healthcare division, diagnostic, quality professional. There are a lot of forums for everybody, wherein people can become a member and they can stay abreast with whatever things, new things which are happening in the industry. We have a lot of academic programs. Then we were ruminating, okay, we have developed a system, right, for giving capacity building. Who is the attendees? The attendees are from topmost hospitals, which has a very good resource, right? They have the bandwidth. So then what happens to the secondary healthcare organization or small healthcare organization, which constitute 65% of our healthcare system? If you take 100 beds, 65 beds are provided by our small healthcare organization, which is nothing but your 20 to 50 bedded or 70 bedded hospital. There you see the unique system will be one doctor building up his career. He will be having one manager who will be the facility manager, who will be the HR manager, who will be the operation manager, who will be the liaison manager. One person doing everything. They don't have the money or the bandwidth or the resources to have a vertical, finance vertical, administration vertical, right? So then we thought that how to go about it. Then we started our SHCO wing, small healthcare organization wing. He is the person who started and gave the first boot. I'm just trying to be a follower, that's all. See, he is Dr. Roy, and today he is not amongst us. He died in an accident. One of the good friend, and he was the one who started this initiative. So we always carry his memory and mission. The main thing is that capacity building, compliance, collaboration, and credibility for small healthcare organization. There we conduct 2 programs. One is Jeevan programs like this, where we have a set of sessions addressing to the small healthcare organization, be it be pharmacy, be it be legality, be it be consent forms, be it be operations, be it be finance, whatever it may be the thing, this is put together so that everybody gets knowledge, skill, understanding. This is the 10th conference which we are conducting. We are trying to create an ecosystem of the 65% of our healthcare system if quality can be given as an operational excellence, not as an expenditure. So thank you, Nasrat Hospital, for hosting us, for helping us. I would say that I haven't seen this kind of arrangement anywhere, madam. And it is very technologically forward. And Pramod was doing, like pressing certain buttons. This comes, this goes. I haven't seen anywhere like this. And this arrangement was one of the best, I would say, in all the programs what we have attended. And thank you very much for Noran sister, Pramod, and Dr. Rangat for hosting us. It was really a pleasure. And thank you, chief guest, because see, the government can provide the healthcare, but as a private hospital, as a citizen, we have to take a ownership to help the government to run it, provided the kind of GDP, provided the economies of scale, provided the population. So unless the healthcare becomes our individual motive, we cannot reach a healthcare sustainability. Thank you very much for the opportunity, and thank you very much for the Northeast hospitality. This is the first time in Shillong, and I'm just flabbergasted by the kind of reception and the kind of hospitality provided by Nasrat Hospital. Thanks once again for the opportunity. Thank you very much for all the delegates for coming in, because without you, there is no program, right? Because you are the heroes and heroines of this today, this thing. We are just actors. We are just playing our part. And thank you for coming. Thank you very much.
Thank you so much, sir, for enlightening us with Caho and about Caho activities. It is my privilege to invite our administrator, Sister Noreen, organizing chairperson of Jeevan Shillong, to address the gathering.
Our chief guest, Madam Aram Kurba, Deputy Commissioner Shillong, guest of honor, Dr. Posnam, Deputy Director, DHSMI, Dr. Babu Narayan, Caho, Dr. Rangad, our CMO, Dr. Pramod, our Organizing Secretary for the program, Dr. Jeet Advari, and all the representatives from Caho, all the speakers, chairpersons, and all the participants of the program. Good morning and warm welcome to everyone. It is indeed a privilege for Nasrat Hospital to host this important occasion, the inauguration of the Jeevan Shillong program, an initiative dedicated to strengthening small and medium hospitals in this region. Today's initiative is therefore not just a program, it is a movement. The Jeevan program, in collaboration with Caho, aims to empower hospitals with structured systems, quality frameworks, patient safety standards, and leadership strengthening. It provides mentorship, guidance, and a pathway towards excellence. At Nasrat Hospital, we strongly believe that quality is not an option, it is a responsibility. Our commitment has always been to provide ethical, affordable, and safe care, especially to the poor and marginalized. Strengthening systems is not about paperwork, it is about protecting lives. It's about ensuring that every patient who walks through our doors receives safe, dignified, and evidence-based care. Through this collaboration with Caho, we are not only improving institutions, we are building confidence in communities. We are creating hospitals that are resilient, accountable, and sustainable. Let this program become a platform for shared learning, mutual growth, and collective excellence. Let small and medium hospitals in Meghalaya and Northeast emerge as strong pillars of healthcare delivery. I thank Caho for partnering with us in this meaningful initiative. I also thank every participating hospital for your willingness to learn, improve, and lead change. Together, let us move from good intentions to great systems, from individual effort to institutional excellence. May this initiative bring strength, structure, and sustainability to healthcare organizations. I once again express our heartfelt gratitude to our chief guest, Madam Aram Kurba, for honoring this occasion, and to our guest of honor, Shri Poshnam, Deputy Director DHSMI, for his gracious presence. We also sincerely thank Caho for partnering with us in this meaningful initiative. My special appreciation goes to Dr. Pramod, who has been a driving force behind this program. I also thank all the participating institutions for your commitment to excellence. May the Jeevan Shillong program become a model for institutional strengthening in Meghalaya and across Northeast. Together, let us build hospitals that are strong in systems, ethical in practice, compassionate in service, and sustainable in vision. Thank you. I wish the program for every success and wish God's blessings. Thank you.
Thank you so much, sister, for that wonderful and inspiring speech. May I now invite Dr. R. Pottsnam, Deputy Director, Health Services, DHS Shillong, to deliver his speech.
Deputy Commissioner, Madam, Chief Guest of today's program, Dr. Sir G. Rangat, the Chief Medical Officer of Nazareth Hospital. I just learned that he's 76 years. Now, today's program, I believe we are going to discuss about the KPI of hospital. But most of the time we forget to assess or gauge our own KPI, that is personal health. So to me, he's a role model at 76 years, looking still young, and look at his skin still red. That is the true indication of being fit and healthy. It's so sad that, there's a recent study in Meghalaya that by the time women turn 65, they are widowed. Because men, that is the study which was admitted by our Principal Secretary Health. So men, we have to be careful, but sir is here to prove that we can achieve that. Thank you, sir, for being our role model. And then to Dr. Babu, who is I can say the leader in this quality and patient safety program, Caho, being a leading organization dealing with that aspect. To promote my friend and colleague, who from time to time we do interact how to build a quality improvement system in our state, be it private or public institutions. And Sister Noreen, she's a very dynamic and able administrator, and I think we have met a few times back. The distinguished resource person who I think they come from different states, and some of them are in Meghalaya itself. The participant, I believe a few participants also they are from public health institution. Also, I think it's the right platform that you attend because I do agree that in government, in health department, as part of Ministry of Health and Family Welfare mandate that by December 2026, all government health facilities, right from health and wellness center, right to district hospital, ought to get fully certified on the National Quality Assurance Program. And we are moving in that direction. We have certified many institutions, right from subcenter, PHC, and district hospital. But that is a government program, which is funded by Ministry of Health and Family Health Programs. But this kind of platform will, I believe, will expand the horizon of our thought process because Nazareth Hospital itself, I think it's being the first NABH certified, fully certified institution in all states, both NABH and NABL, right? I believe, yes. So it's a great learning place, especially for the participant from the public health institution. Ladies and gentlemen, so it's a privilege for me and honor to be with this program today. And I believe the small and medium hospital particularly the private hospital in Meghalaya, they play a big role. Be in Juai or Shillong and Turap, public always turn first to the private hospital in times of emergency. That is an admitted fact. I don't say that our public institutions are not good, but evidence shows that we do have huge trust and faith in the private institution. So, but I also am aware that they are working under challenging environment, be it patient expectation a lot, and then with limited resources, it's difficult to deliver, especially in today's world where the expectation of patient is sky high. But anyhow, one thing I would like to stress upon the fact that most of the hospital, they already have the system in place. They have very strong internal levers, be it the teams, the process, and the decision making. They already have it. So this platform will further enhance or strengthen the quality improvement process that hospitals are already implementing in their own capacity. So in today's context, I would like to mention one aspect, because in the session I saw one session which is dedicated on medico-legal documentation. With the recent introduction of new digital platform like MedLipa and IRAT, I believe you are aware of MedLipa, which is the digital platform under the new BNS 2023. Now IPC, CRPC are no longer relevant terms. So we have to speak the language of BNS 2023. So in the state, I'm myself the nodal officer of MedLipa and IRAT. MedLipa, all digital, the medical legal documentation have to be documented in the MedLipa portal. And then all injury cases have to be documented in the IRAT portal. And I have seen, because I do log into the IRAT portal, I have seen most of the private hospitals, they have already been onboarded onto the IRAT portal. And with the implementation of this cashless treatment of accident victim, what they call CTRAP scheme 2025, which is the Ministry of Road and Transport being the nodal agency, any victim of accident, be it he or she from any part of India, they have to avail cashless treatment in any empaneled hospital. So we are working on in that aspect, who will be done. In fact, the State Health Agency is already working on that, in that direction. And once the structure is in place, I think the documentation on the IRAT portal, an injury patient admitted to your hospital, traditionally we do documentation in manual format, but from now on, we have to do it in the IRAT portal and share the report with the police department. So that is the latest development. So with these words, I believe the sixth session that we're going to have today will enrich our thought process, will reinforce our energy, vision, so that patient safety and quality improvement in wherever we work, in whatever capacity we deliver, will be the main driving force behind our role. So I wish this program every success. Thank you. Jai Hind, Kublai.
Thank you so much, sir, for that wonderful speech. I now invite our esteemed chief guest of today's program, Srimati R.M. Kurba, Deputy Commissioner, East Khas Hills District, for the inaugural address.
Thank you so much. A very good morning to all of you. I would like to convey my special thanks to Sister Noreen, who is the administrator of Nazareth Hospital, for having invited me to be here. It is indeed a very important program where we are talking about Jeevan, that is life. And it is a program of first of its kind in Meghalaya. Thank you, Caho, for bringing it to Shillong. And, we really is the need of the hour, actually. uh, our Deputy Director, Dr. Poshna, who's a guest of honor in today's program, Dr. Babu Naren, Caho, SHCO chairperson, also Dr. Rangat, who is very senior and respectable. He is not only, a medical practitioner, he's also a practitioner of the heart, because when he speaks, I've heard him speaking in many, in the church. He is a very good speaker and motivates all of us. Thank you, Dr. Rangan. Also, Dr. Pramod, who is the state chairperson of Caho, and all Dr. Jeet, I hope I'm not wrong. Yes, thank you. And all the doctors present here, coming from the states outside of our Meghalaya, and our very own resource person. Thank you so much for coming here. I know it's a very good, to have good resource person, because the clarity of thought, the clarity of the mind becomes, the center stage when we have good speaker. And I was captivated when I heard Dr. Babu, because I was there for 1.5 years in health, as Secretary of Health. So, these kind of, seminar or workshop, I've attended many. And I was just telling sister, I hope he doesn't shorten you. He was saying shorten, but it was very interesting for me. Thank you so much. We really need, even as a lay person like myself, who doesn't come from a science background, it's important to know. Not necessarily that I have to study, but it's good to know as an administrator myself, to be involved in such kind of, activities, because it also improves our understanding and sensitize us a lot. So, and also, so glad to see such young people over here from the different institution. Just a heads up is that our state is a very young state. We have 74% of people below the age of 35. So you can imagine the workforce. We here they have a lot of work to do, and it is very important for them to improve their capacity from time to time, and especially in health, where new things are coming up, and we need to be updated. And today's program, where we are focusing on a very important area, and that is strengthening of the healthcare in small and medium hospitals. In a state like us, we have very less, government hospital which are really established, which have really all the standards that are required, to be recognized. So therefore, the small and medium hospitals are really important for us. And as Dr. Poshna has already pointed out, it's a people's choice. People's choice. So therefore, your quality, your presentation, everything has, it speaks for himself. You don't need advertisement, you just need by the word of mouth. So therefore, your improvement becomes very important for us in the government. When we talk about, these standards, it's become mandatory for us to ensure that, they are, as you've mentioned, NABH standards. Then we have the SOPs for healthcare, which ensures the quality of quality standards, safety, and especially in my area of work, where I'm looking after the disaster and management. Here, I've just had, mock drill recently. See, the response of the medical team in, at least in my district, is very good, in the sense that we keep on practicing these mock drills, and we make people understand. People ask me why we have mock drill. Are we calling for trouble? Are we inviting nature's kind of like we often say in our Khasi customer, don't invite this trouble, yeah. But then we can't do it, we can't do away with mock drills, because there we need to know whoever is part of the team to understand their role, to be ready. if anything happen, my team is ready. Any time of the, like, should there be any disaster, they know where to report and what needs to be done. So it's very important for us to look at that aspect in health too, to ensure that everyone is trained in disaster management. Then, as you said, doctor, proper record maintenance. That is again a very important step, because I believe, like, most of us don't even keep our own personal records when it comes to medical. So sometime, when we go to the medical specialist, we kind of, like, whatever comes to mind. So our mind cannot be trusted. So even the government now, we have this system where we are trying to put the history of all the patients, but that will take time. It's already started, but how many of us does the truth? Yeah. So we need the doctor, whoever's treating us, should know, like, the whole history. Like, I do a lot of review on maternal deaths. What I notice is that in the records, they don't ask for the past history. So that becomes very difficult. And most of the problem, we say that we are high on maternal deaths. But the problem is that in the certain cases that I found out is that they didn't die because of, birth, of delivery, they die mostly of past records of, illness. So the problem is that most of the time we don't take the history of the patient, so it becomes a problem for the doctor to, in an emergency, to kindly give the proper treatment. So we lose lives like that. So this is something which I come across while doing the maternal death reviews and also infant death reviews. These are the things which I do almost every alternate month, to ensure that we are reducing the maternal death in our district, in our state. So in fact, we have come a long way. The number was in hundreds. Now this year we are hoping, crossing our fingers, that it's just double digit. It will not cross it will not cross the third digit. So we are really working very hard on that. We have a mission, we called it a rescue mission, to ensure that maternal death is reduced to a great extent. We want to, our dream is to have single digit and maybe 1 point of time, which is very difficult, of course, very well. And also, like, we need to monitor ourselves, like continuous monitoring of all the institution, like how we have audits in our office. This thing which you are, capacitating everyone here about maintaining records and monitoring, so that we make corrective measures should any kind of shortfall in the process. So accreditation in itself is not just a certification. It is a continuous commitment to deliver quality, safe, and patient-centric care. And also it builds trust of the patient, improves efficiency, and enhance healthcare outcomes. To me, I feel, added to that, I feel empathy is the word that we need to kind of concentrate to in our training, because a lot of time, with a lot of load and pressure, we tend to kind of forget our, ethics, and, we forget our empathy, and we just kind of speed up our work. So a lot of empathy and self-control is required. As Theodore Roosevelt wisely said that, quote, patients don't care how much you know until they know how much you care. So this reminds us that compassion is at the heart of healing. And another thing is that, I mentioned earlier that in government, we really rely on the small and medium hospital, is because we cannot work in isolation. Like public hospital on their own, and there's no competition here. We have to work together. We have to work in a team, collaborate with each other. So therefore, we really need good leadership. And sometimes we have criticism. We should take them as a double-edged sword, where we can make corrections and improve our performance. And also, what happened is what touched me most is when during the COVID, I saw the work put in by the medical professionals at all levels, and I really I would like to put on record my sincere thanks to all the to all the caregivers who were there, and for your dedication and consistent efforts. Your again, as we are here with Cahos and your vision and mission, where you have your relentless pursuit for betterment in your services, I really deeply appreciate from my end to all of you and to all the learners present here today. And lastly, to end my speech is I would quote Mother Teresa. She says, "It's not how much you do, but how much love you put in to what you're doing." With this, I thank each one of you, and I wish this program a success. And may God touches you with lots of empathy and strength that you can carry on your services to mankind. Thank you. Kublai Shibun, Mithela, and Jai Hind.
Thank you so much, ma'am, for that very insightful address, I should say. We truly appreciate your presence and guidance. And most importantly, thank you for your time. Thank you. As we come to the end of this inaugural program, I now invite Dr. Pramod Paharia, the organizing secretary of Jeevan Shillong and Caho State Chairman Meghalaya, to deliver the vote of thanks.
Good morning, everyone. Respected chief guest, guest of honor, distinguished dignitaries on the dais as well as in the hall present here, esteemed speakers and dear participants. It's my proud privilege to propose the vote of thanks for the inauguration ceremony of the Caho Jeevan program held here in Shillong today on the 21st of Feb. At the outset, I extend our deepest gratitude to our esteemed chief guest, Srimati R.M. Kurba ma'am, Deputy Commissioner, Khasi Hills, East Khasi Hills District. Ma'am, we are truly honored to have you here, and your inspiring words and encouragement have set a strong and purposeful tone for this program, motivating us to strive for excellence in public services as well as in healthcare delivery. In fact, ma'am, I would also like to congratulate in this forum for receiving the prestigious President Award last month, right? So she was there to receive from President Draupadi Murmu ma'am. She got for the best district for the elections, fair elections in the recent time. So congratulate ma'am for that also. I also express our sincere appreciation to our distinguished guest of honor, Dr. R. Posnem sir, Deputy Director, Health Services, DHSMI. our flyer designs and looking at the brochures, looking at the registration, participants, contact, everything. Dr. Balamurugan sir from Caho SSCO division, who was also well supported and guided and supported during the program. Miss Maulin, Miss Mandira, Miss Rikinti, who was nicely doing the MC during the program. Sister Saran for your support. Mr. Arun for arranging the refreshment. Mr. Thomas, Mr. Dhanraj and Vishnu for the IT and the YouTube link which has been created. Thomas was very instrumental, and in fact, he was the most excited person yesterday to say that we will go live. With heartful thanks to everyone who contributed. If I missed anyone, it was not deliberate. Believe me, there are so many names. But I think I should conclude by thanking you all for making this inauguration ceremony memorable and meaningful, and obviously looking towards an exciteful day ahead. Thank you so much. And with that, I think we can take a small break. Thank you so much, ma'am.
Thank you so much, Dr. Pramod. In fact, he has named so many names to thank. I would like to extend my heartfelt thanks to him personally, because he has taken initiative in collaborating and coordinating this whole program. Thank you so much, Dr. Pramod. So now we will take a break. Request all the participants to kindly help themselves. The room for the tea is the adjacent room. Thank you so much, one and all.
We will bring it, sir. Photograph?
We can have a group photo. We can just come this side. We'll have a group photograph. I will request all the resource persons, please to join us for a group photograph. Yeah. Yes, sir, we can do that.
Speaker select ചെയ്യണം speaker. Off ചെയ്തു. Switching to Zoho projects, our customers say it's a breeze.
Your baby's hair is as soft as a feather. So let's put Johnson's Baby Shampoo to test on a feather. First, take 2 feathers, wash one feather with Johnson's Baby Shampoo and the other with a hard shampoo. Johnson's Baby Shampoo gently cleans and protects from day one. Choose products with baby-safe ingredients. Johnson promise from day one.
A new horizon of healthcare delivery and patient safety. We have a goal, a noble drive. Hand in hand, step by step, we will try to march ahead together.
Hello, sister. I would like to inform you that the ceiling in pediatric ward is about to collapse.
Okay. I'm sending Arun there. Arun, please go to third floor pediatric ward. There is an emergency going on. Okay. I'll check and I'll get back. Sister, the baby is about to collapse. We need to evacuate the baby. Yeah. Please immediately evacuate.
Hello, information. Please activate code orange in pediatric third floor.
Okay. Code orange in pediatric ward. Code orange in pediatric ward. Code orange in pediatric ward.
Nico 1, code orange.
Open the emergency exit.
if you were born between 1980 and 2000,
Activate code blue.
Nazareth Hospital expand its services to periphery, where health facilities are very minimum. Our hospital has taken 15 villages and 15 rural schools, where our vibrant and active community health team regularly visit the villages for antenatal checkups, immunization, health education, training, sanitation, school health programs, and surveillance.
doody, squiggly doo da. You've been nibbling at my little हल्के मीठे क्रंची हार्ट शेप्ड पॉपेबल्स ब्रिटानिया लिटिल हार्ट्स हर बाइट प्यार से भरा
Dear friends, today is 31st May 2024. The WHO is celebrating as World No Tobacco Day. So today is an important day globally. And this year's theme is protecting our children from the influence of the tobacco industry, which goes significantly in the fight against tobacco. Friends, we need food, not tobacco. And this year, again, when you compare it, more than 38 million youths between 13 to 15 age group are using some form of tobacco. So friends, again, very important that passive smoking, you kill your near and dear one by more than 40,000 people are dying due to passive smoking. Cigarette smoking directly affects all the body parts and it also decreases the life expectancy. In US, the cancer, like 1 out of every 3 cancers will be directly related to smoking. If you see the heart diseases, if you see the stroke, all are related to smoking. 8 of 10 patients whom we diagnose as chronic obstructive pulmonary disease are related to smoking. And it's a very severe, debilitating diseases causing decreased quality of life, needing oxygen support and medication, and whole family support will be needed, which is directly affected by smoking. Friends, 85% of all lung cancers are related to smoking. More than 8 million people are dying of smoking every year. And quit smoking at any age. It improves your life expectancy and improves the quality of life. Thank you.
Hello, good afternoon. I'm Dr. Raj, consultant psychiatrist, Nazareth Hospital. Today we're going to talk about tobacco/nicotine. Tobacco or nicotine dependence is one of the most prevalent and ignored dependence that we have ignored over the years. Nicotine dependence or nicotine itself is almost a very ideal substance. It is very easy to procure. The effect of nicotine is very fast. Use of it is not punishable. That means it is licit substance. And it is not a taboo of while using it. That is, it is socially approved behavior. In addition to this, nicotine has very unique properties. It do not cause intoxication the way we know other drugs or alcohol does. And henceforth, people end up consuming a huge proportion of this substance. Like other substance, nicotine also has properties of desire, craving to consume the substance. Because over a period of time, the body develop tolerance, you need higher amount to get the effect of nicotine. At the same time, the individual who are using nicotine, they are aware of the harmful health consequences of nicotine or tobacco use, despite that they continue to use. So these factors or these properties are classically seen in substance dependence. Now what happens? The moment an individual smokes tobacco or consumes a tobacco, within 15 seconds, this nicotine is delivered to the brain or central nervous system. In the brain, there are receptors, nicotine receptors, where this nicotine get attached and produce the subjective sense of calmness. The unfortunate part of this is that the receptors get desensitized very fast. It usually effect barely lasts for 2 hours or so. Henceforth, the individual has to consume a higher dose to get the effect. Over a period of time, because of desensitization of the receptors, the individual might require to consume higher and higher dose of nicotine. So
here's the reality. Your college degree took 4 years and $100,000. AI skills, AI skills.
Everything is perfect.
And manpower. I just want to retain the one documentation champion for 1 month. You know, nurses create one documentation champion. Let them go through the papers, see what are the errors in the documentation. Reward whoever catches, make it fun, make it competitive. It really helps. Then, if you have no digital system, just create one standardized, just take one case per day, just one standardized template. Advocate.
Speaking a lot about in your page.
You change your laptop, sir? Did you change the laptop?
No, not yet, because this one is still not ready.
Not yet ready?
Yeah. So this can be closed. Wait, what happened? Acha. Dhanraj, that can be closed. We have to telecast. We'll put this screen now on. Yes.
Lamp lighting is a ceremony where we used to do before the beginning of any program. It symbolizes light over darkness, knowledge over ignorance. Thank you so much, dignitaries, and also Dr. G. Patwari. Now we will welcome the choir from Nazareth Hospital to kindly present us with the welcome song.
May I request all the participants to join us again? Before we proceed to the next session, that is on fixing the leak, efficient workflow, cost reduction in inventory management. I would, since because the inauguration was, we started early, so we would like to felicitate our speakers and chairperson from the first session.
So as told by Dr. Pramod, we will start with this felicitation. May I request Dr. Jeet Patwari to kindly come forward and felicitate our chairpersons and speakers. May I call first Dr. G. Ringat to kindly come forward. So kindly stay here to felicitate the others also. Dr. Anamika Mall. Okay, it seems he has left the hall. So I will call Dr. Babu Narayan. Please come forward. Dr. Babu Narayan, sir. And the last person, Dr. Rebecca L.I. Karsaitiang. Kindly come forward, Dr. Rebecca. Thank you so much, Dr. Jeet Patwari, sir, for doing the honor. Now we will move for the second session. The second session is on fixing the leak, efficient workflow, cost reduction, and inventory management. In this session also, we have two chairpersons, Dr. R. Potnam, Deputy Director, Health Services, DHS Shillong, Meghalaya. I request Dr. R. Potnam to kindly take the seat on the right-hand side of. And the next chairperson, Dr. Cheki M. Pochna, Deputy Medical Superintendent and Registrar Medicine Department, Bethany Hospital, Nagpur. Sir, kindly take your place. The chairpersons will introduce the speakers and they will moderate the session. So over to you, sir.
A very good morning to everyone. Welcome to the second session, Fixing the Leak, Efficiency, Workflow, Cost Reduction, and Inventory Management. As a small hospital, a small and medium hospital, operational efficiency is what allows us to be sustainable, and that what guides us to give quality care. We have two distinguished experts from our regions to guide us through this. I would introduce the first speaker. Our first speaker is Mr. Pele Zoto Pius Kiki. He's a senior quality manager at CSSD Dimapur and also the Caho State Chairman for Nagaland. On a personal note, I have a very great deal of respect for the institution which he represents. I was actually trained in one of the departments under Dr. Sidive Agame. It is a pleasure to have someone from that center of excellence here today to discuss setting up efficiency pharmacy workflow. Please join me in welcoming Mr. Kaki.
Okay. Distinguished guest speakers, delegates, good morning to everyone. I think it's all the, still good morning. It's my pleasure to chair this first session, that is fixing the leak, inventory management. As a person who comes from public institutions, we have seen our system sometimes do not capture the leaks, and that leads to cost escalation of procurement. So this session, I think, is very important, not only from the participant perspective, but even from us as chairpersons. We hope and we expect that the speaker will give his insight so that it'll be a learning lesson for us as well. So to put things into context, now I'll introduce the second speaker, the first speaker. Or second speaker. Okay. So now the session is open, so we'll invite the first speaker to start his lecture.
Good morning. I think the tea is not taking the effect. Good morning. Okay. My session is on efficiency, and I have to be efficient with my time also. And my KPI for my own presentation will be that every one of you takes your lunch break on time. It's a bit of a pressure on me. So while the presentation is to be fixed here, let me just introduce a little bit about the topic also. Efficiency or efficient workflow of any department in any hospital is essential for patient safety, first and foremost, then reducing the errors and also improving the service quality. Now I'll be dealing a little bit about pharmacy. So pharmacy is an important area, and efficiency in that area, in that department, is very, very much vital, because this is generally the last point. Yeah, it's coming. It is? Okay, it's coming. Okay. Pointer. Okay, like I was saying earlier, pharmacy is generally the last point of contact. Okay. So last point of contact. It's like a city is being jammed, right? I'm repeating myself over again. Last point of contact before a patient actually receives the medicine. So before that, a lot of things can go wrong, and pharmacy is like the last point of contact and the last check. If anything goes wrong beyond that, then we can't help it also. Thank you. So when system fails, then the lives hang in balance, especially in the hospital. It's life and death, even if there's a small error. So there are studies which shows that the pharmacists in all over the place, they do experience, like the other staff, some sort of stress, and too much of stress in the workplace is also not a good sign, which leads to this kind of errors, which I'm showing on the slides. These are studies done in India in various hospitals. So you can see that the error rates that has been found during the study. And in Delhi, as you can see, out of every 1,000 prescription in one of the general hospitals, 82 are leading to adverse drug events. So small and medium hospital pharmacies, they generally have some basic features. And I believe we are all from either from the small hospital or from a medium hospital. So these are generally some features that we see. Manual based, small team which is multitasking, the suppliers are not within our control. Most of the time it's small vendors. Example, from Dimapur, I'm from Dimapur, and our suppliers depends on the main suppliers from Guwahati. If there's Bihu, then we get stuck with that. So we have to plan our inventory also based on the festivals in Assam also. So these are some challenges. And I want to stress a little bit on the multitasking also, because this is one of the favorite method which is used in small or medium hospitals. In my case, a long profile has been shared in by our chairperson about me. But in fact, I come from a mission hospital, 219 bedded hospital. Infrastructure is vast, buildings are vast, but the team is small. Now in quality, designation is fancy, senior quality manager, but I am the only full-time quality staff there. I'm doing the role of the manager. I'm doing the role of the office assistant also, filing, documentation, plus the managerial role. So I do the audit, I come back and I do the analysis also. If there's anything related with the documentation, I'm doing the filing also. So there is not in every hospital, but most of the time management loves to abuse multitasking also. So that has to be careful, okay? Because if you do too much multitasking also, it leads to burnout, stress, which I've shown, and which affects the quality of services and leads to error in the department also. Don't multitask too much that you break the back of the employee also. But then don't take this presentation as an advantage to say, sir, see, madam, see, we are not supposed to be multitasking. I'm not saying there has to be a balance. Like Dr. Rebecca in the first presentation has said, there should be a balance. So why pharmacists need an efficient workflow? Because this poor workflow will lead to medication errors, like I've said, long waiting time in the pharmacy, stock goes out of, medicine runs out of stocks, then revenue leakages. These are some examples which happen when there is not when the system is not efficient. And when the system is efficient, it leads to faster service, less errors, patient is satisfied, and compliance with the regulatory, or if you are going for NABH, and compliance with NABH standards as well. Now there are some key challenges, like I've said earlier, multitasking, manpower limitation is something which we have to keep in mind, which leads to stress, supplies in this part of the country with small hospitals. It's a challenge also. We have to adapt to so many things so that our inventory management is up to date with what the patient requires. So these are some basic things which are faced in the small healthcare organization. Now some smart scalable ideas to improve workflow. I'm going a little bit fast so that you can have a lunch break on time. And also to give you, like Dr. Babu, our respected sir has said, take 2-3 points. If I throw in too many things also, it's not going to be retained in your memory. So I'll be sharing few points. Small healthcare organizations usually have tight budgets, small income. So this using AI, introducing smart dispensing system like the barcode scanners, it'll really help reduce. This AI softwares, barcode scanners, this helps in reducing errors almost to zero. But then again, there's a catch in there. You have to invest. Investment both in the software and the hardware also. And AI with pharmacy management system will help. Even if the team is small, it helps in doing a lot of things which can be done by a large team. So there's a catch in that. It involves cost. So I'm not going to go in detail out here. What I'm going to share is, okay, then monitoring feedback and the performance is very important. Quality, efficiency is continuous journey. It doesn't end in one. You do well in 1 month, next month if you're falling back, then it doesn't mean your system is efficient or your quality hospital. So the monitoring is important, trying to see what is the error percentage, what is the waiting time in the pharmacy. These are just few vital important things which we can use to track and see how efficient is our system. What I'm going to stress is a little bit on the lean management. So this is a very simple method, easy to understand. If you apply it, it doesn't involve that much of cost. I won't say it's zero cost, but still very, very minimal cost is required. One is identifying the waste in the process, in the system, waste, physical waste included in that. It goes with the acronym of Tim Woods. I'll show the details in the next slide. Then the other thing is using 5S method to streamline and organize the place so that you reduce the errors and improve the productivity. So like I've said, Team Woods or downtime is an acronym which is used to denote this kind of waste. Okay, both covers the same waste. It's just that the acronym is slightly different, but it is used. You can use either one because it covers the same types of waste. So Team Woods means transportation waste, inventory waste, motion waste, waiting waste, overproduction waste, overprocessing waste, defects waste, skill waste is there. So these are the 8 types of waste which is present in any kind of organization, with the hospital included in that also. And I'll show one example from my hospital. So I just had a session with the pharmacy group on the Team Woods, how to identify the waste in the department and how to reduce it. So a very simple exercise was done by the pharmacy team. When a patient comes to the pharmacy to get a medicine with a bill, they are issued a token. So the token is done manually. And like any small hospitals, we love to reuse. So the empty medicine boxes, they keep it aside. And then when they have time, they cut into a small square shape and they write manually the number 1, 2, 3, and that is given as a token to the patient. So they did a very small exercise. They said, okay, seems to be wasting time, resources on cutting this paper. So they did something. Earlier, the empty boxes were taken from here and they're stored here. So now they said, no, we won't do that. We'll print out, because we get a lot of indent slips from the inpatient department, and that we can reuse for printing, and we'll use that. So they stopped storing it. So ultimately, what they've done is that manually, they take about 37 minutes on an average. Every day, 37 minutes is spent on preparing the token. But after they have done the modification, identify the waste, reduce it, and reuse the paper for printing, they reduce it to 8.75 minutes. So about 30 minutes is saved every day just for the token number, issuing the token number. And these are some of the ways that they have reduced. Motion, moving up and down, from here to there, then take it back to there, that has been eliminated almost. Then inventory waste, just stockpiling of empty carton boxes, which is occupying the space. Then transportation waste, moving things from one location to another, just for the sake of cutting the paper. So these are micro, it may be 1 second, microsecond, but if you accumulate it over a period of time, you'll see that it converts into hours. So in one day, they may be doing a lot of work, See, most of the time, if you don't understand the ways in the system, you will be doing a lot of work. No doubt, hospital is a very hard-working place. But at the end of the day, staff gets fired from the patient, from the management, saying these things have gone wrong, that thing have gone wrong. What are you doing? How are you spending your day? We are spending our day along with the waste, and that is why the efficiency is not seen in our work. Again, from the same hospital, my hospital, pharmacy department. So we store medicine in this way, in boxes, this box, and each of the box, they used to have a small strip with a reorder level. So when the medicine gets over, they send it to the store with a box, with a reorder level strip, and with that, it comes back replenished, and it comes back to the department. So when it comes to the OP or IP dispensing counter, now for them to search which rack the particular box belongs to, it takes time. They have to keep on searching. So around 20 racks are there in this particular dispensing center. So to keep on searching is difficult. So after the session with them, they understood that what they are doing, searching, moving around, is causing delay. And at the same time, that is motion waste also. So they came up with a very simple example. They have pasted numbering on each of the rack, and each of the reorder levels, you can't see it out here, but they mentioned the rack number also. Now the box comes, they don't need to search. They just identify, okay, 16, they go to 16 and put it back. So the extra movement that they make in searching for it is reduced to to a great extent. So these are ways, small ways. It doesn't involve money. It just involves some thinking, some skill. So if we are not training the staff on those kind of skill, then they may not be able to identify it. They know it, but they may not identify that thing as a waste. So if you enhance the skill of the staff, see, as a quality manager, I cannot know all the problem in any department, nor will the managing director or the CEO know all the problem in any department. So if you empower the grassroots level with this kind of trainings, skill enhancement, then they themselves will start on, it's like downline business, right? Oriflame, Northeast part, I think Oriflame, Amway, you very familiar with this kind of business. You train someone, upgrade the skill, then they themselves will keep on upgrading and creating efficient system in the department itself. Then in the accounts department also, I did small this exercise, lean teamwork exercise with them, train them, then they identified. I'm not the one who's identifying these ways. They identified by themselves. Current process is taking 6 steps. Then afterwards, they said, manually, we are wasting so much time. Why don't we go online? And then they went online, and with that, it came to 3 steps. 50% of the step is reduced. And with that, they found that over-processing waste was there, waiting waste was there. Wherever the over-processing is there will always be a waiting waste. So when you remove one waste, the other waste also gets eliminated or reduced. Inventory waste was there, transportation waste was there, going from the department to the bank to the department again. So, and with the transportation waste, it's not just transportation waste. You're going with the vehicle. Maintenance cost will come up. Fuel cost will come up. So when you eliminate the transportation waste, you are saving money. In all these ways, you are not investing any sort of money on it, but then you are getting money in return by saving this kind of efficiency in the process. Now, a little bit about 5S also. 5S is a Japanese method for organizing the workplace so that they improve the efficiency, safety, and productivity of the workplace. So what is the difference in this work environment? One is, I will say, the first picture with a male, second picture with a female. So what is the difference in this work environment? You are sharing your views, but I can hear only bzz, 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 bzz. Yes. Volunteers, 1, 2 volunteers, you can stand up and then share your view loudly. What is the difference out here? Yes? Organization. I thought male, female. So one is organized, the other one is not organized, right? So which pharmacy will have higher chance of error? Or first one? Okay. Which pharmacy will have, in which pharmacy will the staff spend more time searching for the medicines? First one. Okay. So, and which pharmacy would you want to work for? Second. Sure, not the first. Okay. Inventory management, which will be easier to manage? Second, right? Simple. It's all visual management. So 5S deals with this organization or organizing the workplace. Very simple exercise that you have to take ownership of, and you will see the changes. You don't need to buy some AI or invest in some software. This is all human related. Okay. And as a small healthcare organization, we can invest in this kind of things. So 5S, some benefits of it. And I've shown one picture out here also. Before 5S, it takes a lot of space and unnecessary items were all already there. But after the 5S exercise, unnecessary items were removed and they occupy less space. So before 5S, I'm sorry I have to put a picture of a woman out here. I couldn't get a male version, so don't think that I'm generalizing the ladies, okay? Before 5S activity, generally, that means before the training and you understand in what kind of scenario your department is, we are comfortable with the ways in the department. You come to my department, you'll see, oh, there is a waste. But for me, there is not a waste because I've been living in that condition. If you visit anyone's house, no house will be similar, right? Some will be little organized, some will not be organized. But the one who is not organized will not think that my house is not organized because that's the way they have been living for the past many years. Same way with the department, you are living with the ways, with a disorganized manner for a long time, but you think that that is normal. So hand hygiene compliance, is it 100%? Hand hygiene? No. So most of the time it will be no. I mean, even if you invest in quality and do all these exercises, still is difficult to achieve 100%. But if you're comfortable with what we are doing, then we'll think, oh, our hand hygiene process is okay, right? Documentation also, is it 100% compliance, or do we still miss out the thing? And then in the first session, the doctor's handwriting was mentioned also, that generally we think the doctor's handwriting are too bad. But for the doctors, it's not a bad handwriting. It's very beautiful handwriting, right? So that's how we tend to get used with the system and think that what we are doing is right. So with the 5S training, you'll get to understand, have a new view about the system process in the department. And even if you're living like this, first, the 5S, it denotes 5 steps, we start with S in each. First one is sort. Sort is you identify what is not required in your department, and then you remove it. Whatever you don't need, you remove it. And in this phase, like I've said, since you have lived with the process, with the system, the way you function for a long time, you'll feel that this is not a waste. So in this phase, it is good to invite other departments, staff from other department, maybe quality or non-quality, you can invite and let them participate in the decision, let them participate in the activity, and they will be able to show you the things. Like I believe every one of us have got some cloth which is almost fully gone, full of holes, slippers, shoes, very old, but we don't keep it, we don't throw it out. We say, we might need it. The old banyan will transform into the floor, mopping the floor, right? But before that mopping happens, where is it stored? So that accumulation happens. So, but for us, we don't think that is a waste. That is creating some kind of problem in my house or in the way we are managing the things. So if you invite some other people who is not related with the process, they will be able to give you some insight, better insight in helping with the sorting. After you have sorted out whatever item is remaining, you have to put a label on it. You have to designate, everything should have a designated place. Example, this particular stand, is it always here or is it going up and down based on the different kind of program? Is it always here? Nazareth staffs? Okay. So same way with the functioning of the department also. Suppose in the OPD, doctor is there, they need some form. diagnosis. They have to do some tests and they are searching for the form. Today it's here, tomorrow it's there. So while treating the patient also, the doctor has to keep on searching, right? Or the one who is bringing the form has to keep on searching. Same way with the medicine in the pharmacy also. Today you keep one drug here, tomorrow your supervisor says, no, it should be kept there. So these things should be fixed. Whatever item that you find is essential for your workplace, once you have identified that one, you have to keep a place with a proper labeling and storage. Some pictures just for you to see. Shadow board for medicine in the wards. Before it was kept like this, after it became like this. So which one is easier to work for? In the OT also, in any department also. Next, after you have labeled everything and you identify the place, you have to shine. You have to keep it clean. Cleanliness leads to identifying the errors before it occurs. So cleaning is an important part, which should be part of it's not the housekeeping alone. It should be a culture developed for each of the staff for their own workplace. Standardize. Now, after the 3S is done, you have to standardize it. It's not a one-time activity that you do a sorting or you do a shining for one day and then next day you forget about it. So in order to make it a standardized procedure, you have to create maybe a policy, a SOP in place, which you have to follow diligently. Like cleaning. In my department, suppose, every 2 weeks, every 2 days in 1 week. So Monday and Friday, example. So that is designated. So that is standardization. Standardizing in such a way that you follow it every day and becomes part of your culture. So after 5S, there's something how it should be. Your department should look. You can see the labeling is there so that this particular equipment is not moved. So every item will have their own labeling, name of the equipment or the place where they're supposed to be kept. So I'm not going to, it is beyond the scope of this presentation. I'm not going to go much into detail, just giving a quick appetizer and I'll show you an example. And sustaining is the main challenge. You can do it for one time, but to sustain the same 4S, it's a challenge, okay? So there are ways to sustain it, which will be done in the other trainings. So this is the summarized 5S for all of you. If you want, I can share my PPT also. So one hospital in Dubai, they did 5S for their pharmacy. I took this one example. It's not from India, but I still took it because they have done it very nicely. You can see the percentages, the improvement in terms of percentages, organized by 217%, orderliness increased by 800%, dramatic increase. Same hospital again, efficiency gains after they've implemented 5S. What happened with them? Outpatient medication retrieval time reduced by 50%, inpatient time retrieval increased by 40%, reduced by 40%. So these are the evidences that they have found during the study in the hospital after implementing 5S. And this is something how it looks like. Before, after. So in the part of the 5S, they have identified the ways also, team moods ways, which I've discussed earlier. So you can see the before and after and what are the improvement that they have received from each of these with the pictures also, showing the differences in the achievement after implementing 5S. Main challenge is with the senior staff again. Okay, the more senior you are, the more resistant you become. Unknowingly, not that, I'm not saying the senior staffs are the villain of the hospital, but unknowingly become, even for me, once I become a little bit senior, because I am used to a certain side of procedure. Example, we all, suppose, let's say we're all right-handed and we eat from the right hand. Suddenly they say, oh no, as part of 5S, you have to eat from the left hand. Generally, resistance will come up. So, but we have to, in quality or say in making changes in the process, creating efficiency, we have to adapt with the changes. We cannot say we have always done it this way since time immemorial, since 1960 we have been doing those things will not help us achieve the change or efficiency that we are looking into. Now, for the last part, just an exercise. Any volunteer, 2, 3 of you, you can raise your hand. I'm not going to call you in the front. Any volunteer? 1. Okay, 1. Any more to add to her? One, maybe. Okay, two. Okay, we'll start. Okay. I'm not going to invade into your privacy, but if you feel I'm invading, you can stop me. You can take out your phone. You can go to your gallery. Go to the screenshot section, because photo, when we take with the camera, when we click, it's for an important occasion, right?
5 minutes.
For important things. Okay, last part. So go to the screenshot section. How many pictures are there in total? Can you see the number? 236. Okay, then the next one. 599. Now, which one is not important? Because when you took the screenshot, you thought it's important, but it's been lying in your phone for a long time and it's occupying the space. Now, that is part of 5S. You can understand that way. Sort. You have to delete which is not required. Now, for you, everything looks important, but invite one of your friends who can look into your screenshots and ask them which one do you think is not relevant for me or will not be helpful. They'll help you. And once you start reducing, selecting, and then deleting it, you'll find that space is increasing. You're not investing money. You're just doing the exercise by yourself without investing any money, but the space is increasing. Your phone efficiency, the speed will increase. Right? So that is about 5S. So before you do it, it's called as a before, as is, current state. They have got different names, and after you do it, it will call us after, to be, and future state. So this is a very quick example of how to understand 5S. And this 5S activity, which I've just shared with you, is not one time, right? Every time, maybe once in a month, once in a week, you keep checking your phone and deleting, which is not necessary for you. So that sustaining has to be done. Okay, thank you.
Thank you, Mr. Kiki. A very nice deliberation on setting up efficiency in pharmacy workflow. So especially your detail and I should say evidence-based discussion on the impact of 5S in workplace management, which is a basic lean methodology. I come from public sector. It's a well-known fact that we have a very systemic and inbuilt tolerance for waste. But for the private sector, I think it's almost fatal. They should have a zero tolerance for waste. So in that context, from your experience, what is the most common workflow gap in hospital pharmacies that contribute directly to inefficiency and avoidable cost?
It'll differ from hospital to hospital.
From your hospital perspective.
Okay, my hospital perspective, like I've shared, we just had the training and we just gave an update on the staff, how to do it. So as you can see in the slides that I've shown, motion waste is there earlier. They have to run around a lot of, around the pharmacy to keep the things, search for the things. So motion was one of the main concern because proper labeling was not done. So everything was manual, and that will not be the only one, but that we found was the main, one of the main ways.
This relates to implementation of 5S. So now we open the question for the House. Anyone? Anyone would like to put question to?
While you are thinking for this question, I'll just share with you what Dr. Babu has shared earlier. Caho is organizing this kind of trainings, 5S, lean management, quality tools. So if you're interested, very minimal cost, you can attend the training and you can understand the concept in detail again. Yes. Anyone has a doubt?
If not, okay, I think everyone understood. Okay. So please go back and implement 5S in your respective work of management. So thank you once again.
Okay. Thank you.
So now we have our next session, that is technique to fix the leak in inventory management. And the resource person will be Dr. Jit Patwari, Managing Partner, Pinnacle Healthcare Consultant and Zonal Chairperson. I would like to add more about Dr. Jit. He has been collaborating with State Health Department. In fact, we have done multiple number of trainings on the quality assurance. And he's helping us to do baseline assessment in all the public health facilities. They have submitted the reports, and we are very thankful for his contribution. Little more about his profile. He's a program director for executive program on healthcare management at IIM Shillong and Caho. I think one of our colleague in DHSMI also has completed this course under the guidance of Dr. Jeet. He's advisor to the board of directors for many hospitals, have worked extensively in government hospital, corporate houses, and United Nations. He has written 3 books on healthcare management. We would like to know what those books probably we benefit for the house to learn from those books. And being awarded the most valuable resource person by IIM Shillong for SHCM program. In fact, greatly valuable to State Health Department. So, Dr. Jeet, the floor is opened for you.
Yeah, thank you, sir. Good afternoon, everyone. May I request the chairperson's something? My allotted time is 20 minutes, right? Or 25?
30.
25. Okay, so I request the chairpersons to start the clock after 10 minutes. Okay, anyways. But before that, let me tell you, I was working in Hyderabad, Delhi. I used to work for very big clients. Then I thought, what am I doing here? Let me go back to Northeast. 2007, I shifted. This should not be counted. Okay. Then I joined UNICEF in Assam, and then my eyes opened actually. What is healthcare and where we are? There was nothing, almost nothing. You talk about healthcare in the Northeast, except for a few cities like Guwahati, Shillong, then Dimapur, Kohima, Imphal, Aizawl. Rest is not there, almost. People still, have to travel a long way to get the basic healthcare facilities. Now, that is why this kind of program, the Jeevan, is very, very useful for these smaller hospitals and the mid-sized hospitals, where Dr. Babu has given an elaborate detail about how it works and who are the target audiences for this particular program. Now, basically, I'm a teacher. I teach my subject in different universities, and also I run a program with IIM Shillong. So when I go for a lecture, this thing is very slow. Now, this inventory management, leakage, what do you mean by leakage? It is not something like this, somebody trying to steal something and run away from your hospital. It is like a water bucket where there are a lot of leakages. We will see how these leakages work. And being a teacher, my lectures are always like this, And Pramod called me a few months back, Dada, we want to do it on 21st of February. I said, done. And he has given me a mandate that I should be doing something like this. I said, I'm the last one to do that. He's smart enough to put something like this. Now he wants me to go through the entire this thing, a tortoise being converted with a rocket speed. So if at all, I'll try to be a bit on the fast this thing mode. If you do not understand or fail to understand few concepts, please accept my apologies. Fault is not mine, fault is Pramod's. Now, when we talk about inventory is basically a pile of stocks. That is the first thing that comes to our mind. Pele has given a very important aspect in terms of the 5S in the pharmacies. And his first slide where that female was, sitting before 5S, my good friend Babu was asking, is it his? room in his residence? I said, I don't know, I have to ask. Okay, now I'll give you 3 stories. The first story where the hospital was very busy. Now, their hospital was full, but the margins were empty. This is what the corporate hospitals would always look at. The OPD was having long queues, IPD was high occupancy, and OT was full in schedule, but the cash flow was tight. This is a real example of one of the hospitals which I encountered in Assam. We'll see the details. What are the silent losses and what are the other things? Now, the second one was a quiet hospital that survived comfortably. Number of beds was a mid-sized hospital, just above the SHCO. 50 to 60% occupancy, 2 OTs operating regularly and financially rock solid. Discipline was patient lead consumption, all those things were there. The control was tight, very tight. The third hospital, an integrated, a high-end, like the hospitals where Dr. Babu works, Dr. Hirak works, Dr. Seema works, and even Dr. Pramod works, and my good friend Pele. Now, this hospital is built on systems where everything that comes in, the patient enters, everything is documented and placed in the respective slots. Now, mapping every rupee that comes in, kindly do not misunderstand me, not the concept of this or the operating model in this hospital, because financial planning and the accounting has to be there in every hospital, whether it's a trust hospital, whether it's a private hospital or government hospital, because every single penny counts when the accounts manager or the finance manager has to produce the balance sheet. Your discount amount can be huge, but every single penny should be there. The system which was there, closed loop tracking, live dashboards. If at all I want to find out what is happening in my hospital, my dashboards will easily speak. So training of the staff was good, visible inventory and data-driven decisions. Now, what were the key results? Number one, the wastage was less. Don't go by the red color bin. It is not the biomedical waste, but the common wastage I'm talking about. Stockouts were less. Billing accuracy was there, and so the EBITDA. EBITDA was the financial parameter that we consider. Now, in this case, we see that the process-driven growth was there in hospital number 3. Which hospital would you like to, if at all you have to grade, which one would you prefer? First one, second one, third one? Third one? In terms of preference, it is 3-1-2 or 3-2-1 or 1-2-3, 1-3-1, whatever. 3-2-1. Okay, fine. Now, the lesson that we learn from 3 is integrated systems turn inventory into strategic advantage. Now, why this is there? Full OPD, still the hospital was bleeding. Bleeding in the sense that in terms of finances, there was no control in case number 1. In terms of OT, utilization was very high, pharmacy was very high, sales, still the inventory leakage somewhere was there, which led to the hidden money being lost in the hospital. And revenue is visible, leakage is silent. Okay. Now, why leakage is very dangerous? Number one is high consumable dependency. The entire hospital, if you look at all the departments depend on some sort of inventory or the other. The thin margins, nowadays competition is very high, so the margins are very thin. Until and unless you use spurious medicines, even the branded ones will have very less margins. Many pharmacies would operate on a very, very less margin. Pramod, is it going to work? Thank you. Then the many hospitals operate on a manual process. They do not have an inventory management system in place, and that is why there's no accountability. We do a lot of consulting. We were doing in North Bengal, a hospital. The CEO says, the chairman said that, Jit, we are doing quite good, but our growth is very, very stagnant. Our parameters are increasing, but the financials are still, reaching out, going by a plateau. We want to do a financial analysis. I said, why do you want to do financial analysis? You will see that the revenue is on the higher side, your expenditure is again on the higher side, and your margin is on the lower side. I suggested do a process mapping and process audit. And when we did the audit, the entire thing came up. Now the chairman says, I want to fire my CFO and my CEO. Real. I'm going to submit the final report in the coming week. Now, why that leakage is there? Now, there are few myths which are there. Myth one, stores responsible alone. Is it? It is not. There are more to add, that software solves the problem. How many of you agree with this, that the software will prevent leakage? How many of you do not agree? Rest are neutral. How many are neutral? Okay, anyways. See, software is nothing but an automation of the manual process. Until and unless you have the manual process clearly defined, you convert it into automation, you'll have more problem. Not going by or anything against Maruti, but if at all you drive a CVT or on a automatic vehicle, CVT or DCT, and you drive an AMT, auto manual transmission, you'll find the difference. They have transformed into a low-end kind of an automation, which is very, very difficult. Now, the third myth is that leakage means theft. No. There are, but not all leakages would mean that somebody is stealing. Systems create these leakage. System gaps are there. Now, this is especially for the females. How many of you operate your kitchen? Can you raise your hands, please? Not like this. How many males are responsible for maintaining the stocks in the fridge? Babu is laughing. Maybe you manage? Due respect to madam. No? She doesn't allow you? Oh, you are not there. Okay. Okay. So what happens is, don't reveal it in front of my wife. Okay. My wife wanted to buy a fridge. Already she got one during our wedding, our marriage. She wanted a double door. I said, what for? No, once in a while we have parties and where to put the extra food, the surplus. I said, for 3-4 parties in a year. For that you are going to spend so much? No, that is very useful. So she got a very big one. Now, if you look at, on the right-hand side is the fridge, normal, 2 to 8. On the left-hand side is the minus. The entire this thing is minus. The other day, I opened the door. I could see some fish and some frozen food. And also with that, just to, keep it, that something has been kept. I saw some imli, some powder, something or the other. Those are not required. Similarly, in hospitals also, when we procure, we have a tendency, the more we procure, the more would be the benefit. People who manage the fridge at home, I sometimes do. This is overstacking. Yes? Which would lead to something like this. How many of you have opened in the last 7 to 10 days, have opened the lowermost basket in your fridge and found some about to be rotten or maybe some dried up vegetables or fruits? No? I have done it. I have found. Now, this is something which is going to pay you. This is a very well organized fridge, maybe at Babu's place. I would like to have a photo. Anyways, now where inventory starts? It starts from where the patient enters the hospital. And inventory allocation in the different departments, even in the reception also. The forms and the consent forms. Babu has given a very nice explanation of forms. Pele has given about the medicines and the consumables. And all these are to be aligned to a system. Now, inventory leakage mapping, if you do, the entry leak where receiving errors, vendor discrepancies, many a times we do not do the GRN. Directly goes to the hospital pharmacy and goes out. People who are operating with Cheki, 10 minutes or more? More, okay, fine. Now, people who operate a cath lab, they would see that most of the stents and other things go directly to the cath lab. Many pacemakers directly go to the cath lab, or I mean the operating room. Orthopedics implants, they directly go to the OT. How many of you agree? I agree. Be honest and let's be fair. How many of you agree? No? Agree, madam? They don't go directly to the OT, many hospitals. They directly go to the OT. Those are unaccounted. Those are small leakages. Okay. Now, pharmacy leakage points, non-billed issues. Many a times the pharmacist forgets to issue the bill. Open access stock. I can take out an item and give it to you. No. The presentation here, when we teach at IIM, we teach at a very high level. Since the crowd is mixed here, I'm trying to make it or keep it very, very simple. Opening kits. One kit can cater to 10 patients, 10 samples. Even for one patient, I have opened the kit. Usually what the laboratory does, right from the morning, if they start collecting the samples, they start the processing when the samples reach around 10, 12, 15, 20, so that the kits can be properly utilized, which will minimize the cost to the hospital. Then the surgeon's preferences, at times, non-standard consumption patterns. You do a pharmacy audit, you try to find out a lot of unused item for the last so many years or so many months. Where from they have come? This doctor had advised and the prescription bounced. The patient complained, so the doctor said, these are to be there in the pharmacy. After 2 weeks, he started prescribing another medicine. So that has gone to a non-moving item. Okay. Now, ICU leakages, emergency consumption, the first aim is to save the life of the patient. And at times we forget what we were using during that particular time. Then missing tracking. You missed the track. You tried to use the required medicines and consumables, but you forgot to keep the track. This happens usually when you cater to 3-4 patients at a time. You don't know. It gets mixed up. This is not intentional. Now, informal borrowing. How many nursing professionals are there? Can you raise your hands, please? Okay. How many of you have done, hey, I don't have this. Kindly, can I borrow? I'll replenish it in the next shift more. How many of you have done it? Yes. After that, we forget. Then, no accountability. Nobody is bothered who is getting what, who is supposed to get what. Then the procurement leakage, vendor-driven ordering. I prefer a particular vendor, so entire this thing goes to him, and he pushes I had ordered for 100 units, he has pushed 300 units. Paisa baad mein dena, but you have to give. Then overstocking. I have seen the refrigerator. No FEFO. First in, first out. This is first expiry, first out. So what I do in the fridge at times, I don't take permission from my wife. I don't know about yours. What I do is I open the fridge, see which are the items that has the skin has shrunken or something is there. Pull out those items, keep it. Those are to be used first because that is first expiry, has to be first out. Similarly, in case of medicines and consumables, do a short expiry estimation periodically and then pull out those medicines. And poor rotation, inadequate stock rotation practices. Stock has to be rotated. It should not be monotonous that this has to happen every day. Now, inventory, no consumption analytics. Now, software, if at all you use a proper software, you can track from placing the order to the vendor, GRN, going to which pharmacy or central store or which outlet, to which patient it has been given, at what time, by whom, and taken by whom. All these are to be mapped, can be mapped. Now, root cause revelations are manual systems. This is the leakage engine. Like a train, the engine pulls the entire compartments. Now, your entire inventory, if at all it is manual, this is going to add to your leakage. Now, billing integration failure. These two are symbolic in terms of the gear. Sorry. These are the gears which are to be plugged together, and then only it will rotate. And there is a gap. You do not see any integration between these departments. Then human behavior drivers, safety bias. I do not want to have a stock out. Stock out means empty stock. So I have a tendency to procure extra. No. Then stock hoarding, departments maintain personal reserves. This is again very, very dangerous at times. Then this is the invisible gap model where you procure, store, usage, and billing. Now, many hospitals, what happens is due to this, the factors defined or discussed earlier, they fail to do the procurement is okay, storage is okay, usage is also okay, but they fail to do the mapping, and that is why the billing is not done. Not intentional, but now if at all I am confused, now whom to bill? And there is more. Dr. Babu talked about the medico-legal this thing where we are treated as the service providers and the patients as the consumers. Now, if at all my prescription and my bill doesn't match, my history says something, my bill says some other medicine being given. So if at all I am the person, what I will do is I'll try to play safe. I will not bill that particular medicine, but it's a loss for the leakage for the hospital. Now, what are the consumption model? You issue, then use, record what is there. If you're using a software, this will automatically get billed and reconcile. If at all you need to do, you do that. Now, this is the consumption to revenue mapping. You map each and every item and track. Corresponding billing code has to be generated, then automated revenue capture. This happens in the software or the HIS, HMIS, whatever you name. Always categorize your items into ABC. ABC items, high value. But you need to have a very tight control. Then B items, moderate value. C items, low value. Basic tracking you can do. Now, VAD is vital, which is very, very essential or for the critical care patients, then are very, very vital, then essential, and the third one is desirable. We do not categorize this. So whenever I'm taking an item from the shelf where this categorization is done, I would be cautious. Okay, no, this is a high value item. During emergency, I forget everything. My main focus is on the patient. So in this case, these analyses are to be done.
2 minutes more.
How many? Okay, I'll skip this then. OT kit standardization. At times we do not do this. Then practical examples, zero cost process fixing. Closed indent system. Do it with a proper documentation and maintain an issue register. Low cost technology, even Excel dashboards are helpful. Then barcode applications, if you are going a bit a step forward. Then annual audit is very, very important while taking this. Then automatic compliance, behavioral control design. Our staff has to be trained how to design this and how to avoid the errors. Then the governance model, inventory committee should be there which should meet periodically, and these are to be analyzed. Transformation roadmap, this is a 30 days blueprint. How you select top 50 items which are there in your stores or pharmacy. Then third and the fourth week, do a closed billing loop. Try to track the procurement up to the usage. Then the 90 days would be on the long term, a slightly longer term, where you are doing an SOP rollout and then train the staff on the various aspects. Cultural shift from control to ownership. Like the previous picture which I had shown, all the things were scattered. Now people should have the ownership of the items, whatever they use, whatever are there in the stores, so that they do it in a very systematic manner rather than keeping it haphazard. Now ask the audience, is that your audience is the different employees in the hospital? Where are the holes? There are some NABH aligned standards and objective elements which are, the medication safety, traceability, and the documentation. So try to follow that. Then financial impact. Inventory alone, if properly managed, can save 5 to 10% of your entire revenue. The leadership is very, very important in this. The final take is, great hospitals do not earn more. They earn or they leak less. Thanks for your patient hearing, and thanks to the chairman for giving me the opportunity, giving this extra 2 minutes, I guess.
Yes. Thank you, Dr. Jit. I think he neither go at the total pace or the hair's speed, but he has learned how to adapt to Shillong traffic, right? So anyway, we'll open the floor for questions. Any question from the house?
If at all you have any questions, I would be happy to answer. Sorry, I'll try to answer.
I think
if at all I cannot, I can pass it on to the learned other speakers as well. I have that tendency.
Or if not, I can draw a parallel comparison, because I'm coming from public sector. This topic is very important for us. And I'm being the state nodal officer for biomedical waste management. So in 2024, we are directed by NGT, Honorable National Green Tribunal, because Meghalaya, Assam, and Tripura are the non-compliant states. So we had to prepare a compliance report, and submit to NGT. And a horrifying statistic came out. 444 tons of expired medicines had to be dumped, fresh ergati, dumping yard fresh ergati. And if you do economic costing of that, say per ton, it comes to roughly 10 lakhs. So approximately around 50 crores worth of cash we just dumped. So that's a glaring example of poor inventory control. Probably in the past, we had to base our inventory management on paper. But now with the adoption of Maghalayan medical drugs, MMDSL, so now everything is digital, right from procurement, distribution, forecasting. Of course, I believe in the next 5 months, they're going to add one more feature that is predictive analysis. So this tool, because I think what I say is relevant to the topic he has discussed, technique to fix the leaks in inventory management. So technique or tools are similar in concept. So we have adopted a software wherein the distribution, the indent is complete digital. And in that process, we are saving, we are reducing our wastage.
Yes. Should I add on to what you have said?
Yes, please.
I did not want to open up, but since Sir has already mentioned, few of the photographs I have changed, but we did a project on assessing 8 government hospitals. Dr. Gitata was also in the team. So many things which were shown were common in those hospitals. I did not use the original pictures, maybe because it might be somebody's hospital, so that it is. I did not want to pinpoint, but the excess medicine and the consumables which were there, it was huge. And at times, what happened was the medicines which were required in that particular locality, those were not there, and in the stores, something which is not required are stored in those boxes.
Yes.
Those would definitely be in the long term. That will be wastage only.
So anyway, that is the past, but now we are transitioning to that new system.
Yeah, definitely, we would be happy to see that transition. Same in Assam also. When we did the same, this thing came up.
Okay. Anyway, thank you.
Okay.
We close the session.
Okay. Thank you so much.
Thank you so much to both the chairpersons and the speakers. Both the speakers have spoken so well regarding inventory control, management, and fixing those leakage. Before we begin with the next session, may I now request Ms. Maureen C. Rani, the DNS of Nazareth Hospital, Shillong, to kindly come forward and felicitate our chairpersons and speakers. First, I call Dr. R. Posnam to kindly come forward and receive the memento. Next is Dr. Cheki M. Pochna. Dr. Cheki M. Pochna. Next, Mr. Pelezo Pius Kiki, kindly come forward. And Dr. Jeet Patwari, kindly come forward, sir. Thank you so much, Sister Maureen. I request all the dignitaries, the chairperson and secretary of the previous session, Dr. Posnam, Dr. Cheki, Dr. Kiki, Dr. Jeet Patwari, kindly come forward along with Ms. Maureen C. Rani for the photograph session.
My cupboard is full of mementos from Nazareth Hospital and GNRC Hospital. Anyways, thanks. Thank you so much.
Now we will move to the next session, the third session, that this will be a panel discussion on infection prevention and control for small healthcare organizations. For this, may I invite the moderator, Dr. Michael Maulong, to kindly come forward and take a seat in the dais. Dr. Michael Maulong, he is the MD Micro Fellowship of General Infectious Diseases, CMC Vellore, Lab Director and Head Clinical Microbiology and Mycobacteriology, Head of State Referral Lab for Tuberculosis. He is DRTB Committee Member, State Medical Expert Committee Member, and HICC Chairperson. Sir, kindly come forward, and Sir will introduce the panelists as well as lead with the discussion. Sir.
Thank you so much for having me again. As Dr. Jeet has said, my shelf is also full of mementos. Huh? None. Anyway. So anyway, thank you so much everybody for attending this session. I'd like to invite the experts. First, I'd like to call on Dr. Seema Kaur. Is she here? Yes, ma'am, please, kindly. So, Dr. Kaur is the Medical Superintendent of Apollo Excel Care Hospital, Guwahati. So she's the Joint Secretary of AHPI, NE1. She's a medical administrator with more than 15 years of leadership experience in hospital operations, quality systems, and governance. She's motivated and passionate about improving the healthcare systems in Northeast India. Now, I think this is something that all of us should be passionate about. Okay, Northeast lags in healthcare. Okay, particularly places outside of Guwahati. Guwahati is still a lot better. So this is something we need to. Thank you so much. Next, I'd like to invite Dr. Papia Chakraborty. Please come, doctor. So Dr. Chakraborty is a clinical microbiologist, come in charge, come infection control officer, Woodland Hospital, Shillong. She has more than 10 years of experience. Her expertise is in bacteriology, virology, mycology, parasitology, antimicrobial resistance testing, and infection control. She has a strong interest in infection prevention, hospital-acquired infection surveillance, academic research, and clinical correlation of microbiology testing. Thank you so much. Last but not the least, Dr. Ajay Thakur. He's always willing to come and join us in our programs. Thanks so much. Thank you. Please. So Dr. Thakur is a registrar, general surgery. He passed out from JIPMA, Chandigarh. He's an MCH in plastic surgery, again from Chandigarh. He's a consultant plastic surgeon at Woodland, as well as in Supercare Hospital. So he's a faculty to many national and regional programs. So thanks again, all of you. I hope we have a fruitful session. It is almost 1 o'clock. All right. I will try and speak for half an hour, not just me, I mean, our guests out here also. So everybody will be hungry, I think. So we'll try and wrap up fast. I'll try and squeeze in 3 questions each if I can. It'll probably be 2. Okay, so I kindly request you to restrict your answers to about 2 or 3 minutes. And please don't mind if, I feel it has stretched a little bit longer. I'll ask you to, in the interest of everybody, so that the other speakers also get enough time. So let's start off straight. So we have a hospital administrator, we have a microbiologist, and we have a clinician. These are the 3 perspectives that we need in infection control, okay? So simple questions I'm going to ask. We want to know what are the answers in a small setup. So the first question is to Dr. Ajay. We know that surgical site infections are a problem. We don't report them, but they are there. Okay, that surgical site infection may be a small surgery, maybe a big surgery, PHC level, CHC level, referral hospital level. So how can IPC protocols like surgical site marking and hand scrubbing help? Because most of the time they are ignored. You see, so how do you convince a surgeon? 5-minute checklist, less than 5 minutes. Is this ready? Is this okay? Is this okay? Is this okay? Is it the right side? Is it all those checklists have to be done? What is your perspective in it, Dr. Ajay?
See, as a surgeon, I would never want my patient to get an infection. So any surgeon worth his salt will definitely make it a point. But then as you become senior, like previously mentioned, you become a little more stubborn. You don't want to change your views. You don't want to change the way you are doing. So it becomes a little bit difficult. Younger surgeons, it's easier to convince even the staff, the sisters. They can request them. But the senior surgeons, I would like to do like this, and he would not like to change. So regular programs kind of they feel a little bit apprehended, or why you are telling me this. I'm too senior. So ego is something which we have to deal with. I think most of the sisters would agree to that. So regular kind of programs which concentrate mainly on this safety protocol, rather than advising a surgeon what to do. It could be like a dialogue which is you are made to realize that 5 minutes you can always spend, which will not result in a longer hospital stay. 5 minutes will cost you another 5-10 days extra because of skin infection. Though personally, at my personal level, it has never occurred. In routine surgeries, we always make it a point and to wash our hands, maintain all the sterility, and we have a clock where we wash our hands. So and we have those printouts at every nook and corner, wherever we have a washing, hand scrub or whatever. We always keep on educating. So the idea is to bombard that, reinforcing it again and again, not just catching the person and why you're doing this. You have those kind of pamphlets, reminders everywhere. Yeah. And I think now most of the surgeons have realized that hand washing techniques, sterility techniques, and these come under safety protocol, rather than you are advising someone or ordering someone. Surgeons don't like, they have ego. Yes, you have to agree that.
Sometimes you have a larger than life surgeon, big person, very famous.
Yeah.
How would an administration deal with that? Dr. Seema, do you want any take on this? How do you deal with these kind of things? These are, we're just discussing, please, okay? There's...
Well, when it comes to, compliance, it's not coming. Is it okay? So when it comes to, having a compliance from the senior people, definitely it is not so easy. But we really have to look into that, we have to make them understand by, with datas and all. Unless you have evidence, it is all evidence based that you need to tell them. We have the KPIs, the indicators are there that we need to look into. Say, sir said about the surgical safety, those 5 minutes of the WHO checklist. Like when you go and tell them, see, this is your surgery and you haven't done here, this is what is supposed to be done. They are somehow aligned. Let me tell you, they are not averse to good rules. They are aligned, but it is how you take that thing to them is so very important. I mean, you have to keep their ego intact. You have to keep, you have to respect them fully. It's not that you cannot go as an administrator directly. You have to be with them, put them into your unit. Then only things happen.
Two things. Communication skills.
Yes, very much.
Second is data.
Yes.
You must have data. Collect your data. That is important. Thank you. I'll go to the next question. This is for Dr. Papia.
Yes, sir.
So what are the cost-effective infection control strategies for small hospitals? The problems we have MRs coming from big companies, from Johnson & Johnson, from this and that, buy these expensive chemicals. Now, do we actually need them? Could you please share some?
So we do not really need very expensive chemicals as disinfectants. We do not need to be carried away with the MRs because some of the representatives are bigger than us also. So they tend to intimidate us into taking things because they've already met with the management before coming to us, and we always have a pressure. But here also data always suffices. If we have that, in a general ward we do not really need hydrogen peroxide or a high level disinfectant, and we go to the management that please do not pressurize us to accept something which will cost you in the long run. So we go ahead and use a cheaper disinfectant like sodium hypochlorite for the general wards, and we can always go for a chemical disinfectant for OTs. And first and foremost is categorization of the whole hospital, zoning of the hospital. Depending on that, what will be required, we will decide accordingly. But we really do not need to be carried away. As you know, we can always minimize on the cost that the hospital has to bear. At the end, if a proper infection control team is there, the entire top, like you just having a disinfectant, changing a disinfectant doesn't really help. You have to have the entire team who understands what they are doing, and there are people there who are assisting the grade 4. There is a kind of scrutiny how grade 4 people are people who do not really have that much of knowledge of how to get the proper concentrations and how to do the things with the disinfectants. They don't know what is to be used with. So they need assistance from us. It starts from the team and it goes down onwards. So we dedicated people for the entire thing. It is not the disinfectant which matters, it's the process. And in that way, we can decrease the cost that the hospital has to bear. And as Dr. Jeet has already said, leakage in the system is not only for pharmacy. It is for these disinfectants and sanitizers also. A huge cost of the administration is borne by all this. So if we are particular with infection, the percentages of disinfectants, even a simple disinfectant can do wonders.
So in effect, please do not think that just because it is a big international company, that means their products are good. Don't get carried away by that. Okay, that is the first. The second thing what Dr. Papia is saying is attitude is what matters. If you as nurses, if you as housekeeping staff, if you as doctors, if you as paramedicals are willing to actually take that extra step for basic things, hand washing, hand rub, nothing else, you don't need more than that, it is more effective. Lastly, every single hospital you will find that it is actually the housekeeping staff who are the most compliant. Once they are taught, once they are explained, they are the ones who perform the best. The worst are the doctors, okay?
Yes.
Nurses in between somewhere out there. But that's what normally happens every year. You want to say something else?
So actually hand hygiene is the best. And the compliance in Indian hospital as per WHO standards, it's even in the best of the hospitals in the metropolitan cities, it's only 40%. And who are to be blamed? It is the doctors.
40%, you can improve by another 60. That's a huge
Which
thing.
training will take it to 100? God only knows, sir.
100 is expecting a lot. I mean, it will be good, but I don't know. Next question is for Dr. Seema. So NABH standards, they suggest one ICN, infection control nurse, for every 100 beds. So in a small setup, would it be possible? Because see, a lot of hospital administrators, or not just administrators, owners, they want to squeeze as much as possible from every single employee. So putting one ICN who does just that, infection control, not looking after patients directly. What do you have to say of that? Is there a way to use them more effectively?
Yeah, for this, I think absolutely it is required. Like ICNs are required in the organization, whether it's a small organization or a big organization. Of course, it is the scale and the capability that you can put on the manpower sanctioning. That is what says, but standard wise, as you said, for 100 bedded, you will keep at least one, right? So it goes to what Dr. Jeet had said, you have to stop the leak, right? So when you talk of the ICN is not a non-productive staff. It is a sort of revenue protective officer. So that is something very important. So the moment you keep an ICN, and they, they will be monitoring all the infection control measures, because if there is more infection, if there is infection, in fact, then what happens? You lose on revenue. It's not that you gain on revenue, because you are losing on the bad days, which you may have given to a new patient, right? You could have taken a new admission, Because the longer a patient stays, it doesn't mean that the hospital gains, the hospital loses. The hospital loses in terms of manpower utilization, it loses in the terms of, utilizing a lot of high-end antibiotics. So it loses on many things, like most important is the trust, the faith, and the reputation. So that's very important. That, of course, what you said is ICNs, like, we need to have the link nurses. So by that you can distribute the work also, and they also are part of the education part of it, nursing education. And of course they are a team in the antimicrobial stewardship program. So a lot of activities can be clubbed together for an ICN in small setups, where maybe in a bigger ones, these roles can be given to separate individuals.
See, the thing is that what we must understand is in health, we have two aspects: preventive and curative. Most of us concentrate on the curative aspect of health. Preventive, the only thing we usually refer to is vaccination. Preventive. But infection control is probably the biggest preventive role that you can have in a healthcare setup, including a PHC. If there are those people who are working in PHCs, do not please underestimate the importance of infection control. If you're a single nurse in a PHC, you become an infection control nurse, you become a nurse, you become everything rolled into one. And the only thing you really need to take care of is actually hand washing. That's all I'm telling you. It will make a big difference to your practice. Thanks, Dr. Singh.
That's very true.
Next question. Let's hope we have enough time to even get 3 questions each. So, Dr. Ajay, see, given the thin margins we have in a small setup, okay, there is often pressure to reprocess single-use device. You're supposed to use it once, but it's costly. Patients can't pay for it. So we have to reprocess them. A lot of hospitals do it. So my point is, what would you select first thing? And second thing is, when do you decide that, reprocessing beyond once, twice, thrice, that becomes negligence. It's no more trying to help the patient. You're trying to help the patient, but there is a limit to how much you can help one. Okay, what are your views on this?
See, from first speaking from the medico-legal aspect, if equipment is marked as not to be reused, we are not supposed to, first of all. But then, okay, we are working in a small hospital where it's not possible to, so maybe certain things we can reuse, maybe once or maybe twice, but those, items are very limited. There are certain very critical items like catheters, cardiac catheters, or Fogarty's, which go deep into the patient's crevices or whatever. Obviously, we cannot reuse it. We cannot autoclave it. First of all, the products which are made of heat labile products,
Plastics
plastics,
like that, yeah.
you cannot autoclave. Okay, if you can sterilize it through gas, like ETO or plasma, very few products are there, very few products. But certain things like implants, for example, ortho implants or even plastic surgery, any implants, we cannot reuse it at all. In fact, if the chances of litigation goes very high. There are only few things which may be used externally for the patients, like certain metallic trocars.
Harmonics, for example.
Yeah, and external fixators, orthopedics. But most of it, I think you should refrain, because if something goes wrong, you cannot say, oh, I did for the best of the patient. Because in the court of law, no one will protect you. You are not supposed to reuse it, so you cannot. So certain instruments are, like certain trocars have lots of holes, which you can't clean. Physically also, you can't clean those trocars with multiple channels. So basically, any equipment which you cannot physically clean, they are likely to develop what we call as biofilms, that even when you autoclave, it's not going to sterilize it completely. And God forbid something goes wrong, there's no one who's going to protect you. So I would suggest to refrain from using, except few like external devices, like I said, external fixators, and mainly those things, external fixators. Anything that goes like implants, going deep into the bone or into your heart, or any interventional items like those balloon catheters, angioplasty. Obviously, you cannot, because they are not metallic. First of all, they have lots of crevices, holes and channels. And secondly, if you heat sterilize them, the integrity goes. So just imagine if a angioplasty catheter balloon ruptures inside the coronary artery, so you are in custody. So no one is going to protect you from that.
Actually,
So
this
we
is a
should
problem.
refrain.
It is a
as
problem
much.
because there is no legislation for it as such
Yeah.
in India. But NABH says that you can come up with your own rules for reusing something. So generally speaking, the commonest equipment, correct me if I'm wrong, would probably be a harmonic.
Mhm.
That is where we actually reuse it up to 3, 4, 5 times, usually not more than that. Okay, places like CMC, Vellore, they have a very robust way of tracking how many times it has been used. If you can develop it for yourself, good. If your patients can afford it, good, use something new. But my basic question to a surgeon would be that you would ask, would I use that reused material in myself or not? If my answer is no, I won't use it myself, then please don't use it in any other patient. Thanks, Dr.
Yeah,
Ajay.
if you have any doubt, I think better not to use at all.
Better not to.
Yeah.
Next question I'll ask is to Dr. Papia again. Return of investment in testing. Small hospitals often avoid environmental cultures, okay, whether it is routine or whether it is actually required, okay, for whatever reason. What about sensitivity testing? This is a big problem. We'll discuss it a little bit, maybe in detail if we can. And at what point does saving on a lab test become a financial liability for the patient? Okay, let me put it simply. Hospitals don't like investing in costly antibiotic sensitivity testing machines. So is it a problem? Is it not a problem? Could you please?
So if you have a robust system of testing antibiotic susceptibility for a hospital which is medium size, we always have backups. We have two systems always. But for a small hospital, usually the investment is not there. Much support to the microbiology lab is not there. Forget about environmental sampling. But 2025, in a public health hospital in New Delhi, a study has come out by Dr. Purva Mathur, where they have come up that most of the environmental contaminants were the organisms which were causing the disease in the patients in ICU. And they were all multi-drug resistant. And most of the organisms were gram-negative bacilli, which is a problem not only in India, the world over. With WHO already coming up that, antimicrobial resistance is a very big problem. We don't have antibiotics to treat. So if we go through that study, which is in a premier institute of India, I'm sure we also can come up with like a similar study which will say the same things, that environmental cultures are very, very important. Even in a small healthcare setup, we can do something. The lag in sending an antibiotic susceptibility report will always be there for a small healthcare, because they will not invest in a high-end machine like a Malitov or a Vitek maybe. Most usually go for the conventional methods where we have a delay in reporting of 48 to 72 hours. We cannot do much about that if the management is not on the side of the microbiologist. But forgetting environmental cultures and not giving it consideration will be very detrimental for a small healthcare.
Okay. So the thing is, routine environmental testing, taking a swab from here, there, everywhere, that is not recommended anymore. Okay, except for certain places. There are exceptions. Number one is your OT. Okay, that should be done regularly. Air sampling at least. All right, you need to do that. So generally speaking, it is not required. However, another exception again is if you have an outbreak. You're getting blood cultures positive from your patients and you cannot find the source anywhere. Multiple patients, suddenly it happens. Then you need to swab everything and check. Now, the second thing which Dr. Papia has implied is that most small setups will have disk sensitivity testing. The problem is most people do not realize how much effort needs to go into that for quality control to get good results. It's actually far, far more difficult to do disk sensitivity testing than getting machine. With a machine, all your quality control is taken care of. It's much easier. Okay, so thanks, Dr. Papier. Next question. Let me see the time. I think maybe we can squeeze in one or two more questions. This is for Dr. Seema. See, most of our hospitals in Meghalaya, we rely almost completely on your MHIS. Okay, in our hospital, at least 90% of our patients are MHIS. Okay, so the question is, a lot of these patients come in fixed packages. Patient comes in, you will be treated for 1 week, 5 days, whatever. This is the package that you get. Now you get an infection, and then you have to stay for 3 weeks. The loss is to the hospital because MHIS is going to know we're paying you 50,000 rupees. Whatever other expenditure is your hospital. What do you say for this? Do you track it? Do you do all these things to explain to your administration?
Yeah, definitely. In this case, like when you go for Ayushman Bharat or any of the state health insurance schemes, the packages are, not too high. I mean, it of course depends on, like in smaller hospitals, the cost of your, say, for a surgery, your OT charges are lesser than in a bigger hospital. So maybe it suffices in a smaller hospital, but whatever said and done, that is a cost part of it. But when it comes to infection control, and when you say that due to infection a patient had to stay longer, definitely it is a loss to the organization. So how do we check with it is very important, because if we could have stopped that, we could have taken a new admission. That is one loss. One is, the bed days increases. The moment the bed days increases, the operational cost increases. That is also there. So what happens, it is important that we track the long stays in the hospitals. When we track the long stays, you get to know, like, the reason, whether it was due to infection or due to the course of the disease, or maybe some other thing was, related to it. So tracking the long stays are so very important here. Tracking the usage of the antibiotics, how much of high-end antibiotics are used. You can track it through the pharmacy also. Like in corporate setups, we have this clinical pharmacist. I don't know whether it is there in all setups or not. So our clinical pharmacist tracks it through the pharmacy, like how many indents per day of the restricted antibiotics had happened. So there, what it is also done in any of the consultants, if they happen to, prescribe any restricted antibiotic, they have to justify. So it is like, it is a tough time for them. When we started it, let me tell you, we had drastic, decrease of prescriptions of meropenem. It was just going rampant, actually. So this way, like, the cost of the treatment, for the patient also, cost of the package also can be checked. So all these are there. That's important. So readmissions are to be checked, readmissions and return to ICUs within 48 hours needs to be checked. So we check the readmissions within 30 days to the hospital also. All these may be related to infection control. So these are the checks and balances that we need to keep, so that we see to it that the patient is, getting the optimal and the best treatment that it should be getting.
Thank you. So the thing is, if you look at what has been discussed so far, everything, whether it is from an administrative aspect, a clinician's aspect, a microbiologist aspect, a nurse's aspect, or even a patient's aspect, most importantly, it boils down to being able to change your attitude towards infection in a hospital. Okay. So what can you do? Simple, most effective strategy. Anyone? Infection control. Most important, hand wash. 95% of your problems taken care of. Hand wash or hand rub. But for that, you need an effective hand rub also. Okay, not any hand rub. You have to be careful of the contents and things like that. So what is the time? I can squeeze one more question to Dr. Ajay, I think. Let me just... prophylactic antibiotics for surgeons. This is a problem. Okay, is a real problem.
The most controversial topic.
Yes.
Yeah.
My question is it an excuse? Extending antibiotic cover beyond 24 hours, is it an excuse for a lack in your technique?
Yeah,
Not
maybe.
yours, I'm just saying in general, in general.
When I was in PGI Chandigarh, we used to do major clean surgery, not contaminated, clean surgery. For example, we do TMAC, it's absolutely a clean surgery. So we used to give cefazoline, 1 dose, just at the time of induction of anesthesia. Second one, maybe after 8 hours or 12 hours. And third dose the next day. That is 24 hours. After that, we never used. That was a policy. See, in a government setup, it's a the HOD can call the shots, and then everyone has to follow. And we never used to have infection. Never means never. Even for a cholecystectomy, we used to give only 3 doses of antibiotics. One is at the time of induction, then next is 12 hours, and the third one is next morning, and we stop. We don't even give oral antibiotics. Okay, painkillers and all, okay, fine. Unless the patient is diabetic, immunocompromised, or there is some spillage or something. Clean cut cases, we never give more than 3 doses. When I came to Shillong, all my cases were getting infected. I used to follow that. But then my medical officers, they said, sir, why do you give only 3 doses? I said, that is the protocol. He said, forget your protocols here in Shillong. This doesn't work because everyone is using rampant, this antibiotics left, right, and center. I saw meropenem, colistin being given as if it's like.
I mean, that is worrying.
Yes,
that is really worrying.
So I think, I have seen some surgeons, not following strict, pre-op or intra-op protocols, and they'll say, "Koi baat nahi, antibiotic de denge." So, to what you say is, to an extent, yes, correct. But as a surgeon, I would definitely be scared of my patient getting any infection, because I cannot say, oh, so and so microbiologist said we have to give only 3 doses.
Now we are talking about the truth.
I'm telling the
now
truth.
We are talking.
Because I'm the one that have to answer to the patient.
Exactly.
So, but then to implement this, we have to implement safety protocols.
Yes.
You can't just stop antibiotics because someone has said so. Because we have to make a groundwork. We have to follow all these safety protocols, like in OT, even in the ward. Now we have got WISE. We implement. In fact, I'm one of the flag bearers. I go on scolding everyone, but then I cannot scold my colleagues. I can scold nurses, someone junior to me, but a senior surgeon, a senior doctor comes for rounds and he touches the patient here, there, and he doesn't. Who has the guts to say anything?
No, it's not easy. It's not easy.
That's where we usually have once a month or thrice a month. We have kind of a meeting regarding antibiotic, stewardship, what to use where, and we have distributed certain pamphlets showing what is the recent antibiogram, what is the trend going on in the hospital, which infections are showing, which what kind of a sensitivity, and then we distribute it to all the doctors. But then onus finally lies on the treating physician, because in a private setup it's very difficult. You cannot, as ma'am Seema said, it's the same problem, the ego problem.
I'll just add, sir. Here, a hospital-based antibiogram is really, really important. And then putting a list of the restricted antibiotics that you should be, having a justification form before prescription and before usage is really important. And then based on that, a monitoring system that has to be tight. And for the usage, I'm saying for the antimicrobial stewardship part, definitely hand washing is the standard, the gold standard. That is so cheap, and that is, that everyone can do. You don't have to spend so much on that. It is just that the hospital has to ensure that you give the facility of a sink, and then elbow operated, taps. All that should be provided. It is just that the provision, the soap and all. So that is where the hospital or the administration comes into picture, that you give the facility. It may be the minimal part, not the high-end part. And regarding your this one, surgical prophylaxis, there we also did our own study in our own organization, where we saw, like, few restricted antibiotics were used as prophylaxis. So we got the data, then we talked with them, and lastly we could change their way of doing work, and it helps. I think we need to be a bit more persistent. And in the hospital, the IC team, the IPC, the team, I think the infection control team has to be empowered.
Stuff. I've been
It
persistent
has
for
to
18
be empowered.
years. 18 years I've been doing
I know,
this.
but here I feel, the medical heads have a big role, because when it comes to implementing on the stubborn people, or to say people who are performing, say in private hospitals, the performers think they are gods, like, you cannot touch them. So, but then, when it comes to the patient, because it puts a cost on the patient also, their bill also. So we need to look into that things are done properly. So whatever it is, like there in our setups, like I always say, if you have to try once. If you cannot deal with the consultant, you'll come back to me. So that way it happens actually.
Sir, I
Dr.
would
Papia,
like
yeah.
to
Antibiogram.
add
I
here.
want to hear something on that from you.
So I would like to add here that I have 5 infection control nurses. 3 are newly inducted.
5?
Yes, sir.
You're a lucky person, man.
My hospital is very good with me with respect
I think
to
that's
that.
luxury.
Luxury.
2 of them are senior most, but they have become the terror of the hospital. Surgeons, oh my God, she's entering again, the OT. Because she always goes, my nurses always go to check their respective areas on a daily basis. So my work is sorted with them being efficient. So 3 more we have tried to incorporate, but senior surgeons, they always come and tell me that what to do with them. After so many years also, I have been incapable. Senior surgeons are very, very, more than the ego, I think they are stubborn. They will not change if I want to, but there is the time where we involve our boss. Maybe if boss gets...
This is one suggestion I want to make to all of you out here. Try and get a senior doctor with you, clinician, whether it is medicine, whether it is surgery. You convert one. In Kasi, we say, convert the person, your life will be easier.
And to convert them, you have to show the revenue. How much
Data.
IPC?
Ultimately, it boils down to data. See, another thing what Dr. Ajay said, for me to be able to use a single dose of prophylactic antibiotic, I have to be confident in everything else around me. It implies your sterilization techniques. Whatever you get from CSSD has to be good. Your OTs have to be clean. Your scrubbing has to be good, which implies you need elbow taps or foot operated taps. You understand? No, it is an integrated thing that everything works together. You can't do one thing and ignore everything else out there. It doesn't work. Anyway, we have run out of time. 32 minutes, I think I took. Thank you so much, 3 of you, really. Thank you so much for taking out time.
Thank you, Michael. Thank you, everyone.
Organizers. Just a minute.
Thank you so much, sir, for that wonderful discussion. Now, I request Dr. Pramod Paharia. May I request Dr. Michael Maulong, sir, to kindly come forward and receive the token of appreciation. Dr. Michael.
Another one.
Dr. Seema Conver, kindly come forward Dr. Papya Chakrabarti. And Dr. Ajay Kumar Thakur, sir, kindly come forward. Thank you so much, Dr. Pramod. Thank you to all the panelists and the moderator. Now I request all the dignitaries, Dr. Michael, sir, Dr. Papya, Dr. Seema, and Dr. Ajay Thakur to kindly come forward for the group photo session. So now we will move for the lunch. Okay, the lunch, as I said earlier, lunch break for all the participants will be in the adjacent room. We will take only 30 minutes break. After that, we will come again so that we can resume early. Thank you so much.
Regional leadership, and international collaboration. The future of healthcare is being rewritten, where technology advances care, human touch defines healing, and trust becomes the new healthcare code. Welcome to CahoCon 2026, the 10th Annual International Conference of the Consortium of Accredited Healthcare Organizations. CAHO, proudly designated as the first ISQA regional conference for South Asia. CahoCon 2026 brings global credibility, regional leadership, and international collaboration onto one powerful platform. From immersive pre-conference workshops across Chennai's leading hospitals, to scientific sessions, debates, innovation showcases, and the prestigious Caho Awards, CahoCon 2026 is where ideas turn into action. Over 2,500 delegates from India, Asia Pacific, the Middle East, Africa, Europe, and beyond. Healthcare leaders, clinicians, quality professionals, policymakers, educators, innovators, all in one place. Gain insights into cutting-edge quality and patient safety practices, exchange ideas with global experts, and take back practical learning that strengthens healthcare systems. Join us from 10th to 12th April 2026 at the Chennai Trade Center, Chennai, India. CahoCon 2026, where tech, touch, and trust define the future of healthcare. workshops across Chennai's leading hospitals, to scientific sessions, debates, innovation showcases, and the prestigious Caho Awards. CahoCon 2026 is where ideas turn into action. Over 2,500 delegates from India, Asia Pacific, the Middle East, Africa, Europe, and beyond. Healthcare leaders, clinicians, quality professionals, policymakers, educators, innovators, all in one place. Gain insights into cutting-edge quality and patient safety practices, exchange ideas with global experts, and take back practical learning that strengthens healthcare systems. Join us from 10th to 12th April 2026 at the Chennai Trade Center, Chennai, India. CahoCon 2026, where tech, touch, and trust define the future of healthcare.
Some of you are present here today. Your willingness and efforts are highly appreciated, and I'm happy to say that there has been a great interest in presenting in 2026, so we can look forward to another exciting year and hopefully to many more. Finally, I would like to announce that CahoCon 2026, taking place on the 10th to 12th April in Chennai, will be branded as an ISQA regional conference for South Asia. This is the first South Asian regional conference of ISQA. It is a landmark moment for Indian healthcare, and we are proud to join Caho's global journey by taking this step. For this, once again, congratulations. Thank you to everyone.
Good afternoon, ladies and gentlemen. Kindly settle down so that we will begin with this session. This is the fourth session. It is on CSSD management and surgical safety. There are two chairpersons in this session, Dr. Jayanta Das. Dr. Jayanta Das, he is the consultant surgeon, Nazareth Hospital, Shillong, being instrumental in setting the AMASI Center at Nazareth Hospital, Shillong, held various positions in state, regional, and national surgery chapters, organized various state and national workshops and conferences, has multiple publications in international journals, and has participated as faculty in multiple conferences. So welcome Dr. Jayanta Kumar Das. Another next speaker is Dr. Zulfikar Hazarika. Dr. Zulfikar Hazarika, he's the chairperson, sorry. He is consultant ENT surgeon at Bethany Hospital, Shillong. ENT specialist and deputy medical superintendent published several publications in national and international publications, and he is a resource person for various programs. So welcome, Dr. Zulfikar Hazarika. I request him to kindly come forward and take the seat. So the two chairperson will introduce the speakers for this session and will moderate the session. Thank you.
Good afternoon. We'd like to welcome Mr. Ujjwal Chakrabarti. He's a healthcare leader with 20 years of cross-functional experience in hospitals, medical devices, and healthcare education. Skill in operations, quality, CSSD, OT management, strategic growth, digital transformation, and training. He has a proven record of driving institutional excellence, turnkey hospital projects, and national and international speaking engagements. And he has served different corporate hospitals, industry, and service providers. May I welcome Dr. Ujjwal Chakrabarti to the stage. Thank you.
Thank you, doctor. First of all, a little clarification. I am not a doctor, so I am Ujjwal. Thank you, doctor. Thank you. So I believe if I am little mobile, that is okay, right? Permitted. Fine. So how much time I will be allocated? 20 minutes. Half an hour. Oh, that's really great. 10 minutes more than my expectations. Fine. So very good afternoon. Oh, we all are, and very nice lunch. Thank you. So my topic is CSSD management myths and challenges. Very easy and easiest job in the world. How many of you agree? Yes, no? Not easy? It's just washing and cleaning the utensils kind of thing, and sometimes some instruments come and we clean. Is it not? Have you heard any term called double autoclave? Have you heard? Can you elaborate a little bit on that? What is double autoclave? And rather than what, the main attraction is why. What may be, okay, fine, we can run through the definition. Double autoclave means a sequential autoclave. Once the first autoclave is over, then we can move it to second autoclave. That is double autoclaving. But why? Today, a very eminent person's surgery is posted, so we need double autoclaving. Have you heard this? Yes, no? So we'll like to put some basic facts, and frankly speaking, this is not going to be a very jam-packed slides. We'll be seeing so many photographs, and I'll be sharing my little experience of 20 plus years in this field. I believe it's not working. Fine. These are objectives, only 3 points. Myths, factors and challenges related to sustainable clinical excellence, and conclusion. So this slide is the only slide, jam-packed slide. So what are the myths? Generally, if we largely segregate the myths, those comes under these 5 parameters, out of which 2 is actually operational, means from the leadership thoughts level and operational level, and the remaining are infrastructure, process, and people. Okay. So let us see. CSSD has minimal impact on revenue, right? And we have been told that this topic has to be delivered in for a small and medium-sized healthcare organizations, right? It's not working, I believe. So maybe switch off, right? Fine, great, sorry. Fine, so CSSD has minimal impact of revenue. Can you see some of the key words? From the morning, we all speakers have been told that we have to concise our talks in some specified time limit, right? Now, there are many topics. Suppose, say for an example, instrumentation or unplanned leave or breakdown or loaner instrument or sterile dart, we can have at least 1 hour in each of these keywords, at least 1 hour required. But why we need to concise our talks in only 30 minutes? The reason behind, we have to take some keywords. When we leave, we should have some keywords so that information is readily available, right? If you have the keywords, you can Google it and you can download n number of literature on that, right? Now, when I'm saying that CSSD has a minimal impact on revenue and I am writing a very bold word called sterile dart, can you see different keywords, right? Is there any mistake, spelling or grammatical mistake in these keywords? Any of the keyword is having any mistake? Yes, adequate, right? Actually, most of the things are not adequate. Understood? And all of us, this thoughts is going in adequate, though there are 20 plus keywords maybe, but we are focusing our ideas on negatives, right? Same thing happens in practical life. You may be delivering 100 good things, but if only one bad thing you have done in healthcare, because there is no second chance, right? There is no second chance. Now, sterile dart. Is there anything called sterile dart? Dart is always unsterile, right? Now, let me give you an example. So, we talk about time. In one day, suppose there are some loaner instruments. Have you heard this term called loaner instrument? What is loaner instrument? Suppose you are having a surgery posted, orthopedic surgery, and there are many equipment or instrument which your or our organization may not have. We need to borrow it from some vendors, right? Huge instrumentation sets are coming. Now, what happens to this set? The surgery is posted just 1 hour after you receive the instrument. How to clean? This one surgery, maybe if it is a hip replacement surgery, maybe 5 boxes. How to clean those big 5 boxes? Because in CSSD, magicians are there. If instruments see them, it gets cleaned automatically. Prove me that I am wrong. I am saying 90% of Indian hospitals, I am claiming this, 90% of Indian hospitals, they receive the loaner instrument, they put directly into the sterilizer. No cleaning. No cleaning happens. I am saying from reading from a textbook, no. 400 plus hospitals I have visited. Loaner instruments receiving from vendors directly going into the sterilizer. So that means you are producing sterile dart and nobody is thinking on this. This is not a rocket science. CSSD, what is the full form of CSSD? Central Sterile Supply Department. Is it? No. It is common sense and sense of development, which we are missing most of the time. Yes. Because we are producing sterile darts every day. Every day. There is a word called breakdown. Management is saying it is not revenue generating, but when the sterilizers are breakdown, suppose you are having 2 autoclaves and both the autoclaves are not working. What CSSD managers are doing? They are getting tensed. They are trying to give some solution, makeshift arrangement. If the sterilizer is breakdown, it is breakdown. Communicate this to the management or to the team. But they are not communicating. I don't know, where is the fear? Why are you not communicating? Your boiler, your steam generator is not producing adequate steam. Your sterilization phase is not coming, but you are still delivering the load. I'm not talking about India of 1900. I'm talking of India of 2025. Hospitals are there. Their sterilizer is faulty, but we are taking the instrument and doing the surgery. Communicate this. From the morning, we are saying that it is very difficult to handle or to tackle or to communicate seniors. Do you know why it is difficult? Why it is difficult? I am giving you an example. A salesperson comes to different hospital purchase managers to sell one N95 mask 10 years back. Hospitals are saying we don't require that kind of costly mask. One mask is costing 100 plus rupees. We don't need that. We need 2-3 rupees mask. And the same India, many hospitals were asking for N95 mask. And the producers, the manufacturers, they don't have even a single mask in their factory while COVID was there. Right? So how do they convince the seniors? How? They didn't even came to tell that please take N95 mask. They didn't come. But we were asking them to supply. So what acted? How seniors changed? How management changed overnight? What is the factor? Only one factor, fear. No quality, fear. I want to leave. So please communicate. It's not difficult to convince seniors. You give the instrument to the surgeon and say, sir, this is the instrument we are giving you, sterile instrument, but we have not cleaned. See, surgeon is not going to do the surgery because they are focused in patient treatment. We are the back office person. We need to tell them the truth. We need to tell them the difficulties. From the morning we are saying small healthcare, medium healthcare hospitals. Does that mean that large healthcare only need infrastructure, small doesn't need any infrastructure? Please communicate. If you can't, that has to be informed decision. You are having only one endoscope in your facility and you are scheduling 40 cases. So you know, you are educated. You are not a CSSD guy, right? You know, one instrument, 30 cases, what kind of sterility we are asking? You know that. So only fear. Operational myths. What are the main operation things? Dilution factor. Can you see? In the morning we heard housekeeping personnel, if they are trained, they are the most compliant personnel, right? Absolutely true. We talk about dilution. In most of the CSSD or in most of the areas wherein we are using different agents, you can't even find out a measuring jar. How do they measure? How do they calculate the volume ratio? There is nothing. They are magicians. If they pour something in 10 liters of water, it is as per the volume. 10 ml is only coming, or maybe 100 ml is coming. It's not that. They don't even know what is the water capacity their sink is holding. Is it 30 liters of water, or is it 10 liters, or is it 50 liters? So if you don't know what is the capacity of soakage tank, how do you soak? How do you mix solutions? Rocket science, right? No. Common sense. Missing. We heard about, in these competitive exams, we heard about general knowledge test. General knowledge is actually not general. It's difficult. So, quick, VIP. I need this instrument right now. Patient is in the OT, incised. How do you give instruments without cleaning, without sterilizing? Doctor has rightly pointed, if you can't clean, you can't sterilize. These are gray areas, single-use devices. Should we reuse or should we not? NABH 5th edition, they came up with the guideline that single-use devices, if you want to reuse, you have to take the consent for that reuse. Suddenly it disappeared from 6th edition. So much to think. It's not a rocket science. Heat and moisture sensitive, we discussed NVC. What is this? NVC? Have you heard this word? Yes, we all have heard. Non-verbal communication. We say that we have to train, we have to motivate, but at the end of the day, our housekeeping personnel, OT personnel, a nurse, a sister, a technician, in this market, they are getting 10,000 in a month. After a month, 10,000, right? And you are scolding. Everything boils down to that weaker fellow, right? And you we are supposing that he has to be motivated and deliver quality work. And if it is a urology or very high intensive MIS kind of instrumentation unit, lakhs of rupees instruments are going to him. We talked about revenue leakage. In hospital, you will be continuing purchasing high-end equipment and the damage will be continuous because non-verbal communication, you put the load onto him. If he is not mentally fit, he is going to damage the instrument. Nobody is bothered. Instruments are costly. These are hospital property. Why I need to be bothered? It is not my thing. If that is the case, very difficult to manage. No cycle printouts. We run an autoclave. What kind of temperature, what kind of pressure it is maintaining, we are writing down in hands. And we are thinking that in the court of law, we will be saved. We can't. From the morning we are listening that documentation, right? But the problem of documentation is, if we are not having proper, adequate documentation, it is again a major problem. PI, CI, BI. Have you heard this? These are 3 quality parameters: physical indicator, chemical indicator, and biological indicator to validate your sterilization process. I can't go into deeper because of the time. So these are infrastructural myths, process myths, people related myths. So these slides are available, you can take. So that's not a big deal. The keywords, let's focus on keywords. It is a small hospital. It is a neurospecialty hospital. And the CSSD is not having HEPA. What is HEPA? High efficiency particulate air. Now, in front of the OT, most of the hospitals are having a red line. What does it mean? Microbes can understand that if I go there, I will be killed. I should be here. Is it so? Red line means everything. Red line means sterile, right? It's not about what kind of hospital you are, what kind of outcomes you are generating. Your infrastructure has to be on that. Even if you are a small size hospital, if you are dealing cardiac surgery, your CSSD has to be high end. Even if you are a small hospital, if you are asking me that I want to go to ship, I can't tell you that without a spaceship you can travel. I don't know the media. Maybe through meditation we can travel. But physically, if we have to go, we need spaceship. Even if your budget is not permitting, you have to have spaceship or forget the dream of going to space. There is nothing called small hospital, don't need medium hospital, don't need large hospitals are needed. You need to focus on outcome. What kind of outcome or result you are going to generate? That should be on your priority when you are designing. Corrosion. You are giving new instruments to CSSD and CSSD is giving back rusted instruments. Right? Why? Because CSSD persons are magicians. Rusting is a chemical formula, right? So what CSSD people are doing to change your new instrument to rusted instrument? They are mixing with other department. No. Focus on the water. Look into your instrument quality. Look into the kind of solution you are using. Maybe you are using too acidic solution, a very high acidity. You are cleaning with high acidic solutions or you are cleaning with high alkalinity. You will be having problems. Right? PM defined. Have you heard of PM? Preventive maintenance. We all talk about preventive maintenance, but ask yourself. Ask the vendor. Suppose the vendor is a ECG machine or MRI machine, high-end equipment or CSSD's autoclave. Ask him. You are saying that you have done your biomedical department, you have done preventive maintenance. What are your preventive maintenance checkpoints? Write down first. What is preventive maintenance? A person is coming, looking at the sterilizer, tightening some nuts, going back. This is not a preventive. Let them define what a preventive means. right? So all these key words are very, very important. Have you heard about sporicidal? Now, in the OT or in the maybe in the endoscopy department, endoscopy unit, we are using some solution and we are thinking that is this giving me sterility? No, read. The vendor, the manufacturer is saying sporicidal activity you can only achieve after 10 hours. If you soak it, after 10 hours you will achieve sporicidal. Sporicidal means that is the way you can assume it as sterility. That means your instrument is not sterile. It is only maybe cleaned or mid-level disinfection process, intermediate disinfection. That's it. You are using a surgical knife or surgical scissors. You are dipping into XYZ, side X XYZ solution and you are thinking that it is a sterile. Absolutely, come out from that myth. It is not sterile. That's why you need this keyword called sporicidal. You need to know. Have you heard about this SOP lockers? Lockers are made to keep SOPs. Is it so? SOP has to be easily, readily accessible. How many of your staff know the SOPs? Or maybe some units doesn't have any SOPs as well. Along with SOP, how many of you or we have heard about WIM? What is WIM? Work Instruction Manual. Every now and then hospitals are getting high-end equipment. Do you know how to run that equipment? That person only knows. If that person is in leave, it's in toss. Nobody is there. Write down the work instruction manual. If I press this switch, what will happen? What screen will come? If I go that line, what are the series of sequential events that will come? So we need to write down. We need to create document. Do whatever you write whatever you do. Nice. Can you see something? 2 restaurants. One is multi-cuisine restaurant. One is only Indian cuisine, and that too specific Indian cuisine restaurant, right? Now, what is the slide doing here? It's a CSSD topic. Why this Italian cuisine, this pizza and this dosa idli is coming? Suppose I am running one multi-cuisine restaurant. For pizza making, I need oven at least, right? Yes, no? For if I have to serve idli, I need a idli maker, right? But if I'm a small roadside eatery, I don't need a idli maker. Is it so? But we are having a misconception, myths, that if we are a small hospital, even if we are a heart hospital, even if we are a neurosurgical hospital, even if we are a urology hospital, our CSSD doesn't need that kind of fancy things. These are not fancy. I'll show you in upcoming slides. These are some pictorial representation of a small, medium and large hospital. Let me show you this. Even if it is a small size hospital, this kind of instruments will be there. Yes, no? Yes? Yes. Now, let's see this. This is the, have you seen this? Now, with the help of this, you are supposed to treat these instruments and keep the instrument alive for surgeons. What are we doing? It's a small size hospital. How can they invest on CSSD equipment? Then forget about quality. Because this kind of instrument, just see this shows, see this kind of minimal surgical invasive instruments. You can't even dip that kind of hand instruments with this kind of sink. So that means we are thinking our staffs in the CSSD is a magician or a son of God. After seeing them, the instruments will be automatically cleaned, protected. Can't be, ma'am. You need infra. Because even if it is a small and medium-sized hospital, your doctor is a top-notch person. But he doesn't know where things are going wrong. Because he is not into back office. It is not his job. It is we. We need to communicate. We need to communicate approach to him. Sir, आपका जो instruments आता है, in the sink we can't even dip. How to clean? I can't clean your instrument. Somebody was saying that inform and carry your boss along with you. Go. Surgeons are excellent. Even if you are in my life, I have seen many angry surgeons. They shout. They shouted me. Shouted on me. They shouted. You try to prioritize your thoughts to the surgeon's mind. How? You have to be smart enough. You need to catch hold of him. After shouting, he also knows. मैंने अच्छा नहीं किया, उतना बोलना नहीं चाहिए था शायद. उसका माइंड में चल रहा है. It's there in his mind. But he will not come back. Because he is a very busy and top person. You need to go to him. You need to say, sir, can I come? Just 2-3 minutes. His secretary is your friend. Right? Go. Discuss your problems. Half of the problems will be solved by him only. Because he knows his patient is important. He has to face the patient. You are not. We are not. We are in the back office. Get the help. Don't go to the management asking for manpower. Management will never give you manpower. Right? So how do you get the manpower? Do you know? I am showing. Wherever I joined, for last 2 years, I am not working with any individual hospitals. I have been into different hospitals starting, and all these hospitals are corporate big names. I have been to Tata, I have been to CK Birla, I have been to Apollo, I have been to 3M. So big ones. My first target is to, when I am at night, I am sleeping at night, my phone should not ring. How do you ensure that? You need trusted manpower. How do you create that? If once you join, you see only 2 manpower is there in the department. How can you make it 4? If you go and ask 4, you will not get. You need to do the back end analysis. What? How? Suppose there is one complaint surgeon has raised. I am giving one practical example. Surgeon has raised one complaint. What is that? A Caesar is having a blood stain. While he is trying to do the surgery, sister has given, she has overlooked probably, or even sister has only noticed that there is a blood stain. Huge issues. Management CEO called you. What your department is delivering? A rusted instrument with blood. This is practical, I am saying. What I told you, no. Sir, out of 30 surgeries, you only called me once, and that too after 2 years. That kind of efficiency we are delivering. We are unable to deliver quality services because of, before that I have already done my manpower gap analysis. I showed him that I need 1,000 hours of man hours, and I am having only 500 man hours. Can you do that analysis first? I didn't go to ask manpower. That day, HR has been instructed to give me 3 manpower. That day. So what worked? Science, knowledge, training, no. Fear. You need to learn the art. You need to be visible. I was a CSSD person. Only 15% were selected to talk to Ratan Tata. I was that. I was a CSSD person. I talked to him. How? You need to be fearless. No need to be fearful, and you need to create fear. So these are some of the infrastructure process pillars. These are some of the levers. If you can work on infrastructure, you can ensure safety. If you can work on process, you can have consistency. If you can work on people, you can have precision. Every now and then we say about training. Do you know how difficult it is to train? 8 hours of job. Where is the training time? How can you impart training? It's not easy. If you want to have measurable outcome from the training, it's not easy because everyone is working. Nobody is relaxed to give or to take training. How can you devise a training strategy that can generate outcome. It's an engineering. It's not easy. So this is a water quality kind of thing. This is freely available. This kind of water quality you need to have in your boiler. This is a very basic pictorial workflow for CSSD, not a rocket science. All these are processes, workflow, SOP. What is the IFU? Have you heard about IFU? Instruction for use. Who can give you? The manufacturer of the equipment. Every equipment, it comes with IFU. But what we do, we take the equipment or instrument and then throw the brochure or booklet. IFU is there. How to clean, how to protect the instrument. What is Hira? H-I-R-A? In Bengali, Hira means diamond. But it is not about diamond. But if you can comply this, you can ensure diamond. Hira is hazard identification and risk analysis. If you can do for your individual department, all the departments, if you can do, you can generate quality outcome. We already discussed, if you can't clean, you can't sterilize. Because without cleaning, if you sterilize, it will give you sterile dirt. Dirt is always unsterile. This is a very basic classification. High risk item, medium risk item, low risk item. You can have this list across all the hospitals units. You know that what kind of reprocessing system I need to comply with. Right? Can you read this line? In God we trust. Rest all must bring data. We have not asked data from God, right? But remaining others, we need to prepare data. And that data has to be adequate, that data has to be measurable, that data has to be visible. And my only point is to break the myths and challenges of CSSD or OT or any department. Try your activities so that you can be visible. Most of the hospitals, CSSD is not visible. Visible means you need to take pictures and put it in front of the gate, right? Is it so? No. Suppose a parent is they are having 4 children. Do you know who will get the most love out of 4? The children who cries the most. Right? No. Right or not? So, if you want to prioritize yourself, if you want to make yourself visible to the management, cry. Cry means ask. Ask. Don't be fearful. Communicate. Approach. I am done. I am waiting for your questions. Thank you, sir.
Thank you, Mr. Chakraborty. Any questions or comments? No comments. Just one question. Yes, sir. You said in your reversion that it was a nice, elaborately given lecture. Actually, you said about disposable instruments. As a surgeon, we are routinely using. So, did you want to condemn the NABH changing, removing that, or what?
Basically, my thoughts are, sir, very simple. If I am going to reuse the instrument or item, that clause NABH actually should have, but the problem is hospitals were facing problems to convince patient parties. That's why probably they have removed. But only point is, we all know it is not in India. You read the literature, 1930, US were having discussions about reusable devices, and they defined how can you prepare your own policy for reusable. Suppose I am given one example. For a heart surgery, you need one item called octopus. Octopus. One octopus is your purchasing price will be something around 1 lakh. 1 octopus. Now you think, after single use, if the octopus has to be thrown out, what kind of cost implications the patient has to bear? So the answer to that question is, we need to have that clarity and that consent and intimation that we need to educate society and our fellow colleagues and try to get the help from the management, because it is clearly defined that if I am going to use the octopus for 30 times, the hospital management should be able to answer on 29th time which patient it was used, which is very difficult to maintain. So it is a gray area. NABH started to do something on 4th, 5th edition, but again it has gone back into dark rooms. Not only in India, even in developed countries, single-use devices are coming more and more, because world is shifting from reusables to single use. It's difficult, sir. It's still in a gray area. There is no such yes no kind of answer, or there is no such binary answers wherein I can say you should use or you should not use. The 2 points are very clear. It has to be trackable, and the next is patient should get the cost benefit. In India, FDA has closed down one big corporate chain hospital in Mumbai. I am not going to name that hospital. This is very much available in the net, for 3 days, because they have not passed the cost benefit to the patient. So that's the scenario, sir. I don't know whether I have given you the answer or I have told something with no answer. Thank you, doctor. Thanks a lot. Thank you. Thank you.
So may I request Dr. M. Braling, is a very dear friend of mine. He's a senior consultant surgical oncology in Supercare Hospital, Shillong. Published multiple national and international articles in renowned journals, and performing complex and open and laparoscopic cancer and general surgical cases. We will speak on SHCO. Welcome.
Yeah, thank you, sir, for the introduction. Now, my topic is on surgical safety in small hospitals. I'll just go to the topic. The first question I would like to ask all of you is the WHO surgical safety list sufficient? Because when we say surgical safety, in all of your minds will be the WHO list. Oh, we've been doing for 10 years, we've been doing for 15 years. Now this is the list. All of you know this. Now let me give you some scenarios. It happened in a hospital in Shillong a few weeks back. Patient came with trauma, both hands, had fracture on the left side according to X-ray, was about to be operated. Nerve block was supposed to be given. Before the anesthesia gave, the orthopedic surgeon said, no, let me check again, because I remember the right side, the swelling was more. He went and checked. Fracture was on the right side. Mislabeling from the X-ray department. So where did the error happen? It happened before surgery. And we know many cases of retained DJ stents, ERCP stents. No? Where did the mistake happen? After surgery. This list is intraoperative list. So WHO list, is it sufficient? I would like to ask that question to all of you. The second question I would like to ask is, why are small hospitals so resistant to checklists or protocols? Now, when I was a PG resident many years back, this WHO checklist came. That was in PGIMS Rohtak. We used to operate around 1 lakh operations, all departments across. So in a 1 lakh operation per year, mistakes happen, wrong side surgeries happen. So WHO list was, we used to follow that. Then I came to Nagaland, practiced for around 5-6 years in 2 hospitals, no list. Then went to Tata. There in Tata, I learned how to follow this WHO list. Very nice. Then came to Guwahati, Shillong, work in NABH hospitals, WHO checklist by name. So the trend is very clear. Bigger hospitals, they follow smaller hospitals resistant. Why? Because smaller hospitals things, lesser incidences. This is there in literature also. Then since in smaller hospitals, less staff, there is less confusion. Better line of communication. The number one error is communication errors. Now the same surgeon is operating on the same patient. When in big colleges, we work up the case, then somebody else goes and operate. The SRS never seen the patient, he sees in the operation table. That's where mistakes happen. In smaller hospitals, these things are lesser. But is it true? There are some certain disadvantages of small hospitals. Few nurses, doctors, no PG students for backup, multitasking. In most small hospitals, the surgeons will operate at 4 or 5 in the evening after you are fresh. No, you are tired. All day talking in the OPD, and now you are going to do a life-saving surgery. So will that translate to more errors? In small hospitals, many hospitals don't have permanent anesthesia and surgeons. First time they see the patient is in the OT table, both the anesthesia and surgeon. And on top of that, that's the last time they see also. The surgeon will say bye-bye and go away and give some good instructions over the phone to the MO. And that's how we are supposed to give quality care. PAC is non-existent in most small hospitals. Even if we do, it's paper PAC. And errors are not recorded because we don't have a monitoring protocols. And since errors are not recorded, you think you are doing very well. So, disadvantages of small hospitals. Now let's go to literature and see what are the most common surgical errors, communication gap, like I've said. Then it comes down to documentation errors. These things you know, I'll not go deep into it. Then lack of standardization. Hospital panders to the surgeon's needs. Now, you know what's that? Now, this young doctor comes back and says that, oh, in our medical college, we used to give antibiotic during induction because this is the latest thing. Then the senior surgeon says, no, for 30 years I give at 6 a.m., nothing happens. Same thing with anesthesia. The young anesthesia wants to say that now we don't need 12 hours fasting. We don't need to fast the whole night and operate next day at 6 p.m. Just 2-3 hours of liquid fasting is required. Then the HOD says, no. What? I've done 10,000 cases. And things, no standardization. That's why what happens in the ward, the nurses are confused. One will do the surgical part preparation with clippers. The other will say no shaving. The third one will say no cream. So which one will they use? Somebody will say enema in every case. Even in ENT case, they give enema. Because the nurses are confused. No standardization, more errors. Then another reason for errors is administrative barrier, culture of fear. Now administration is there to support the staffs. Administration is not there to suppress the staffs. Now, in our hospitals, we have very good people from non-medical backgrounds. But some people from non-medical backgrounds, a bit difficult. Until you have touched urine stool, until the blood has spattered over your face, you have done night duties, you cannot understand some things which the staffs are going through. And they want to control, they cannot control the doctors. So on whom does it fall down to? The nurses. Small errors, suspension. This one, that one, rules, regulation, culture of fear. Errors are there, they suppress it. And when you suppress errors, more errors happen. Near miss events become never events. Now, if you go to the literature, this error rates, the recent literature 2004 by Royal College of Edinburgh, they say that 33% of errors happen in the pre-operative setting. One example I've given to you, no? The errors in pathology, the clinician's misdiagnosis, failure to optimize. Patient has congestive heart failure, but they want to operate so much, no? Just push into operation, improper counseling. And out of this, look, 1 in 7 dying as a result. That's a huge statistics. How many intraoperative errors? 31%. Huge. How many post-operative errors? More than 40% surgical errors are in the post-operative. WHO checklist, which one does it? Where does it come? Intraoperative. But errors are happening in the preoperative and the post-operative. So if we talk about the surgical checklist, we should be going through everything from the preoperative, from OPD to discharge. So what is surgical safety? Coming back to that question. Surgical safety should include all of this. WHO safety list is not enough. But I'm not saying it's bad, okay? It's good, very good. WHO safety list came out in 2008. Because that time there was lots of wrong side surgery. After this list came, it has decreased a lot. But the data which I gave you was from 2024. In recent times, most of our errors are happening outside the OT. We have to take care of that. So a checklist should cover from OPD to discharge. Can we have such a system? But can we have such a system without increasing documentation? Without changing current practice? That's the question. No? Because when I say documentation, some sisters will be scared now. No? So many documentation. NABH is like a girlfriend, no? Who says that, if you marry me, your standard will go up. Comes for dinner, I'm coming for dinner. But when you open the door, mother, father, brother, sister, everybody is there. No? When you sit for dinner, the neighbors, the colleagues, everybody's there again. Documentation. No? If you go to literature, you'll find this NABH burnt out. It's right. Now, in words, they say that 60% of nurses' time is in documentation. Now in a hospital where I used to go, 10 o'clock I go, nurses in the corridor, documentation. 5 a.m. in the morning I go, documentation. And sadly, in one hospital, NABH hospital, the administration said it, patient मरने दो, लेकिन documentation ठीक-ठाक होना चाहिए. See, is that the standard which we want to go to? Because some of you are from NABH background, no? Do you want to pepper NABH? Is that excellence in patient care? No, as a doctor, I want my nurses to be at the bedside. These days, going to the bedside, how are you? Was the food good? Forget about clinical things, no? Those kind of things are gone. Busy documentation, and for doctors, click burden. People say that when EMR, HMS came, all doctors' workload will be gone, no? Because now computers have come. A few months back, one patient came to me and said, I'm not going back to that doctor. I said, why? Because when I'm talking, doctor is in the computer. Doctor is not talking to me. And that happened to me also when I was in Tata. Very good system. 15 people from TCS used to stay there and take care of the system. But patient is in front of me, most of the time like this, no? Because if I listen to him for 15 minutes and write down, no time. So as a speaker, I have to fast. So this kind of burden they come. So when I'm talking about documentation, can we do without extra documentation? Can we do a booklet type from where the surgical checklist will go from OPD till the time of discharge? Just a suggestion. Can we take all these standardized tools, ERAS, WHO, all these things, no? Make it customized into your local setting, and can we do it? Can we use system like a closed loop communication? Now, closed loop communication is like this. The anesthetist says that give 1 gram of Tranixa. The nurse will say 1 gram of tranexam. The anesthetist will say yes. So command goes out, it comes back, and it confirms. Closed loop communication system. Can we use this kind of system? Can we use stop the line in authority? Now, what is stop the line? Now, this Dr. Ajay is in OT, he has operated. There was some problem, so he said to Sister Kamala, I had this problem today, please fix it. So the nursing superintendent will go to the deputy MS will say, oh, yeah. And we'll go to the MS will say, yeah, really, that kind of problem. And the MS will go to the CEO, then the CEO will listen very nicely and go to the chairman. And one day the chairman, after 2 months, will call to Dr. Ajay again. Dr. Ajay, I heard you had the problem in OT 2 months back. So what is your suggestion? He's asking for a suggestion, and finally, after many months, he has to give the suggestion. So in a hospital system, we have to have to stop the line. Authority problem stops here. CSSD, where does the problem stop? With that fellow. Infection control, where does it stop? With that fellow. Then errors, all these things becomes lesser. So can we customize something? So this is just my imagination. In that booklet, in the front page, you have all these data which the OPD doctor will fill, the important data, and the surgeon will sign at the bottom. Then the next page, maybe the PAC forms will come in the same booklet without duplicating, without writing the name again and again. Then with that booklet, the patient goes into the ward. And in the ward, the nurses re-identifies the patient and do their job. Then at the holding area, re-identify again and go do their job again. All this is happening in the same booklet. Then intraoperative checklist, and we customize the WHO within that booklet again. And post-operative list also comes within that until the time of discharge. So can we have something like that? That was my thought, okay? Because now most of us are doing, but we are fragmented. One list is here, one list is here, one list is here. And when something happens to patient, what will you do? The sister will say, no, I gave a proper handing over. Maybe the page, the paper flew away somewhere, because we're using individual sheets. Now, what will be the advantage of using a booklet? There will be no duplication of work, because if you do 500 operations in a month and you write in 5 papers, patient's name, UHID, address, now you're writing once. Most important points will be covered, and there will be established standardized care within the hospital. And it will be easy to follow, and there will be compliance. Compliance means the administration can go back to all those booklets. Oh, the anesthesia department, they are not doing their job well. They can easily follow. Now, when I say this, some of you will think, oh, such a big Mount Everest we have to climb. Let me just show you this chart. This chart is from SuperCare. Now, we did a project in 2023 about phlebitis. Then I had to go through 400 files. I was reading them. I found out there's lots of duplication, especially in nursing work. So we said, can we reduce it? Then our nurses, they were quite smart. They worked with the administration, and they reduced 12 sheets into this. I'm sure the hospital also saved money. Now what we do in the morning is, we go open the chart. The vitals are there, output are there, whatever I need, within my bird's eye view, everything is there. Earlier, vitals mean what is the unit output? It's a bit irritating also, standing there in front of the patient and going here, there, and still we make mistakes and lots of duplication. So we did this, we have been using for 5 months, and we have very good inputs of it. Okay, so can we do for a surgical checklist? I think it's possible. So how to implement? You get a team of surgeons, anesthetists and all, and administration has to be there. In Tata, the surgical checklist was very good, not because of the surgeons. It was because of the anesthetists. You know what the anesthetist used to do? Patient is there, ready to intubate, and they'll say, checklist. So if the nurse will not come and do the checklist, they will not touch the patient. So since they set the standards, the surgeon had to follow. And this group of people will go into current practices, they will identify deficiencies, and they will make a standardized checklist and regular reviews for sustenance. Now, so many points I can put, but there is one point. If that point is not there, flop everything. administrative will, especially in small hospitals, no? Where it's run by a family or it's run by a proprietor. For Tata, AIMS, and all, even if the director change, if they have an institutional goal, the next director comes and carry it forward. In a small hospital, today he did not look at me. Today she did not give me coffee and everything gone. So we need administrative will. Otherwise, very difficult. Let me give you some examples. Operating at night time, operating at odd hours causes increased surgical error. But in most small hospitals, it happens. Who let it happen? The administration. Without PAC, surgical errors increase. Who allows this? The administration. In some hospitals, the administration says that, oh yeah, we have not been doing that for so many years, so it's okay. Without a proper handing over, the handing over, I don't know whether you know or not, but handing over from OT to ICU is taken as a high risk error even, okay? High risk error even from OT to ICU. But we don't have a handing over protocol in most hospitals. In some hospitals, as soon as the surgery is done, forget about the surgeon. Even the anesthetist will go and leave the patient to the anesthesia assistant. If any problem, call me, like that. And who allows these things? The administration. That's why administration will is very important, especially in small hospitals. So coming back, can we do a comprehensive surgical checklist? Is it possible? I think it's possible. Okay, but we need a teamwork here from the clinicians to the administration. And it can be done without increasing the workload. In Supercare, we had decreased the workload in our paperwork for our nurses. And surgical safety includes from OPD to discharge. So I'll finish here. Thank you.
Excellent talk, Dr. Relang.
Thank you, sir.
Very nice. And, this is something that which is adoptable, and I think we should adopt your comprehensive surgical checklist.
Yes.
Thank you so much. Comments and questions.
Excellent talk. Now, I'm taking it a bit personal, I will say. Being from Caho, being from NABH. So I'm an NABH assessor. So that's why. Now, the thing is, you have fared obviously a good knowledge about NABH because the way you have presented it. Now, my question to you is have you got anywhere in NABH which says that you need this number of documents or a list of documents?
So see, we don't have that, but that is implied indirectly. In one hospital where I was working, in the surgical recovery, they had 18 registers.
Exactly.
So medicine reconciliation, for transfer, for discharge, this, that. No?
See, the thing is, it's NABH is talking about quality, patient safety, and is talking about documentation in the sense of making the hospital safe. When it comes to medico-legal, this documentation are going to save you, right? Hirok is there. He is a senior NABH assessor on this. He full accreditation he is looking into. So what we are asking is what you have defined. For example, the booklet. If you have started in your hospital, believe me, no assessor will ask you why you are doing like this. It is like this. No. What the assessor asks is what you have defined. If you have said we are going to write only 5 papers in the patient file, we will be checking those 5. We will not ask you, Fortis is doing 50 papers, why are you doing 5? It's not like that. It's what you have defined. It's the organizations that define the processes, organizations who define the documentation, and it's the perspective, right? So if you're taking I really like the concept of having it in a booklet form because writing only the name 10 times in 10 papers takes few minutes extra, correct? Name, MRN number, age, sex, and all those little details, correct? We don't need. First page, good enough. Okay, so that way is very nice. Sticker system is there, which can remove even that part.
Yes, so
it all depends.
In the small hospitals where we have worked, we have actually advised the sticker system because that's what we used to do in Tata. But cost comes into play. Yeah.
Yes.
Yeah. The
So
barcode was suggested, then cost comes into play.
when it comes to all this, remember, it's a multidisciplinary thing.
How many-
Give your Like it has to be, everyone can give you a feedback. Yes.
Maybe how many stickers will you use? So
Yeah.
many papers, so many forms to be filled up. How many stickers will you use?
Correct.
How much cost it cost?
Yeah. No, yeah, that is one point.
Most of the hospitals, accredited hospitals, one A4 size paper contains more than 80 or 90 stickers, and that suffices. It can be pasted in each and every paper. Why it is important? Because if the, as sir said, if it is possible to create a booklet, that is the wonderful thing. If booklet cannot be prepared, then loose paper might get lost during transition. So that is one thing. Individual paper also should have the patient's identity. That is number one. And coming to your like a statement, NABH has defined many objective elements, whether it is entry level standard or NABH full accreditation standards. It is up to, as Dr. Pramod also mentioned, it is up to the organization how you are going to address those objective elements. They are not asking you to create different papers, forms, format to increase the burden of the nurses. They are asking how you are addressing. If you are able to address in a compiled paper, that is more than sufficient. It saves time, it saves paper, and it is useful, user friendly for the clinicians also. So that's what it is. The intent, that intent has to be addressed. How you address that, that is up to the organization.
I think this message is very important.
Yes.
And this message should reach the hospital administration.
Yes,
Because
yes, yes.
Every committee meeting ends up with one protocol.
So,
we will be going to address some
yes.
points into it in our next two
Yes.
sessions,
Yeah.
which he and myself will be taking on the NABH perspective. With due permission.
Yeah, excellent presentation and touching the base points so nicely. Most of the time we come up, with a comment that NABH has increased the documentation. How many of you agree? Okay. Can I have 2 minutes of yours? Okay, thank you. How many of you agree that NABH has increased the documentation of the doctors and the nurses, and that has led to a compromise on the clinical care? How many of you agree? Okay. How many of you agree NABH assignment or accreditation is a burden, extra burden, without getting any extra payment?
No hands required, everyone agrees.
Okay. See, during our MBBS days, we used to attend the classes, keep the notebooks there. Just before the exams, we used to study day and night. Few studious guys, they used to study all throughout the year. And they used to be the top rank holders. In the question paper was the same. Right? It did not ask anything extra to us. For us, that was an additional burden because we were supposed to do that at that point of time. We didn't do it. Now, NABH assessors are there, practicing surgeons are there. The sirs have raised their hands. Let me ask you, NABH will never ask for something which is extra. WHO checklist is there. It is nothing extra that you should be doing. PSE, all those protocols are there, nothing extra. Pediatric patient, you go by the IAP guidelines. Sir is there, they have their own guidelines. NABH is never prescriptive. It will never give you a prescription. These are the points that you should follow. It would say, okay, infection control practices to be, or the manual has to be there, the system has to be there, IPC should be in place, and those are the things that NABH is asking. Number one. Number two is how I interpret the standards and the objective elements and how I reflect it in my document. That is again another point. Number three, very dangerous, are the NABH consultants. Now, most of these consultants, when I walk into a conference, we, bang on somebody. Oh, hi, I'm Jeet. Hi, I'm an NABH consultant. rampant. They would come and change the entire culture, entire documentation, because it is there, that is how they interpret. Most of them have never worked a single day in a hospital. Like doctor said, that until and unless they work in a hospital, you will never be able to understand the processes. So to be on the safe side, what I'll do, I'll put as many points as possible. And at times, in one of the hospitals in Guwahati, when I was going through the manual, I got it, Rabindranath Tagore Institute of Cardiac Sciences. Everything is copied. So these are the things which you should follow. I don't think this is extra documentation, but I think those are mandatory, how we interpret it. So I think we will have a neutral discussion over a cup of tea.
I just want to give a comment, short comment. What you said is right. NABH is not all about so many documentation. What Rowling said is also right. It depends on the local hospital committee who is looking after the NABH. So many paperwork we probably don't need. And it has to be, it has to be perfect.
I think this debate will continue. Please allow me to allow me to disconnect over here only. Yeah, please.
Yeah, no, what I have noticed, practically speaking, is it has increased the paperwork, especially for the nurses, the doctors escape, and the clinical care, which I have seen practically has come down for the nurses because they have to do so much of documentation. If NABH helps us in how to reduce documentation, will be a big thing for us. No, that is what we don't know. It's difficult for a small hospital to know. Yes. Thank you so much. Yeah, we'll close the session.
Thank you.
Thank you so much, Dr. Jayanta Das and Dr. Zulfikar Hazarika. And also thank you to both the speakers for that very interesting and insightful presentation. Now I request Dr. Santanu Deb, sir, Head of Department, Pediatric Department, Nazareth Hospital, to kindly come forward and felicitate our chairpersons and speakers. May I call upon first Dr. Jayanta Das to come forward and receive the memento. Dr. Zulfikar Hazarika, kindly come forward. Mr. Ujwal Chakrabarti, kindly come forward, sir. And Dr. M. Ralling, kindly come forward, sir. Thank you so much, Dr. Santanu, sir, for doing that honor. Now we will move to the next session, the session 5. This session will be on licenses and standards, getting your hospital compliant and NABH ready. May I first call the first chairperson of this session, Dr. Santanu Deb, to kindly come forward and take the seat. And Dr. Gitartha Roy Medhi to kindly come forward and take the seat. Dr. Santanu Deb, he is MBBS, MD Pediatrics, FIAP. He is a senior consultant here in Nazareth Hospital. ex-executive board member IAP, faculty of various IAP programs. He is a lead faculty to various IAP programs. He has published several national and international publications, editor and reviewer in various pediatrics books. Welcome, sir. And the next chairperson, Dr. Githartha Roy Medhi. He is a medical hospital administrator in P.S. Sangma International Medical College and Hospital, Meghalaya. He is an eminent speaker, trainers in patient safety and quality, awarded several awards in medical tourism, healthcare quality. He has published several articles in leading journals and newspapers. Welcome to you, sir. So I invite the two chairpersons to kindly welcome the speakers and introduce them.
A very good afternoon, everyone. Hopefully no one is feeling sleepy. It is the second session after lunch, so I can expect that no one is feeling sleepy. So our first topic is about licensing in hospitals. And I request Dr. Hirok Das onto this stage. So Dr. Hirok Das, already we all came to know that he is external assessor of NABH and medical superintendent of International Apollo Hospital, master trainer for NACO, with 23 years of experience in clinical pathology and hospital administration. So he has already conducted assessment in more than 350 hospitals and healthcare facilities. Hirokda, over to you.
Namaste and very good afternoon. So in the last previous two topics, several times the word fear that was used by the previous two speakers. I have something with me which is more fearful. So that is all about licenses. We have been discussing from morning itself many things about consent, then CSSD infection control protocols, and many other topics. Now the hospital is ready to treat patients. We have the infrastructure, but before start of the operation, hospital operation, we should have all the licenses in place. Because without licenses, without complying to the statutory requirements, we cannot move ahead. That's why fair understanding about the hospital licenses, which is never taught in any of the academic curriculum, is very, very essential for all of us to understand. We should have a clear understanding about the various licenses before we start any hospital functioning. So though it is believed that law is blind, but it has many ears, many other informers, so we should not violate in any of the legal parameters, because it gives gives the permission to operate. It gives a foolproof system for safety and regulatory adherence. It is in any of the inspections, whether it is NABH, NABL, or any other statutory agencies or insurance company who are visiting your hospital, they will be going through in some part of their assessment process or auditing process, they will go through the licenses first. So it is very, very important for us to have a fair understanding or fair compliance in terms of statutory requirements. So we must read, we should be aware of, we should update, and we should work on time for meeting the compliance requirements. Many a times we keep on hearing, especially in the Hindi movies, कानून के बहुत बड़े लंबे बहुत हाथ बहुत बड़े लंबे लंबे होते हैं. Yes, this is true, because if we fail to comply with the statutory requirements, we may have penalties, fines. That will be the minimum thing. If we are very good with the licensing or the legal or the government agencies, then it can be minimized to fines and penalties. But it can escalate up to suspension of services also. Many organizations, for not updating their licenses in time, put suspension in services also. And not only suspension or penalties, the hospital loses its name, fame, and reputation. And sometimes, if it is being highlighted by opposition, by government, by social media, or the news media, then the hospital may be closed also. So we have to be very, very careful. Now, the hospital licenses can be categorized in various categories. So I have divided into 8 major categories. One, the core regulatory licenses. Second, facility management licenses. Third, clinical departmental specific licenses, pharmacy licenses, radiology department licenses, nuclear medicine licenses if you are having the services, then the radiation oncology related licenses if you are having or offering the oncology services, and many other licenses which can be clubbed together. Now coming to the core regulatory licenses. First, you have to have the clinical licenses of Clinical Establishment Act. So you have, before that also, we have to have the land agreement. If the hospital owners are the owners of the land also, so then it's fine. Registration in the name of the owner will be enough. But if the land is on rent or on lease, then lease agreement has to be there. Then you will be developing the building. Then permission from the municipality corporation has to be there. So that is to have the building design. Once the building construction is there, then occupancy certificate has to be there. After occupancy, again, we have to have certain structure related licenses that I'll be discussing. So first, we have to have the Clinical Establishment Act licenses. And this, to apply for this license, we have to have somebody in the administration who is from the medical background, say medical superintendent or medical administrator or the medical director. His or her documents will be submitted at the time of application. So it is not the CEO, it is not the hospital director who is from non-medical background. The clinical establishment license cannot be applied in his or her name. It is always in the name of the medical person who is heading the department. Say, for example, in my hospital, there are CEOs, there are CEOs, but the hospital clinical establishment license, it is in my name because it has been applied using my medical documents. Usually, it is a provisional document, provisional certificate, which is valid only for 1 year. Ideally, after 5 years, the government should issue a permanent license in the name of Clinical Establishment Act. But in Assam also, probably it is applicable in Meghalaya also. So they are every year they are providing the provisional license only. And in that license, if you closely look at, the department, the scope of services which we call in the NABH or any other language, the services which are provided or offered by the organization, those are included in the clinical establishment license. So once we have the clinical establishment license, another two registrations, registration under Shops and Establishment Act has to be there. Again, it is issued by municipality board. In Assam, it is municipality board Kamrup. Since it has been taken from my hospital, so I am referring Kamrup, Assam. Then registration with local authorities has to be there. Usually it is again by municipality authority or by village panchayat in rural areas. Again, this is also valid for 1 year. Then after having these clinical licenses, then we have to have the pollution control board certificate. So it is issued by pollution control board of the state, and before starting the operation, clinical operation, we have to have this particular license. Usually it is granted for 5 years. In between there will be multiple inspections. Now the fifth license we should have related to PCV only. It is consent for water, then consent for air pollution, and authorization under hazardous material. These three licenses again issued by Pollution Control Board. Here, one thing I have to mention: if the hospital size is more than 50 beds, 51 to above, then we have to have the licenses, additional licenses for water and air. If it is less than 50, then pollution control biomedical waste license is enough. NABH is also asking that only if the hospital is more than 50 bedded, then additionally we should have water and pollution air pollution licenses. Next, facility related some licenses. Fire NOC. Usually it is issued by the state fire authority for 1 year. Here, one important thing is that all the clinical area where patient care is offered, all areas to be applied or covered under the fire NOC licenses. Say for example, in the terrace, you are keeping the MRD department, or in the top floor, you are having the MRD department or canteen. Patient goes there, or patient's relative, visitors, they go there, or patient's food is coming from the canteen, then we have to include that area also under fire NOC audit. Because in the fire NOC, whatever license you are having, probably if you give a close look, you will see each and every area which are audited by the fire emergency department, it is included and mentioned, and during any of the inspections, those areas covered in patient care area will be checked, verified in the license also. So it is always important to include all patient care areas from the hospital in the fire NOC. Even in some of the hospitals, the administrative block is not included in the fire NOC. But that is again observed as non-compliances by many of the authorities. Because even if you are not keeping patients there, but the people who are giving patient care are working from that place. So we have to include that administrative block also. Next, building occupancy. Once, as I already mentioned, once the building is like ready for occupying, then we have to get the occupancy certificate also. That is one time. Electrical installation, yes, that certificate also we should have. That is one time license. If the hospital is storing, then like medical gases, then we have to have the peso license. That is usually valid for 1 to 5 years depending on the state. Then if you are having leaves, ideally most of the hospitals should have a separate leave for patient and separately for other activities. So you have to have licenses for those leaves also. Usually it is valid for 1 year. Now clinical department specific licenses, if the hospital is having blood bank or blood center, then separate license from a state drug controller should be there. And those hospitals having blood bank licenses or blood center licenses, they know the pain of getting the license, blood bank license especially, because it goes through lots of inspections, assessment from office to office. There will be NOC from the age control society, there will be NOC from the state drug controller office, there will be permission finally granted from CDSCO. So it goes through lots of checks and balances, lots of renovations happens. You have created the design for the blood bank, then the inspector will come, they will go through the drug and cosmetic act line by line, ward by ward. If there is any deviation, they will ask you to change that. If there is some structural non-conformity, then also they will ask you to demolish. So it's a very, very tedious job. And another important thing I have to mention here, last year only, this regulation came. Those hospitals or those blood banks which are not situated within the hospital premises, they will not be granted renewal license. If it is hospital based, I'm repeating again because this is a new edition, new information, which is very, very important, because many of the hospitals or many of the blood banks, they have suffered a lot because of this new notification. If the hospital, if the blood bank is hospital blood based blood bank, and if it is located outside the main hospital premises, then renewal license will not be granted. And those blood banks which are licensed as standalone blood bank, they will get the renewal, but not the hospital based blood banks. And they are not going to CDSCO or state drug controller authority, they are not going to entertain any license, new licenses applied as a standalone blood center. Hope I am clear. If it is old blood bank, hospital associated but located outside the hospital premises, no renewal licenses will be granted. You have to accommodate, bring that blood bank within your hospital premises only. If it is standalone from before, renewal will be happening. If you are planning to apply as a solo standalone blood center, then you should not apply, because it is not going to be granted. Next, MTP license. Again, here also it is a lifetime license. There are two categories of licenses. One, usually, commonly, most of the hospitals dealing with obs and gynae department, they will be having license for 12 weeks. 12 weeks of gestation, you are allowed. But nowadays, very recently, they are granting licenses up to 24 weeks of gestation. But before applying for 24 weeks MTP, you have to invite or apply for application. The expert team will come and will assess the complexity or the infrastructure or the talent you have inside your hospital to deal with complex pregnancies up to 24 weeks. Otherwise, it will be 12 weeks only. So this is the new thing which is happening in Northeast. Then registration for transplant. If you are having any transplant program, cornea transplant program, renal transplant program, liver transplant program, so you have to have separate license. That is usually valid for 5 years. In my hospital, we have license for renal transplant from 2013. Many renewal happens, and very recently we got the license for liver transplant also. Now coming to pharmacy licenses, there are three major licenses: drug bulk licenses, then retail licenses, and narcotic licenses or NDPS. So drug bulk licenses or retail licenses, they are usually controlled and issued by State Drug Controller Office, and narcotic licenses, it is by the DC office. And the first two licenses are usually granted for 5 years, and after 5 years every year they will be doing renewal. And narcotic licenses is issued for 1 year. And there are few other important things which should be known to everybody who are using or who are having narcotic licenses. One, the consultants or the doctors who are authorized to use to prescribe narcotics should be included in the license. The author, their name should be sent. It is usually the anesthesiologist. They are by default entitled to prescribe narcotics, but other doctors who are not from anesthesia background, but they also need to prescribe, then you have to get the authorization in their individual names. So hospital can do that. It is usually granted. And another important thing regarding narcotic uses, every vial count is very, very essential to get the renewal. So the broken ampule count, the broken ampules also needs to be returned to the like DC office while applying for renewal license. Then if there is some discrepancy in the procurement and the uses, then the license is not going to be renewed. So this is very, very important regarding prescription, administration, discard, and returning of the broken ampule. So these are the, in any inspection, whether it is NABH or NABL or any other Caho audit, this will be like verified in detail. Now, radiology related licenses, except one, all other licenses are issued by AERB, Atomic Energy Regulatory Body. Only PCPNDT, it is issued by the Director of Health Services or Additional District Magistrate. It is in the name of the machine which is used to do the scanning, or it, and also it is in the name of the doctor who will be getting the approval. So who are the doctors whose name should be included? It is the sonologist, it is the cardiologist who are doing echo, and even it is not for the echo machine or the ultrasound machine, even for MRI also, the doctors who are reporting the MRI, who are involved in the MRI activity, their name also should be registered in the PCPNDT Act. This is one important information, and the rest of the other radiology related licenses are issued by AERB. Usually it is valid for 5 years, provided all the compliance related requirements are fulfilled as per AERB. What are the essential requirements? It is the annual safety reports, which needs to be surveyed and submitted to the AERB portal. There is a designated portal, ILORA, by the name ILORA. We have to submit the annual safety report, then download the submitted report approved by the AERB and keep it in your file. Only thing is that all licenses are valid for 5 years except the RSO, Radiation Safety Officer. It is usually valid for 3 years. There are different levels of RSO certification, RSO 1, level 1, level 2, level 3, depending on the extent of services or scope of services you are offering to your patients. If it is diagnostic, then RSO level 1 is enough. So who can be like RSO level 1? It is radiologist or any senior technician who has some knowledge in the radiation functioning. So even if it is a radiologist, nowadays to apply for RSO certification, The radiologist has to go through their training model. At the end of the training model, they will conduct one exam, and the radiologist or the applicant has to clear that. Then only certificate will be issued. Now coming to nuclear medicine department, I am not going into detail of this nuclear medicine departmental licenses. Here also, most of the licenses are valid for issued by AERB. All the licenses are issued by AERB and valid for 5 years except the RSO level 2. If it is nuclear medicine related, it is level 2 license. Level 2 RSO certification has to be there, which is again valid for 3 years. So any staff who is trained in radiology with physics and isotope handling, he or she is eligible to apply for RSO level 2 certification. Similarly, if you are offering radiation oncology, then you have to have level 3 RSO certification, which is again valid for 3 years. Who can be qualified? A medical physicist. Usually the ideal candidate for RSO level 3 certification. Employee and administrative related licenses. These are common one-time license or registration. It is employee provident fund registration hospital should have. Then employee state ESI, then PAN, labor license, GST registration. These all registrations needs to be in place. Now other licenses, if there is canteen, if food is service offered to the patients from the hospital side, then F&B license has to be there. From municipality board, it is usually valid for 1 year. Then methylated spirit, denatured spirit, then methyl alcohol. If you are storing, then you have to get the approval from DC office. Valid for 1 year. License to possess like rectified spirit, DC office again. FSSI license, that is again issued by Food Safety and Standard Authority of India. It is usually valid for 1 to 5 years. Then there will be many MOUs. Suppose you have license from Pollution Control Board, but somebody will be taking the biomedical waste and treating for final disposal. So you have to have MOU with the approved vendor, which is approved by your state pollution control board. So one MOU has to be there. If you are having ambulance services outsource, then you have to have a MOU. For all outsourced services, you should have MOUs. Only important thing is that in MOU, it should not be in the letterhead of the vendor or the hospital. It has to be in the legal stamp paper with all the 16 or 20 clauses are there in MOU. In any standardized MOUs, those clauses has to be there, and there should be one element mentioning about the quality assurance or quality assessment, how you are going to assess the performance or the quality of that vendor. You have to mention something in that particular clause.
Sorry to interrupt. 5 more minutes.
5 more minutes. Yeah. So these are the licenses. There should not be any non-compliances, because it is going to put the hospital in very difficult situation. So how to manage? There are few important things you can think of. There are many other ways you can design in the hospital, but you should identify somebody who is accountable, who is responsible for keeping the track of the licenses. Ideally, in most of the corporate hospitals, we have compliant officer. In your hospital, you can designate that responsibility to a senior person who is having fair understanding about the statutory requirements. Second, once the responsibility is delegated, then he or she can put a tracker, and tracker will help in keeping the documents in a proper sequence, and the next renewal date, those things will be kept as a like reminder. Then you can take the you can visit the Caho website, where they have designed, beautifully designed statutory compliance tracker. It is easily downloadable, and you can use this info like checklist for the hospital compliance management system. Then you make you like build a good relationship with all the licensing authority or officials, because at any moment you may have to approach those departments, because it is a like ongoing relationship. So you have to maintain a very good relationship with the licensing authorities, create SOPs in a very simple, in a understandable way, so that not only the top officials or the senior executives they understand, it is also important for the junior level staff to have a fair understanding about the license or statutory requirements. Then there should be internal or external audit. In most of the corporate hospitals, there is a designated compliant officer. There is a defined portal. In my hospital, we have a designated gold portal where all licenses are scanned and uploaded. The like timeline is fixed. Whenever there is the license is going to be expired, 90 days before, signal auto trigger is popped out. Then the second reminder will be at the 60 days prior to the expiry. Then next third reminder comes 1 month 30 days before expiry. So there are repeated reminders, so it can help. And if internal people are trained enough to do the internal audit, then we can, after internal audit, deficiency can be identified, close. Sometimes it may not be possible for one person to go through all the licenses, because from time to time there will be, as I already mentioned, 2 3 notifications came very recently. So that may not be known to one person might forget also. Then if you involve your internal team, that can be a very useful thing. Then you can call external people. For us corporate hospitals, it is very easy. There are corporate team who are constantly reviewing our doing our compliance audit. But for smaller hospitals, inter hospital audit can also be conducted. Somebody can be invited from this hospital to another hospital, and vice versa, that can be created. Then Caho is offering different types of external audits, fire safety audit, electrical audit, that also can be used for internal improvement. Then have a very good relationship with the local vendors, have tie-up. Then you can engage biomedical waste. As I already mentioned, biomedical waste collector or final disposal or treatment facility. Then fire extinguisher services, you can use local vendors. Radiation safety and calibration purposes also you can engage. Then for AC maintenance or HVAC maintenance, we can use local vendors. Then we can use this Google Drive or Dropbox. We can scan it, keep it in separate folders. Internal training, as I already mentioned, if the responsibility is assigned or known to only one person, then there will be there is a high possibility of having some deficiencies. If many people are involved and trained, then the chances of having non-compliance is very less. Then the licenses needs to be displayed. The hospital clinical establishment license, that needs to be displayed in radiology department, the PCPNDT and the RSO licenses. There are many licenses which needs to be displayed in different locations. That also can act as a reminder. And do not, already mentioned in some of the previous discussions, we should not blindly trust or depend on the external outsource agencies, because they will come, they will do their work and they will go off. But again, after some time, you have to struggle. So it's always better to like train our internal people so that we are empowered, we are trained enough to see or to do internal audit from time to time. So compliance is a team responsibility. It should not be delegated or dependent to, we should not be dependent on a single person only. So I'm ending my topic with a quote by James Clear, who is the author of the atomic famous book called The Atomic Habit. The person who learns the most in any classroom is the teacher. And I'm by presenting, by getting this platform, I learned a lot because I had to go through many references, many like topics, many articles. So probably I learned because of the opportunity I was given by Caho and Dr. Pramod. Thank you.
Thank you, Dr. Hirak. You have clearly explained the importance of hospital licenses. It is associated with patient safety, quality care, then for legal purposes also. So as we are running out of time, so we'll take questions after this session. So our next speaker is
Can I?
so welcoming our next speaker, Dr. Pramod Paharia. He is we all know already about him, certified quality implementer, Lean Six Sigma Green Belt certified, certified healthcare risk manager, principal assessor NABH entry level program, assessor CGHS, ECHS empanelment, state chairman CAHC Meghalaya, and faculty Caho and NABH program. So his talk will be based on step-by-step guide for NABH entry level. So over to you, Pramod.
A very good evening. I know a tiring day, busy day, right? Lot of presentation, one after another people are coming, talking so much, trying to give everything in one shot, tough job. And on the midst of this, I have come up with the topic which is hated by most, NABH, right? He has already guided you. Dr. Hirog has already guided you about the licenses. And I know already from the previous session, NABH is one of the hated most word today. So, but let me see, let me start. I have no choice. I have been given that. So I have to do that, right? Let us just think for a few seconds exactly why I am coming to this topic, right? Can anyone tell me what's so common about this? NABH we know, right? NABH, something is there here, but what it is? Yes, corporate hospital, correct. And NABH accredited, right? What more? Anything more on this? Big brands, yes. Everyone wants an Audi, right? Not everyone like Maruti. I am not against Maruti, but just giving an example. Because everyone like an Audi outside, right? Why? Still a four-seater? Still a four-seater? Safety, quality, class, everything we are talking about. That's the brand which we are looking for. These are meaningful logos. And let me come to it why. These are major private sector hospitals, covering around 35% of the share in the healthcare sector. And from these, they are giving you 70% treatment value. Why? If any one of us gets sick now, how many of us are willing to get admitted in Supercare Hospital, Bethany Hospital, Nazareth Hospital? And how many of us are willing to go immediately to Fortis, Max, Apollo? Right? Question to ponder. Question for you all. How many? We go with the brand, right? Why? Why we have so much confidence in these organizations? Why? These whys are coming again and again. And that's what I will be talking about. Because see, these organizations which we are talking about, Since 2014, they are being accredited by NABH. And from time and time, with repeated inspection, with repeated assessment, what is happening is they are raising their bar. They are raising the quality. They are raising the patient safety aspect. And I am not going to talk about details on all this. My part is to start the stepping stone, that is the entry level. Okay? So let me come up with my topic, step-by-step guide for NABH entry level. So what is NABH entry level? We have talked about full accreditation. So basically, it's the first step. Focuses on helping hospitals meet the basic quality and safety standard. Okay? Just basic standards. We have so many standards and objective element to cover when we are looking at the full accreditation. When we are looking at entry level, they are far low. Roughly not even one, roughly, I can say 1/4 or say nearing 1/5. These standards, they actually serve as a framework for improving hospital over all performances, okay? And increasing the patient satisfaction. Ultimately, what we need is a satisfied customer. And our customer is primarily who? The patient, right? So we are talking about this. Accreditation, on the other hand, if we go ahead, is a self-assessment and external peer assessment process used by healthcare organization to accurately assess their level of performance in relation to established standards, okay? And then to implement ways to improve it. Presently, the 6th edition is going on. Now, when we talk about entry level, this actually was brought out later on by NABH because they found that the smaller hospitals were finding it difficult actually to cater to those high demand of going with 600 plus objective elements. And then obviously they were faltering. So, and plus the cost. So what happened? Most of them were not trying to get into NABH. NABH came up with this entry level structured pre-accreditation standards and objective elements, which were targeted to smaller hospital, mid-sized hospital. We are talking about less than 50 bed, talking about 50 to around 100, 150 bed hospital. Okay, their budget does not match with the one part of budget of Apollo group of hospital. That's the difference, huge difference, right? But then what exactly do these hospitals get? They can establish quality, bridge the gap, standardize care. We are talking about foundational quality and patient safety aspects. We are talking about a stepping stone towards full accreditation, and we are talking about consistent processes that ensure that every patient who is coming to your organization is safe and receiving a high quality care, right? So what exactly is the importance of NABH? Sorry. Enhancing patient safety, streamlining operational procedures, building trust, and improving clinical outcome. When a patient enters in your organization, if he or she knows beforehand that the say surgical safety, that the surgical site infection rate in your organization is not even 1%, how safe do you feel? Okay, if operation is done, the chance of getting an hospital-acquired infection from this organization is minimal. Will you not be happy with that? Why you go to 40s? And when you inquire about a surgery, you need a, suppose if someone requires a knee replacement, what do you ask? Who is the best doctor? What is his success rate? What are the chances of getting an infection in the operated knee or operated joint, right? What are those? HAIs? Why do you need them? That's what we are questioning. That because we are requiring beforehand these rates so that we are sure that when we are operated, our chance of getting that infection is equally the same. Or that means almost nearing zero, right? Now, this zero does not mean that we are not auditing and we are saying that we have zero medication errors or zero HAIs. We are talking about a procedure where the processes are being monitored and then the rates are nearing zero, right? So we are looking at those. So HCOs, when we say we are looking at basically more than 50 beds, like Dr. Irok has correctly said, 51 and above. And SSCOs, when we are talking about less than 50 beds, and they have accreditation levels also for them, right? So we are talking of entry-level certificate for this organization, and we are talking about full accreditation guidelines also, right? So these are the entry-level edition 1. This is for SSCO, this is for HCO standards. When any of the organization is preparing or coming forward, they will be looking and referring to these guidelines. What we have moved forward from this month, or say from 1st of March, these two will go obsolete and this will come into place. That is the NABH 2nd edition. The NABH guideline second edition covers now both the part, that means SSCO and HCO. We'll come to that, don't worry. These are the 10 chapters. These 5 chapters, AAC, that is access, assessment and continuity of care, care of patient, management of medication, patient rights and education, and hospital infection control are for patients, patient related, okay? And these are management related. Continuous quality improvement, ROM, that is responsibility of management, FMS, that is facility management and safety, HRM, that is human resource management and information management system, IMS. The change, there is no longer called CQI, it is now called PSQ, patient safety and quality. Okay, so that's the major change over here. And this has changed now. HIC chapter has been changed to IPC, infection prevention and control. So there are 2 chapters which has the names have changed. There is no longer hospital infection control. We are talking about prevention. So it has become infection prevention and control. Okay. So standards, these were the earlier one. Since it's almost obsolete, let us talk about the second edition. We have 10 chapters, 46 standards, and 189 objective element. And of these, 122 are core, 35 are commitment, and 32 are excellence. So what's the difference? Let us assume one organization is planning to start now. Let us start the journey. Let us go for NABH entry level. And let us assume this hospital is more than 50 beds. Okay? 51 bed, 55, 70 bed, whatever you call it, right? So what are the standards in the first assessment they will get? They have to comply to this. 122 plus 35, that is 157, okay, objective element. Whereas, if suppose it's a less than 50 bedded hospital, they will be primarily targeted to 122, okay? When they go for next assessment, SSCO will cover this much. Whereas HCO, that is more than 50 bed, has to cover plus 32. So for SHCO, less than 50 bed, it will always be these 2. Till we come up with the new change after 5 years or so. These 2, that is 157 objectives elements which needs to be covered. For HCO, it will be plus 32 from after 2 years. So it's a continuous journey. Start with these 2. Go ahead after 2 years, add another 32, right? And if you are good, go ahead, go for the full accreditation. So, eligibility criteria, can everyone apply? Yes, definitely. But something is required. NABH is having, specifically for entry level we are talking about allopathic hospitals only. We are talking about functioning for at least 6 months, okay? So today you have opened and tomorrow you apply. No, right? That is wrong. And a minimum 30% bed occupancy. Now this again has changed. They have come down to even around 15% you can apply. Conditions are there. But in general, 15 to 20% also now can apply for NABH. Okay? So what you need, basically a 6-month functioning allopathic unit. If you are combining with Ayurvedic, Unani, that means Ayush, you cannot apply for these standards. Okay, they have different standards again, so you can go for it. Next comes the certification journey. So it's a big, right from application to prepare actually for that one, go for assessment, go for review, and then certified. Long process. How much time will say? Let's prepare. Let's see. So we have what? We have, sorry. Let us do in step 1. Where do we stand? If suppose we have a new organization, where do actually we stand? Are we really complying to it? Let us do a self-assessment. Okay, look at the hospital standard or whichever standard is applicable to us. See that you can apply, go with that at least for 3 months, right? If you're consistent with that, you have achieved, that means you can proceed with the next step. Okay, the next step in between is to form a team. Don't give only a quality person that look at the assessment. We need this NABH certificate in 6 months. You have to get it for us. It is not available in the market. You cannot get it. So you can't ask your team, ask your one person to do it. It's a teamwork. So where do we stand? Who is required? The first and foremost, which sir has rightly mentioned in his previous session, that administrative will. If you need an NABH certificate, we need the administrative will to participate. So that's why that slide I have not put. Because without that willingness of the administration to get this, without the willingness of the administration to be ready for this or to raise the bar of quality and safety in your organization, it doesn't make sense to talk about anything else here, right? You have to be NABH ready every time. So form a team. Now this team is multidisciplinary and this team has got assigned roles and responsibilities. Okay, you have clinicians, you have nurses, you have doctors, you have safety officers, you have quality members, you have infection control people, so many. You need members from each and everyone. Even your IT person will be required. Even you need representation from your paramedical staff if you really want to work it nicely. Teams. Now committees, how many you need? So many. So the committees, you have so many committees, but actually do you need so many? See, blood transfusion committee, if you have a blood center, that is mandatory by NACO. That's why you need. Internal complaint cell. If you have more than 10 staff, female staff, as per the law, if you have more than 10 female staff in your organization, you need an internal complaint cell. Does NABH say so? No. It is required by mandate, by act. Come to others. Okay? Pharmacy and therapeutic committee. If you have a pharmacy, you need a pharmacy and therapeutic committee to handle. Infection control is the teamwork. Again, so you need a team. Hospital safety will require a team. You need an apex team or you need apex as well as quality team to work. And you need a documentation because we were talking about so much of documentation. That means we need someone to actually look at it, right? So we need a medical record committee. These minimum 5 committees actually are looked for when entry-level assessors like me, we go for assessments. We see whether you have. Now, I have only 10 employees in my hospital. How will I form 5 committees? I will give 2 members in each team. Correct? Yes? No. I can form one team, maybe of 2, 3, 4 members. They will meet at different interval with the agenda required. You don't need to hire more people. Don't do. Not required. It's your understanding. As I said, it's as sir was also Dr. Hirok was saying that time that your intent is required. If you really want to progress, you have to work for that. It's not about having a lot of people or a lot of documentation. It's everything that is intent. Statutory requirement, he has talked about everything. I will just stress that you need primarily these licenses when you are looking at a smaller healthcare organization. Registration, it can be shop and establishment, it can be trade license or anything. Pollution control, if you're less than 50 bed, you need only one pollution control certificate. More than 50 bed, you need for air and water also. Then MOU with third party, because biomedical waste disposal will require that, and fire NOC. Fire NOC has become a mandate for overall. In some state, you get an exemption if your building height is less than 15 meter. Okay, so that depends again on the state to state. So it does not go like, no, it has to be mandated. So I will go to, say, Tamil Nadu and ask them, yes, you have to give me like this. If they have, it is applicable for them, yes. If someone comes from there to Meghalaya, we don't have a licensing authority. So what to do? It may not be valid for me. It may be like this. Fire NOC is valid for us, but then there may not be defined criteria, right? So the step 3, documentation. Lot of documents to prepare. Has NABH given a mandate as I has asked earlier session? No. There is no mandate. What document you require? What you need is whatever processes you are following in your organization, please have a defined, a documented policy or SOP for it. See, if you are doing in your lab, if you have something, you have SOPs, one page like that. After this, you do this. After this, you do this. Like step by step you have given, right? Similarly, for everything else, just prepare SOPs and that's done. Have registers. Emergency patient are coming. You need a record. This NABH does not want. The organization, the director, administrator, they will ask you for it, right? Admission record, discharge record, they are asking already. Why you need more? We are not asking anything new. What we want is, if you have defined it, we want them to see. Now you have kept registers after registers there, but you're not doing any record. That is non-compliance. Okay. Other thing what you need, infrastructure related. Lot of infrastructure related, that is ventilation, safety, maintenance, accessibility, so many things. You have a 3-storied building, no lift. Acceptable? And your OT is in the 3rd floor. And you have orthopedics neurosurgery in the scope. Will you be accepting it? Leave aside accepting it. As a patient, will you be ready to go there? How will you walk to the third floor? A stroke patient, how will that patient walk? Not possible. So do you think the NABH will comply or agree to it? That's where NABH will say objection, no. It's not safe transfer. Will you carry them in the wheelchairs and trolleys to third floor? Will it be acceptable? No, there is risk. So those things will be looked upon. So start the application now. Once you are ready, 3 months implemented, everything, start the application. Look at what is required. You need to upload the self-assessment toolkit. That means the gap analysis report, which you have done 3 months back, and the re-audit report. You have to upload all the mandatory documents, your license, fire NOC and all, which I was showing that time, 5-6 documents, and go with the fee payment. So fee structure, it has come down significantly. The rates have been slashed, and earlier it was yearly fee, okay, which has come down to now like this. So number of beds according to that. And you see 300 beds and above, now it is entry level is not applicable. Except for public sector. Everywhere there is a condition apply, no? Asterisk condition apply. So here the condition applied is government sector, public sector is allowed more than 300 beds. But private sector up to 300 beds, only the application is there. And these concessional rates are applicable till September 30th of this month, this year, and then there will be some changes which may come. Okay. The process, start filling the application. There will be a desktop assessment. There will be 2 cycles of NC closure. If there are any gaps, non-conformance, there are some differences. They will allow you two steps. 2 steps will go. Once we have cleared those part, then we can move to the on-site assessment. Again, 2 steps of NC closures. And then if the committee reviews and find it good, you get the certificate, right? So registration, you get all the document and all, fee submission, everything done, you get a permanent number. With that, you go ahead for assessment. If there are NCs, close the NCs. If there are no NCs, directly go for on-site assessment allotment. If there are NCs, if they are accepted, you go ahead with the on-site assessment. If rejected, you reapply, right? So once on-site assessment done, same thing, assessment will be done by the on-site assessor. NCs, if they found, they will raise it. Close the NCs. If it is accepted, you go for, it will move forward to certification committee. In case NCs are rejected, your application get rejected? No, because it still goes to certification committee and they look thoroughly again whether your things were correct or not, assessor has correctly judged or not. Okay, so rejection or acceptance of your application is not on the assessor. It is on the certification committee who reviewed it nicely and then only decide. Sometimes we accept, they reject. Sometimes we reject, they accept. Many times it has happened. Okay, once they accept it properly, then what will happen? Your certification committee, either they will, if accepted, they will grant, you can get the certificate. If not, they will go out. So let us quickly see what benefits are we getting. Community trust. You have the NABH logo displayed. You announce that we are NABH certified. You start getting the confidence on the patient who are now quite educated. They know very well. When you say that we are NABH compliant, they know, okay, they have got some certificate, they've got some branding. Your footfalls increase. You get other benefit because you ensure that now patient safety is there. You ensure now also that you can go for insurance empanelment like CGHS, ECHS, Ayushman Bharat, and you get benefit. Okay, every organization is getting benefited when they are going for this. Ayushman Bharat is making it mandated. Why this NABH stock has come out? Because all these insurance scheme has come up with the thing, with the catch that there is a hike. If you get certified, you get 10% increase in your bonuses. And if you are accredited, you get 15%. If you are a teaching institute, you get another 10%. For certificate and accreditation, 15%. Again, you are situated in a metropolitan city, you get another 10%. Imagine, from 100, it became 130 or 135. Good, na? And that's good only the administration wants. Why the directors, administrator, they want NABH certificate? Because of these numbers. Okay? First reason why they want is because of this number. 100 is not enough, 130 I want. Simple. Right, ma'am? Right, sir? You are there, so you know this very well. But is it the only benefit you get? No, you are getting this community trust. People come there because of this. And you have a system, now a quality roadmap is set, because you have to set the standard high always. You have to continuously work for it. You have to certificate, the accreditation is not the end, actually just the beginning. Once you get it, then you realize, अरे इतना कुछ किया, अभी तो शुरुआत हुई है. क्यों? क्योंकि अब हमें काम करना है. Now we have to sustain this. That quality sustenance is not easy, right? So documentation management, infrastructure upgrade, and compliance checking are our major challenges. Everyone agrees? Documentation management, we have discussed already, a short debate was there on documentation. And believe me, if you properly do and if you properly put your minds together, your documentation will cut down. Everything actually improves. The processes, if they are tracked well, instead of going circular, you will come in a straight line. You will follow for everything the critical pathways. And that's where it matters. We try to go with a different course for lean management. What is lean management? It is just simply that do your thing right and remove the waste what is there. Typical certification timeline, 1 to 3 months for preparation, 4 to 6 months for implementation, right? Then comes application review, assessment, and by 12 to 18 months, you get your certificate. That means if you properly do, your organization will need around 12 months to 18 months to prepare. Get your certificate. Is it true? No. There are actually simultaneously things are going on. So if you start from 6 months, by around 12 months or 9 to 12 months, you will get your certificate, right? It's not 12 to 18 months, but yes, if you do properly. One question was, or one point was continuously being raised by most of the speakers today, that don't believe on the consultants, right? But may I ask, where is the solution? You don't have consultant, but I need someone to guide me, no? I don't know everything. What to do now? Where will I go? Whom to look to? We need someone, no? NABH has come up with a solution, and that's called NABH E-Mitra. Entry-level assessors, entry-level hospitals, smaller hospitals, you don't have to pay money to the consultant and get a copy-pasted SOPs and manuals from Fortis, Max, Apollos, and all. You don't need them. They will not explain your hospital. They will explain others and will give you, this is done in Fortis, you have to do. No, please don't do that. You don't need to do. Go with your center, go with your organization. I was involved with one of the hospital in Meghalaya. I can't name it because of other issues. But then I told them the same thing. They worked it well and they got their NABH without any problem. That's how things work. So NABH E-Mitra, what they do? It's a comprehensive online platform launched by NABH. The purpose is to assist the SCOs and SSCOs in smooth understanding. Just type NABH E-Mitra. Go to the website. You have ready-made documents over there. Downloadable format. Just download and edit according to your needs and it's done. Your SOPs, document, policies, forms, formats, whatever you need, it's ready. You need a template of narcotic register, it is there. You need how to document the medicines, medication charts, it is there. Why to look for others? No need. And this is a digital bridge actually now. So in fact, NABH has come up with Quality Connect, okay, Gunvatta Yatra program, and NABH has come up with Quality E-Mitra. From E-Mitra, they have come NABH Mitra. People are getting trained, okay, who can come and help you. So many of the people, I think many of you from here have attended. You have attended? Okay. And he is a faculty for that program. So we are doing this. Gunvatta Yatra, we are running to explain about all these factors only. So accreditation compliance is not a one-time event, as I was saying, but an ongoing process and just the beginning rather than the end, right? So thank you so much. I hope I could finish on time. Any questions now? Licensing and authority, yes, and with entry level. Thank you.
Thank you so much, Dr. Pramod. And I think so we can now apply for the NABH ourselves, right?
Yes.
He have shown all the steps, right? How to apply in the portal. And NABH is a continuous process, okay? It's not a goal or target. So we'll have to continue with this. It is a commitment of patient safety, right? So coming to the participants, any questions from your side? Regarding, as Dr. Hirak has explained, regarding the license, hospital license.
Before before that, I just wanted to make a comment that I mean, like, I haven't seen anybody taking this NABH this passionate and very interactive and keeping them very awake in all these 10 programs, because it will be a kind of monotonous kind of things where people try to doze off. And I was thinking what Pramod is doing, this is more interesting than any clinical talk or something like that, making it more interactive. I mean, passionate and making it simple and interesting. Making NABH interesting is, of course, it is, I mean, like out of the world task. Good work, Pramod. Good work. I mean, it was really very appreciative. I mean, like all these 10 minutes, this was the best NABH entry level. I think I have to get this copy, video recorded,
Thanks
and
to
do
him
something.
being a full accreditation assessor, commenting. So a good feedback from another assessor. Thanks to him.
Yes, after this presentation, I don't think we need to hire any like self-proclaimed, right? Assessor, consultant, self-proclaimed consultant, NABH consultant, right? So after this presentation, I don't think so that we need. Yes.
Pramod, one question to you. Is there unlimited attempts for re-accreditation of entry level?
Entry level? Yes, sir.
Still there?
Yes, sir. Yes, sir. For less than 300 bedded, you can keep on trying. But yes, when we go, we always encourage them to come and get the full accreditation. Definitely, you are going to raise the bar. Who wants to stay with the same level all the time? Yeah.
Two questions to you also, sir. So in the narcotic license, we need to put the names of the doctors. So what does it actually mean? Means they are the ones who will prescribe, or why? Why do we need the names of the doctors?
Not in the license per se. You got the license. Ideally, it is meant for the intensivists and the anesthesiologists.
Yes.
But in your hospital, you will be having 2 or 3 intensivists or anesthesiologists. But your need coverage 24/7, 365 days. So in that situation, you have to involve more and more doctors. So in that situation, you have to like take out the list and get the authorization in their name.
So it is better to put everybody who will be involved in
yes,
administering
not
narcotics.
everybody. You have to be very selective, because in judicial uses might be there. That might be another issue. So that's why you have to be very careful while selecting the names. From emergency you can include 2 or 3. From ICU you can include 2 or 3. From neuro ICU you can include 2 or 3, and you can submit the names and get the approval from this office. That is one thing. I just wanted to I wanted to add one more thing. E-Mitra is there, and apart from that, there is one chatbot, Q Mitra. So it is a chatbot designed by NABH. It's like ChatGPT. NABH related, quality related, patient safety related, or objective element standard related. You ask any question in that chatbot, the NABH will be replying, giving like some kind of authentic reply. Till now, this Q Mitra is applicable for entry level assessment only. Entry level certification program. It has not been designed for the main accreditation programs, but gradually works are being initiated. So it will be like after some time, probably it will be available for main accreditation program also.
So another question. Ultrasound has now become an extension of clinical clinical examination.
Yes.
So what will be the status of all those who are doing POCAS, bedside POCAS, and under the PCPNDT Act?
Yes. So, sir, if I give you practical example from my hospital, in emergency, like ultrasound machine is there. In ICU also, ultrasound machine is there. So we have included everybody's name in the PCPNDT registration, so that they can use whenever there is any clinical need.
So it is better to include
It is
all of them.
always better. It is always better.
Thank you for the clarification, sir. Yes.
So coming to your question regarding the PCP and DT, we are of the opinion or view that it is only required for the ultrasound machine, right? But the guidelines say that any modality which is or can be used for determination of the sex of the fetus should come under PCP and DT. That is why Dr. Hirok has said that even MRI is used in that case.
Yes. For the PCP and DT, if you are having MRI or CT, that also actually required. Those CT is not to be done on pregnant ones, but still if need to cover. Focus also same thing. Yes, their name should be there, included in their list. That means in the state chapter. That means in the licensing authority, they will include the names. If they are displaying it on the license or not, that's not mandatory.
One of the companies, I won't name the company, they came up with a device, very portable device, which is, tagged with your smartphone. So whether PCP and DT is required or not. So that was one of the major distinct, because that is even more dangerous. Rather than carrying the briefcase like machine, you can put it in your pocket and then can go to the peripheries. And that is why this has come up so strong, in a strong manner.
Thank you so much for the two chairpersons and speakers for enlightening us with licensing and also NABH readiness. May I now request Dr. Seema Conver, Medical Superintendent Apollo Excel Care, to kindly come forward and felicitate the chairpersons and speakers. May I request Dr. Santanu Deb, sir, to kindly come forward. Dr. Gitartha Roy Medhi, kindly come forward. Request Dr. Hirak Jyoti Das also to kindly come forward. And Dr. Pramod Paharia, kindly come forward, sir. I request again the dignitaries, the chairpersons and secretaries and the speakers of that session to kindly come forward for the group photo session. Dr. Santanu, Dr. Gitartha, Dr. Hirak Jyoti and Dr. Pramod Paharia, as well as Dr. Seema Conver. Thank you. Now we will move to the next and last session of this program. Our next session will be on making small hospitals efficient. For this, I request chairpersons Dr. Babu Narayan, SHCO Chairperson, Business Officer and Head of Quality, Senior Consultant Physician and Diabetologist, GEM Hospital, Chennai, to kindly take the seat in front. Dr. Jeet Patwari, Managing Partner, Pinnacle Healthcare Consultants and Zonal Chairperson, Caho, kindly come and take your seat there. I request the chairperson to introduce and manage the session.
Babu, would you like to start?
No, Jeet, it's better you start.
You are my guest, so I think we should give preference to the guest, right?
No, actually, he is called as Jeet Da, and he's my senior. I cannot start.
If you don't listen to me, I'll convert the entire session to Hindi.
Actually, I'm trying to learn Hindi, madam, after coming to mostly. I'm trying my level best, and I'm trying to understand it. The last 2 months, I have understood more Hindi than in my entire lifetime. So, especially by the Jeet, whenever he tries to speak to me, he speaks in Hindi, and sometime in Assamese as well. And I understand fully.
That's a blatant lie. Anyways, so let's move on to the next session, how we make the smaller hospitals efficient. Now, when we talk about efficiency, what is efficiency in a hospital? Yes? Anyone? See, when we talk about any hospital or any organization, we divide it into 3 parts. One is the infrastructure, second, the processes, third is the manpower. When we talk about infrastructure, it covers almost the entire thing, the building, the systems, the engineering, and the other things. Processes will include your clinical processes, non-clinical processes. And the manpower is, again, divided into clinical manpower and non-clinical manpower. And again, out of that, few would be skilled and few would be unskilled. Now, when we talk about efficiency, we have got a very senior pediatrician, one of the most renowned in this part of the country, Dr. Debashish Das. I call him Debashish Das. But anyways, officially Dr. Debashish Das. Sir, welcome to the program. He is a senior consultant pediatrician and director of Children's Hospital, the only single specialty pediatric hospital in this in the state of Meghalaya. Recipient of Sishu Visheshagya Ceremony Award and Pioneer Award from IAP. Lot of things to say when we go about. And when Dr. Santanu sir is nodding, definitely it is a big yes. Right? Now, he will talk about efficiency from his experience in running the hospital. He will cover up the different areas, how we can make our hospital efficient. Now, over to you, sir.
Thank you. Thank you, Jeet, for that introduction. Chairpersons, Babu, Jeet, each and everyone present out here. Thank you, Pramod, and the organizing team for giving this opportunity to be here and to speak about something which, of course, Pramod had given me the topic. So this is what the topic is all about, the facility management. So let's think about what is a facility. When you think about a facility, what exactly is a facility? Anyone who can come up with what is a facility? We need to understand what is a facility. Now, then only we can think about the management part. So when you think about the hospital facility management, Jeet has mentioned about something. Now let's put it into 4 parts. When you think about the 4 parts, one, people, program, and the processes. See, that's one part of it. People, program, and processes. The second part, what are you doing with it? If it's a coordination of people, program, and processes, what is it helping? You are ensuring a safe, a compliant, and efficient environment. So that's the second part. So it's a coordination of people, program, processes, and then you're ensuring what? You're ensuring a very safe, compliant, and efficient environment. And through what? Covering that infrastructure. That is what he was mentioning about. The infrastructure will have all those things which you see, whether it's the ventilation, whether it's the power, whether it's the plumbing, whether it's the medical gas, everything will come into that along with the support services. So you see to it that the support services of cleaning, waste management, those are under support services, the medical equipments which are there in a hospital. So it's very essential that you understand what a hospital facility management is. People, program, processes divided into all these phases. Now, why is it so critical? You work in a hospital, you need to understand that it's a very, very critical part of it if your facility is proper. So now you think of it, your patient safety. If your equipments are all right, if your hospital-acquired infections are less, you are taking care of the patient safety. Think of it that if your hospital is all right, you're focusing on quality. That is your immediate aim. Focus on quality, and you are not thinking about the facility because you know that your facility is already in place. So you're focusing on quality. The third is the quality of care. So the quality of care comes up because your facility is proper. The cost, see, it manages the budgets. So that is these are the four things why it is critical that your hospital facility should be in place. Now this is the subdivision. Each and everyone will agree that these are the things which are necessary in the hospital. It's the electrical one, it's the ventilation, plumbing, medical gas, fire safety, security, housekeeping, biomedical. Don't you agree that these are the things which are required in a hospital facility? These are the things which are required, and see this, that in a hospital facility management, these are something which we call it the hard and the soft practices. So when you think about the hard facilities, lighting, HVAC systems, water systems, fire safety, they fall under the hard facilities. The soft facilities are something which we call it the cleaning, waste management, and security. So that is the soft part. Now, because the topic is myths and challenges, let's go by the myths which are prevalent when you think about the hospital facility. I shall go by this first. The first myth. Do you believe that in a hospital facility, you think about only cleaning and maintenance? That's the first myth which comes up. That a hospital is there, you think about just cleaning, maintaining that one, and that's all about. No. It's not only that, it's a broad discipline covering few things. Whether you save energy, whether it's sustainability, whether you see your support staff, whether you see your space planning, whether you see your IT integration, everything falls under this first condition. That it is not only of cleaning and maintenance, it covers up so many things. Think of this. If your hospital's facility is proper, we always think about cost-centric. But if it is managed in a proper way, you save a lot of your economic constraints. It's not an expense, but a value creator. You agree to it? That it is not only for large corporations. Each and every one of us, we have heard that we need to think about the smaller hospitals, the medium-sized hospitals also. So it's not only for large corporate hospitals, it's also applicable for the smaller hospitals. Do you think it's a one-man job? No. A hospital's facility can only be managed when each and every one of us work together. It's not a one person's job. So you need a team of experts. As I said, all those soft facilities, the hard facilities, each and everyone needs to come to place and to work together. It's not a one person's job. Does it not impact the business performance? It impacts. If your facility is proper, it definitely gives, it boosts your employees' productivity, comfort, and overall business satisfaction. Sustainability is one. If your facility is all right, sustainability is one thing which comes up. The softwares which are used, even if it is expensive, you might think it's expensive, but in the long run, it helps us it helps us in the long run. Outsourcing, of course, is costlier. That is something which depends on facility to facility. This is something which I wanted to point out. It's always said prevention is better than cure. You do not wait for something to break up. So if it is not broken, don't fix it. That is something in a hospital facility, we need to think ahead of it. We need to think about prevention. It's not that when it breaks up, then you start fixing it up. Now, when you think about the challenges which are faced, what are the challenges? Don't you think this is something which is important? This is a continuous challenge for each and every facility. You need to think about hospital-acquired infections. They talked about an NABH accredited hospital which has less of infections. So hospital-acquired infections is something which is always a challenge. You need your 24/7 operations, emergency readiness, the compliance which they have already talked, the regulatory compliances which are always necessary, the budget constraints which are always there in a hospital. In the small hospitals, the infrastructure. It's something which one needs to understand that after all, buildings and all also have their own life cycle. So aging is always a problem, whether it's the building, whether it's the medical equipment, aging infrastructure is always there. Your medical equipment, technology integration, staffing. Staffing is something, recruiting and retaining those qualified personnel is not at all easy for a hospital man. That itself is a challenge. The staff experience, the patient's experience, creating always a comfortable environment for each and everyone is not easy. That remains a challenge. And of course, the cyber security, which has come up now. But I put it in a different way now. Like all of you who are here and with our senior persons out here and the knowledgeable people who have all gathered here. This is something which I put it, the myth of natural profitability. The assumption which is there, I'm talking in terms of me running a pediatric hospital. I'm not going into the cycle of the other bigger hospitals. I'm just giving my experience of running a small pediatric hospital. The assumption is that when you are coming to a hospital, a private hospital is expensive. I'm not talking about the corporate hospitals. I'm not talking about a multi-specialty hospital. This is for each and every one of you to understand that running a pediatric hospital, a single specialty hospital, is slightly different than what we have talked about. This is the reason why in the concluding part, I'm just bringing up something for all of you to think and ponder. The assumption is that you're coming to a pediatric hospital, coming to a private hospital, it is expensive. Let me tell you, the reality is revenue is shallow. The overhead is very deep. Taking into account the pediatric population which comes to the hospital doesn't come to the hospital mainly for only sick conditions. They come for immunization, they come for routine checkup, does not give you much of the revenue. So that revenue is quite shallow, the expenses are quite deep. The wear and tear of a 24/7 environment. All the hospitals, they have a wear and tear. 24/7, someone or the other is using. Shantanu might agree with this, with the pediatric field as such. In a single room, you will have the mother, the child, and another attendant, which is in an adult-centric hospital, you have the adult and the attendant. Here you are dealing with someone more than, you are dealing with 3 persons continuously in one room, 3 or 4. The wear and tear of in that hospital is more than the one which is when you think about the other hospitals. I'm just giving an idea of what happens to a pediatric hospital, the challenges which are being faced in the pediatric hospital. So there is a constant depreciation, and what I said about the pediatric factor. I put it as human capital burden of the staff salaries. That itself is a challenge. The lean season in Meghalaya, in Shillong or something like that, when it starts from November to January or something, it becomes very difficult to even pay the staff salaries also. That I put it as human capital burden of staff salaries. It's not easy to run. That itself is a challenge for a pediatric hospital. It's a single specialty hospital. The fourth, which I put it as the self-generated expenses. You don't have a corpus. The challenge which is faced, you don't have a corpus. There's no central fund as such. And it's I call it a catch-22 situation. To make my hospital look nice and attractive and to see that patients are coming to the hospital, you need to see that the hospital is maintained spick and span. Keep it so clean surroundings, everything. You need to have everything in place. But to maintain that, it becomes difficult to stay profitable. The other challenge which is faced by a single specialty, I'm talking about the own, the experience as such. So it's not easy for any one of us to just send a patient for undue investigations. I would not like my patient to be subjected to a CT or an MR or something like that, unnecessary. The cost of a ventilator, the cost of anything comes up quite a lot. To take out that revenue is not easy for a small hospital. So it's nice, whatever we have discussed, it's all good, but at the end of the day, what I said, we need to maintain some balance where the patient's care and safety, and whether you do the tech upgrade and all those things, they are at a balance. So thank you all, dear friends. Whatever I had about the myths and challenges being faced, so that's something which I wanted to share with you. Thank you all, dear friends.
Thank you.
Dr. Pramod, should we take up the questions at the end of the session?
I think that will be better.
Okay. Our next speaker is Dr. Paul Dakhar, Junior Consultant Medicine, Diabetologist and Sonologist, AHA certified BLS trained and ACLS instructor. The trait which I know and what makes Dr. Paul very unique is the facility management and the risk management strategies which he can design. And that makes him very, very special in the entire Northeastern region. And that is why if you look at the last sentence, he is an eminent member of the state disaster management team. I think people from other parts of, the other states of the Northeast should, get benefited from a learned person like Dr. Paul. Over to you, Dr. Paul.
Thank you, Dr. Jeet, for that beautiful introduction. Well, I'm no specialist in technology, nor am I an IT professional. Okay, I'm a medical person given the task to talk about technology. I have my backup. I have Dhanraj and Thomas here to back me up in case something goes wrong. Well, I like to thank Dr. Debashish for standing me up just now because I was stuck in the OPD just now. Thank you, Deva. I bring you greetings from Nazareth Hospital. Well, this is when I first joined. This was the old hospital where I worked, Assam type building. And after many generations, so many administrators came. Then they were thinking, are we prepared for change? And some bold administrators said, yeah, I think we have to do some changes. And this is what we are now. So welcome to Nazareth Hospital. Well, I'll try to do justice to the topic which I've been given. What is technological solution? Well, just to talk about it, it's something about solving problem by the use of technologies such as machines, softwares, tools or systems. And in simple word, the technological solution that we use the technology is to make something easier, faster, safer and more efficient in healthcare setting. Now, the simple definition goes like this, that the use of tools through science to save and to solve the problem in the real world. So now, how does technology help? If you ask me, how does technology help? Well, in the earlier days, you have to go to the banks, fill up the withdrawal slip or the check, wait in line, then you can then it go the process to the teller. The teller will go to the other clerk who will check whether your signature is fine or not. Then only your money will be disbursed to you. But nowadays, you just go down outside of Nazareth Gate, you buy something, you just take out your mobile, scan the QR code, done. So that is called solution, technical solution. Solar panels. We had just a crisis this morning, which I had to run around. Light went off. Okay, the generator didn't back up. Something went down. So we had to put the second generator on so that you can have again this electricity. Now solar panels, they are another improvement where you spend one-time investment, you get a good result for that. Same thing about water purifiers. Dirty water is being made into pure water where you can drink. GPS, Google Maps. Who doesn't use Google Map now? Before I go out from the hospital, first I check the Google Map. Because the place where I stay, there's construction of 4-lane. And there's lots of traffic jam. So once I see in the map that, okay, there's red line. So I take the different route. I go through like core. So that is technology. And so many other things are going on right now in the world. So mean, why does this technologies are important? Because they save time and effort. They increase the efficiency, they improve communication, and they solve environmental problems and improve the healthcare and education. Now, technological solution for small healthcare organizations. Why it is important? Because most of the clinics, as it was told before, those less than 50 beds hospitals, where less manpower will be there, limited staff are there. But if you have technology, it saves. It saves. And when we talk about technology, about the solutions, we are talking about digital health. Right now, lots of even the deputy director of the health services today has spoken about the digital health which is being incorporated into the government sector. Now, what happens that these see, it's not that we're going to replace humans in the health sector. No, these will just supplement. They will supplement it by, we can have a close monitoring of the patient, and we can diagnose health issues with greater accuracy by using AI, and develop personalized prevention or treatment plans. And we provide a service, a wider service, which I'll tell you later on. What are those wider service which we had started earlier, then again we had to stop again. We are planning again later on, and this will improve the overall quality of patients' life. Now, are we ready for change? That is the big question. When we first started to get ourselves accredited by NABH, there were a lot of resistance from everywhere. Nobody liked to change the system, how it's work. We are very safe in our comfort zone. When we first asked the doctors to use EMR, they said, no, we don't know how to type. We do not use computers. How can we change? Now, once you have accepted that, the most important thing is interoperability. Now, this is a big word, okay? Interoperability. Now, this is the thing which you should know. You should have, because different apps will be there, different applications will be there, softwares will be there, and these should be able to work with your hospital information system or the electronic health system. Now, if these doesn't work, then you may have problem. Now, let me talk to you a bit about what we can do as a small and medium-sized hospital. Number one, I'm going to talk what we have done here at Nazareth. The electronic health records. This has really changed a lot. What it does, it stores the patient's record digitally instead of paper files. That means papers are all out. Our OPD is totally digitalized. You will not see any paper in the OPD. Okay. Now, the digital system that provide the authorized providers with instant access to comprehensive, up-to-date patient medical history. That means once you open the EMR, all the history of the patient will be there. The name of the patient, the age of the patient, the address of the patient, all the past history of the patient, the past records of the patients. Everything is there at your, tip of fingers. And for that, to have EMR, you will need what we call high-end servers for storage of all these data. Now, what are the benefits of having this EMR or the electronic health records? Number one, as I said, easy access to patient history, easy retrieval of patient's record. And then number two is reduces paperwork. It reduces a lot of paperwork and reduces the cost of papers. Now, if you tell me how it reduces the cost, one example I'll tell you is that if you write in a paper, you find something is missing, you just crumple and throw it. Nobody keep records of the thrown crumpled paper. So how many thrown crumpled papers will be there in 1 year? Just imagine. That is being abolished by using digital system. And it prevents data loss. It prevents data loss means once you have input all your information in the electronic health records, that stays there. Now, if you put it in paper, if you search after a month or a year, some of the pages will be missing. Some of the pages will be missing. Then again, you will not get those records. And the services is very fast, and it reduces your storage spaces. Let me tell you, even Nazit now has got 3 separate buildings. We still find constraint in finding place to keep all those, files, records which we have. Why? Because how long you have to keep the general files? 10 years, correct. 10 years you have to keep. Just imagine the amount of papers will be generated in 10 years. It will be huge amount, and you will not find space to store them all up. Forget about MLC, medical legal cases, all the other files which you have to keep lifelong. So electrical health records gives you the benefit of storing unlimited amount of records. Now, once you have done that, once you have had an electronic health records, you can integrate, we call it integrations, you can integrate these with the different departments, provided, as I told you before, the interoperability is there. Now, for lab, I'll give you an example. For lab machines, people will bring with different softwares. Now, that software should work with your EMR. Once that works, then you can integrate it directly from the lab machine to your EHR, whereby the reports will directly go to the EHR. You don't have to take a printout. You don't have to do anything. And then this automatic results will be generated at a faster pace, and the physician can see it in real time. And then the human errors are eliminated. Human errors means like wrong reports, wrong entry. Okay, so these will be eliminated, and you'll save a lot of time, because as soon as the results are out, physician from the wards can view the results in real time.
You've got another 5 minutes.
Okay, sure. Finishing. Again, radiological reports, same thing. You input, you get it. And if you have a PACS, you do away with all the X-ray films, because that again is a big burden to store them. Now, what does the technological solution help? Billing. As today, you go, as I open my EMR, suppose I see a patient, I wrote a prescription. In the prescription, the name of the drug is there, the price is there, and as soon as I save it, it goes directly to the pharmacy. Now, the pharmacy people, they just open it, bill it, kept things ready. By the time a patient reaches the pharmacy, everything is done. So it saves time. It handles this billing in the pharmacy, payments, invoices, insurance, and the billing will be accurate. Accurate how? Because that everything is in the software. It's been digitalized there. We don't have people who will, those with poor maths, again, they'll have problem. They use the, what you call, calculators and all that. They may miss the billing. And medical devices, you'll say, okay, what are the other technical solutions that we have? We may say that, no, we never have that. But digital BP monitoring. Now, mercury monitors are all out. The digital BPs are in, portable ECGs are in, glucose monitors. When I talk about glucose monitors, I mean if you can have this continuous, glucose monitoring devices where you place it in your arm, and with just your mobile, you just check it before you eat, and then you will have the insulin pump, which is there, inbuilt in you. Then you have thermal thermometers. Mercury thermometers now are out. We are using thermal thermometers. USG machines, CT, MRI, AI aided, they'll give you better diagnosis, and even in the lab machines. So what are the benefits? Faster diagnosis helps you give you more accurate results and improve patient care. And it'll be less cumbersome. I'm telling you, with all those other gadgets that we have, like we have monitors. You've all seen these monitors. What they do? You don't have to touch the patient. Everything is being done by the machines. You just have to read them. They give you the SpO2, the blood pressure, the pulse, the cardiac rhythms. And the best part that what we have now in Nazareth is the dozy bed. Some of the hospital of you here, you have the dozy bed. where you do not have to touch the patient. Below the bed, there's a sensor sheet, there's a monitor there, and there's central control console where the BP, the pulse, the SpO2, the all the vitals of the patient is being recorded, and you can just control it from your area. Same thing, it gives you faster diagnosis, less patient interaction. That means some patients, they get agitated when you, after 2, 3, or 4 hours, you go and check the pulse, the BP, SpO2, your RBS, this and that. They get frustrated. They get angry sometimes. You have that done. You don't have to even disturb the patient in their sleep. And this will improve the patient care. Now, what's the future? Future, Nazareth, now they are trying for the appointment and scheduling a software. That means you, from the comfort of your home, you put your appointments in the app, you can just come any day. Indoor, that is indoor electronic records. We have now completely digitalized in the outdoor. Indoor, it's half-half. So we are going to try to make it full. Telemedicine, we had started. Note takers, maybe in the future we may have again. And the benefits that in the telemedicine, it allows the doctors to have a video conferencing. See, even in the government sector, it's a very good thing. Because why? You don't have to ask the doctors to refer each and every patient to the civil hospital. By teleconferencing, you can advise them, give them the guidelines on how to go about treating the patient. Which right now the government has done is what, the drone technology of delivering medicine. That is going on now. I don't know whether it has stopped or not. I don't know. But I heard it has stopped for some time because of, some issue with the connectivity. Next thing, wearable. Wearable technology is coming soon. 17 September 2026, Modi was wearing what spec in the AI summit in Delhi? Any idea? Sarvan Kaze. Okay, that's the AI, operated specs. He can see, he can visualize everything. That is coming soon, even in medical. And I was very impressed when first Dr. Ngat brought his smartwatch a few years back. And he showed a smartwatch. I know it showed you about the pulse, the BP, how much steps he has taken that day. Well, we were at odd those days. But now this is coming. People are wearing now. So this will come soon in the medical field. And the other things which I told you, these things, robotics everywhere is going now, except of course in Northeast, or maybe in India, I don't know. In India they're doing, I think. So these are on the pipeline. So please be abreast with the technology. Thank you.
Thank you, Dr. Paul. Maybe we can have a couple of questions from the audience. No? Everybody is in a mood to go back home, especially the people who have come all the way from Guwahati and other places. Anything to add? No? Okay, with that we wrap up the final session for the day. On behalf of all the faculty and the resource persons, I would like to thank Nazareth for inviting us here. And special thanks to Dr. Pramod and Sister Norin for having us here. Thank you so much.
Thank you so much. So with that, we have come to the end of the program. Before we conclude, there are a few things, obviously. So first of all, let us felicitate our speakers. May I request Sister Norin to please felicitate. Sister. So may I request Devasi sir, we have you here. So Sister Norin, please felicitate Devasi sir. Yeah. Thank you, sir. I will also request Sister to felicitate Dr. Paul Lakha, sir. Sir, please. Can we have a group photo now with the chairpersons and the speaker along with Sister Noreen? Sir. Thank you so much. So we had I think, an immersive day. Lot of topics, lot of deliberation. I know some will definitely say that it's a mental fatigue. Too many points, can't take everything, can't absorb anything. But believe me, at least one point from each chapter or each session would be quite useful. And when you are going back to your organization, when you will see, you will definitely find that yes, we have heard something on that day. It will be definitely useful. We are looking forward to smaller hospitals to come forward, look at all these, come forward and be a part of the quality journey. Don't think that bigger hospitals are doing something different. They are not. Just that they have a build size bigger, so they have to work accordingly. But for you all, definitely you all can work. The organizations which are being represented by bigger organizations, I know you have good number of takeaways from here, and definitely it will enrich your experience. Before I go ahead with the formal valedictory, I will invite Dr. Babu Narayan, chairperson of the SSGO Wing Healthcare Division, Caho, to share his views and give an, I think, closer for the program. Sir.
I wouldn't take much time. I mean, like most of you have to fly, return to your places, which is far away given the terrain and the climate and other things. So when I was heading this 1,000-bedded hospital or Vijaya, somebody will be always coming and saying that, oh, Babu, you are so young. At 30 years, you are heading a 1,000-bedded hospital. Wow, it should be a very difficult task. But I always say that, it is not at all a matter. Who is the real hero is that the single practitioner who at the nook or corner somewhere there at the foothills or in the tribal area or wherever it may be, in the mountains, or because we have that Western Ghats, there he practices and treats with all his limitations, resources, whatnot. He doesn't have anything, but he treats. He is the hero, right? Not sitting in this thing office. You have your 20 to 30 securities. It doesn't make a matter because it is a system, right? It is a system that protects you. So why I am saying this important aspect is that small healthcare organization, because we are trying to build up the ecosystem in the small healthcare organization, make it so quality wise, make it the society should be confident about it by bringing processes in place, not person oriented, process oriented. But actually the next step is going one step further to the clinicians to make it more standardized, because they are the system who do the primary healthcare. Then it comes to the secondary small healthcare organization. Then it should come to the tertiary. Then only the system can be efficient for the society, for the government. That is one thing I just wanted to impress upon it. Second, I take this opportunity, of course, to congratulate and thank the Nazareth Hospital and its hospitality. The one name which comes to my mind again and again is Sister Noreen, because from the first day, because I do not know Sister Noreen, and first day Dr. Pramod was telling, no, Babu, it is not me. It is Sister Noreen, which is behind everything. And I know that with the kind of arrangements and everything, thank you, Sister Noreen, because the humility what it brings, because when I having the tea, she was giving me a puff. And I was telling that because I had this kind of experience when I was doing post my MBBS studying for my PG. I was in a congregation as a resident medical officer, 24/7. They will feed you good pay and you can prepare for your PG. That is what this, we go to this Kerala border, Tamil Nadu Kerala border. There are a lot of congregations and they have this hospitals or this missionary hospitals, and good pay, good food, and you got a lot of time to read and I'll be reading, putting my this thing, then cases will be coming, we'll be seeing to it. I mean, that is the humility, right? I am not the owner of the hospital, I am the medical superintendent. Okay, come and sir, Babu, do you want this? Babu, do you want this? That is a humility that every human being should have. That is what we have to learn and reflect upon. I mean, wearing a coat suit doesn't matter. It is the humans that we value. And in addition to it, Sister Sharon, Miss Molinsi Rane, please forgive me if I'm misspelling something. I don't have a tongue for it. Rikhit, Mr. Arun, Mr. Thomas, Dhanraj, these are quite okay. Mr. Vishnu, and of course, Dr. Pramod, who has been a very good friend and for successfully conducting this. And I will be running short if I'm not, and I will be in danger also if I'm not thanking Jidda. Because before coming to Northeast, I have to get his permission. Jidda, can you go to Shillong? Okay, Babu, you can go. I mean, and he said, because see, I met Jeet maybe around 2016 or something, NEMCAR, doing my first CPUH faculty. That was my first interaction. From them, he has been impressed with this kind of dedication and the kind of passion he brings into it. In spite of, I know, a lot of challenges and other things which we share equally, the passion. I mean, when you are having everything, having the passion is not the way. With lot of challenges, then you are going forward with the passion. That is an important thing to realize. That I always, he's my inspiration. It is not for just the words, it's an inspiration. Because what I believe is that, as Dr. Pramod was saying, is that it is not like in a resourceful setting, we can do everything. Doesn't matter. Everybody can do everything. If I have 100 crore rupees, I can do everything. But in a resource restricted setting, if we could bring in quality, if you could bring in some kind of passion, then that is the solution. What we provide, that is, we are Indians or far. Okay? It is not about the NHS system or the US system where you have, for a pregnancy, you will be charging 3 crores and you get very good thing. My sister was there. Pregnancy, preterm, everything. 8 crores was the bill. Of course, she paid only 60 lakhs. Everything came from the insurance. But think about it, 8 crores. Oh God, in my lifetime, I cannot even earn that money. So, but in India, for a 10,000 bucks, if you can do. So we should be proud of ourselves. And Meghalaya being the youngest, this thing, Madam was telling, 70% of the population, less than 35%. I think there is a lot of potential here wherein we can develop our system. And of course, all the things can happen here, robotics and other things. I believe that this kind of movement will take you further for, come together and develop a system, a quality, because we as a healthcare professional, everyone should believe that we can do it rather than thinking that only the resourceful people can do. Nothing like that, nothing like that. So this Jeevan program, it is so passionate to me because I wanted to prove that SHCOs can fare far better than the group of hospitals. Or I belong to a corporate hospital, but I always loved the time I worked in my Madras Medical College, my almost 12 years, my graduation, post-graduation. And that, if you ask me what gives you the most satisfaction, I would say that those days which I really worked in those government hospital with this limited resources, where I could see the smile with these people who doesn't have money, because that gives you soul satisfaction. That is one thing. So that is second thing. And thank you for being here. And I would say that 115 participants for Meghalaya. I was telling to my friend that it is equivalent to 350 participants in Chennai or something like that for total population. I mean, relatively speaking, this is a very good crowd. And what I really felt very, connected was that all the faculties, there they come and go in a rush. Here, they being an important person, of course, everybody is an administrator, everybody is an top echelon of whatever they are, hospital owners. They can just come in, attend to the session and go. No, they stayed together. They look forward to things, what interactions are happening. And these are the positive points I learned when I visit the Northeast. And of course, there is no words for the hospitality. Thank you very much for this opportunity. I think that this will create some kind of snowballing effect. And I think together we can build a lot. And I would take this platform to thank Caho, Dr. Agarwal and Dr. Lalu for giving an opportunity for taking this passion forward. Thank you very much. I don't want to keep you waiting. Thank you very much once again.
May I now request Sister Noreen to please say a few words.
I know all are mentally tired, wanting to go home soon. Once again, my special thanks to Caho and organizing this program, and all the speakers and all the chairpersons who have done a very good job. And I'm sure everyone has taken a message home to, in their own capacity, to build up something for the patients. Thank you very much. I also thank Dr. Pramod for doing a wonderful job during this. So thank you very much.
So before giving the vote of thanks, I will say that few things. First, CahoCon 2026 is near the corner. The April 10th, 11th, and 12th. It is in Chennai. Invite you all to be there and have a first-hand experience of more on quality, patient safety, infection control. On 10th of April, there are 33 pre-conference workshops which will be there. So in different setups, different organizations, and the main conference on 11th and 12th will be in the Chennai Trade Center in Chennai. Okay, so that I am assuring you the programs are going to be definitely learning materials. Kahuban, that only I was telling them. Yeah. So and if you want to be a part of this movement called Caho, please become a member. Attend the different programs. They are cost effective. You will learn the teeth and beats what you need. You, according to your needs, identify which actually training you would want. We are almost 78 plus trainings are going on, online, offline, hybrid. So depending on your needs, you can define, right? So thank you so much. And I am really very thankful to each one of you here. Definitely the faculty who have been here with us agreed to be a part, and they are here till now. It's really very thankful. They have to again go back. Coming early morning, again going back from Guwahati, that's not a joke. Coming from Dimapur, whole day traveling yesterday, then again going back now. So you can, this shows the commitment. Again from, yeah, as sir has rightly mentioned, the owners, the directors, they are there with us for the whole program. That's not a joke, because they have to leave back the authority to others and come and involve in this. That shows where do we stand. Each of you who have been there towards the end of the program, we were just talking. Many a time we see half of the crowd is gone by the end of the session. But here almost 99%, I will say, because few have to leave due to some emergencies. Most of you are still there. Thank you so much. And we'll not waste more time. We can have a quick group photograph, and then you can proceed for tea and move back to your houses. Those who are going to Guwahati or other distant places, have a safe journey home. And thank you so much. We'll be looking to more programs in future. Thank you. Thomas, can we have a group photograph? We'll have it there only, because can't get every one of you here. So we'll have it in that platform only. Huh? We'll have there. So, in seated position? No problem. From the back, if you want to be more eminent, why don't you come to the side?